Good morning, everyone. If you can have people settle down, we'll go ahead and get started. We will call the Public Health Committee public hearing for February 26, 2024 to order. And just a few things. In the first hour of the meeting, we will have some of our elected officials and members of the executive branch may be able to come and speak. And after that, we will alternate between the groups and the general public. So wanted to give you a heads up on that. We do have a pretty busy agenda. So for the question answers, if they're absolutely relevant, ask them. Otherwise, we will just keep moving pretty fast. And I'll have my esteemed co-chair make her opening remarks.
Thank you very much, Senator Anwar, and thank you everyone for joining us today. We have over 70 people signed up today. We do have a time limit. Everyone, including our elected officials, will have a time. As Senator Anwar said, we will have people ask questions, but keeping in mind that we want to make sure that we hear from all of you. It's great to be back in the public hearing process and to have the opportunity to hear from the public as we work together on the bills and as we work collaboratively as a committee. With that, I will turn it back to you, Senator Anwar.
Do our ranking members want to make any opening remarks or? All right, I see no, and we move to our first speaker. That is Senator Seminara. Welcome.
Good morning, co-chairs Anwar and Vehi, vice chairs Marks, Kushner, and Parker, and Senators Summers and Rep. Detria, and other distinguished members of the Public Health Committee. I am Senator Lisa Seminara, and I am here today to support HB 5197, the Social Work Licensure Compact. As ranking member of the Human Services, Children's, and Aging Committees, as well as a member of the Education Committee, I am keenly aware, and I'm sure that you are, that we are in amid of a workforce crisis. We are especially in need of social workers. By taking part in the compact, we can continue to address the ongoing need for more social workers in our state, making it easier, more desirable for Connecticut to be a state that these professionals can call home. I can remember 30 years ago when I moved here, I was a licensed clinical social worker practicing in New York State. I moved here and was not able to acquire job position because I had to sit and chair for the exam before I was able to accept any position here. So I'm hoping that you will all share in my desire to take this seriously. We are in desperate need of social workers, and I think we need to do this to simplify the process. I feel that this also allows for increased services being available to those out of state, meaning that if we are in this compact and there are a number of people in this compact, that we are going to have other professionals available and might be able to do it remotely. So I, again, just urge you to consider this and hope that you will take it forward by doing this and hopefully lowering. By the way, I put in a bill to address the licensure fee in general law this session, and I'm hoping that that is going to get addressed as well, so that by lowering the licensure fee and lowering the renewal fees for social workers, we would be increasing our availability for these professionals and overall service delivery to the mental health crisis. Thank you so much, and I can happily answer any questions that anybody might have.
Thank you so much for your testimony in under 3 minutes too. Thank you.
I'm efficient.
Good start. We hear you loud and clear. We thank you for recommending this bill as well, and that's why we wanted to hear this. And I know it's important to you and a lot of our social workers. So appreciate you.
Okay, thank you so much. Have a good day. I hope
Thank-
everybody is as quick as I am.
Yes, thank you. The next person on our list is Kathy Flaherty. This Kathy is supposed to be, you are there. Welcome.
Good morning, members of the Public Health Committee. My name is Kathy Flaherty, and I'm the Executive Director of Connecticut Legal Rights Project. I'm here to offer testimony on 3 bills, and you do have my written testimony, so I'll try to keep this as short and sweet as possible. In support of telehealth, telehealth is 5198. It has really expanded access to care for people who have access to the technology. It's made a difference in the ability to access care, especially during the worst parts of the pandemic. It is our hope that someday those rules will be made permanent, but we understand expanding the sunset date is what's being proposed right now. The other 2 bills I want to speak in support of are SB 180 and SB 182. And both of them really talk to the fact about insurance companies interfering in doctor-patient relationships and reducing access to recommended care. That is something I have experienced personally, both in terms of treatment for a psychiatric disorder where my doctor recommended brand name drugs because that was actually the only thing that worked. When I took a generic because they had changed manufacturers, very quickly within days, it was noticeable that it was not working. And the insurance, fortunately, I had the privilege of being able to pay the difference when I was at the pharmacy so I could get my prescription till I had to fight out an appeal with the insurance company. And because I'm a lawyer, I was able to fight that appeal successfully. It was probably one of the more sarcastic letters I've ever written because they required a prior authorization, which would have required me to go back in time and fail on other drugs before I could get the medication that my doctor recommended. And it's also experiencing in terms of dealing with long COVID. Neurologists have recommended treatment for me. And I had one insurance company where a year of appeals did not get approved. And if the burden was shifted to the insurance company rather than being placed on the doctor and the patient, I think we'd all be better off. Thank you.
Thank you so much. We appreciate your testimony. We hear you loud and clear. Seeing no questions or comments, we'll move to the next person on the list, which is Kristen Winters. Welcome. You press the button, the red button, the light, so that right in your front is a, I'll come. Yeah, there you go.
My name is Dr. Kristen Winters. I'm the Connecticut Podiatric Medical Association's president. I want to thank you all for having me speak today on Raised Bill 5196 and expanding the podiatric scope of practice. I am in favor of this bill. I currently have been in practice for the last 25 years in the state of Connecticut, servicing Enfield and South Windsor. We have gone through a committee review. The DPH has its report. I completed my surgical training here in St. Francis in 2000 in St. Francis Hospital, and currently am president of my practice, and we have 5 foot and ankle surgeons. The educational requirements for a doctor of podiatric medicine are 4 years of podiatric medical school training. 2 years of that are identical to osteopathic medicine. 3 years, we then do a podiatric surgical residency program and then begin the board certification process through the American Board of Foot and Ankle Surgeons. Historical perspective on this bill, it began in 2007. The surgical ankle law was put in place, excluding total ankle replacement and tibial pylon fracture repair. 16 years later, advances in training mandate an update in our bill. The scope of practice proposal was originally total ankle replacement, which is simply replacing an ankle joint that is arthritic, similar to a hip or a knee. 44 states now currently permit this, including the District of Columbia. Tibial pylon fracture repair was number 2. That is an ankle fracture repair involving a large surface of the ankle. 43 states now permit this in the country, including the District of Columbia. And foot amputations was omitted from the bill. We are asking it to be put back in because we feel it is an important portion of what we do. I'm going to spend a little time on that. We are currently limiting to the middle part of the foot in performing a foot amputation. Our current amputation law is a proven obstacle for us to deliver complete care for a patient. A patient will come into my office with an ulceration to the toe that will lead to a hallux amputation, which is the big toe, which will lead to another amputation and another amputation. And quite frankly, sometimes it's not until surgery to we're able to identify infection and to identify the level at that moment, then we're able to deliver the definitive treatment. So it is important to update this as well. In summary, patients will benefit from these updates. It will allow qualified physicians to be able to simply practice what they're trained to do with the appropriate certification, training, and credentialing by the hospitals. This will improve access to care and help the delivery of care, as well as just attract our residents to stay here. We train them. We want them to stay and practice in the state of Connecticut and help deliver this care to patients. Thank you.
Thank you so much for your testimony. We have a question from Representative Park.
Thank you, Mr. Chair. Thank you for being here. I have a question. Do you have any details about if there's data around the number of Medicaid patients that are not able to access services right now? That's something that came up a lot in the testimony. Is that a real problem or not? Is there a lack of access from your perspective? And can you help us quantify that?
Yeah, we can get that information for you. I don't have that with me, but I certainly can provide that for you to get more solidified on that. Of course.
All right. Thank you. Thank you,
You're
Mr.
welcome.
Chair.
Representative Claridis Teacher.
Thank you, Mr. Chair. Thank you for being here today. One question I have is, can you give me a number to be a certified podiatric surgeon? How many foot and ankle surgeries do you need to perform as part of your training or in your residencies compared to an orthopedic surgeon, foot and ankle?
That's a good question as well, and I can get the answer for you for that as well. I'm not certain if there's a number that you have to have, but on either side, on both the orthopedic side and the podiatric side, but I can get that information for you as well.
Thank you. Thank
You're
you for
welcome.
being here.
You're
Thank you,
welcome.
Mr. Chair.
I see online Senator Summers has a question or comment.
Of course.
Yes, good morning. I was wondering if you could tell me, I'm not sure if you know this or not, so I'm looking to see if we can get to the bottom of this. Do you know if every orthopedic surgeon who does ankle replacements has training to do this during the residency specifically?
I know that the orthopods start with general training first, and then they go into foot and ankle if they so choose. Whereas the foot and ankle person does that from day one. I'd be better served to have one of the orthopods answer that question for you, as I'm not certain.
Okay, but it is the podiatrist, basically spends their time doing that specifically on the ankle replacements. I'm just trying to figure out, and I will ask an orthopedic, like how much time during the residency are they done doing training in that particular procedure? Thank you.
You're welcome. And as I said, from day one, podiatric foot and ankle surgeons do just that. So we're doing this training from day one. That's all we're doing through the entire residency program and through the entire educational process, to be honest with you.
Thank you.
You're welcome.
Rep. Dauphine.
Thank you, Mr. Chair, and thank you for being here today. My question is, are you aware of any specific issues or problems that have happened in the other 43 states that now permit this expansion, the scope expansion with podiatrists?
I'm not aware of any issues, and that brings up a good point. We're the outlier here. As I indicated, most of the states in the country allow this. They've gone through this process, and I'm not aware of specific issues that would have halted that process. Which led them to pass the bill. So we are the outlier in that, as I've indicated, the number of states that have already been down this road. And we certainly, it's time for us to catch up to where we need to be and keep in line with our training.
Thank you.
You're welcome.
Just as a reminder for individuals who are here to testify online, that you will get invitation to come to the main panel. Please accept that, otherwise you will not be able to testify. With that, Representative D'Amico.
Thank you, Mr. Chair. Thank you, Doctor, for being here and testifying today. So I'm a little behind on this whole subject. So from what I understand, you had a scope of practice review
We did,
with the
yes.
Department of Public Health.
That's correct.
And again, I might have missed it in your testimony. What was the result of that review?
There wasn't a huge consensus. We had the panel was serviced by 4 orthopedic surgeons and 4 podiatric surgeons, and we did not come to a consensus in the time we spent together. We were in alignment with the amputations that were admitted, but we could not come to see eye to eye on the importance of passing this bill.
Okay. So I guess the other thing, I don't see any testimony here from the Department of Public Health. I know that's not your issue, but that's a problem for me.
Yeah.
But would you care to comment on that?
Yeah, I have it in my briefcase. I have the full report. And if you need that, we can get that for you. That has been completed, was submitted last week to us.
Okay, I
Yeah.
wouldn't mind taking a look at that.
Of course.
So,
Of course.
thank you.
Yeah,
Thank
you're
you, Mr.
welcome.
Chair.
Thank you, Dr. Winters. I wanted to ask you a couple of questions.
Yes,
too.
sir.
I was reading the testimonies, and one of the testimonies that whoever wrote that will come later and speak. They're talking about the peer review process in podiatry surgery.
Say that again. I'm
Yeah,
sorry.
sorry. So the peer review process at the state level for podiatry surgery, what are the systems that are available to address that?
I'm sorry, I don't understand your specific question.
If there are complications,
Yeah.
How do you keep track of them in the state of Connecticut?
That's a good question. Peter Bloom is following me. I think he'd be better serviced to answer that question for you. He's due up next, but that's a good question. I'm not familiar with the specifics that I could give you.
Sure. And how would you reflect on somebody suggesting, and actually there's a lot of research and data showing as well, that the complication rate for the procedures that the podiatrists are performing is higher?
I'm glad you brought that up, Senator Anwar. We did look at all the studies that were reported and are part of the DPH report. There is significant bias in those studies. The APMA will be represented by Dr. Christina, who will get into that for you. But those studies are significantly biased in the report. I have studies to offer you that shows a very equal rate of postoperative complication. So the APMA will address that directly with you.
Okay, thank you so much.
You're welcome.
And we do have 2 more questions.
Sure.
I can see Senator Gordon has a question, and then Representative Claire DeStitra second time around.
Thank you, Mr. Chairman. I'll try to be brief. Dr. Winters, it's nice to see you. Thank you for testifying. I just want to make certain I'm clear about what it is that you're asking. Are there's specific procedures or surgeries that you're asking for to be able to do that podiatrists are already trained and I guess board certified to do? Is that correct?
Yes.
And one of the things I just wanted to ask a quick question about is about one of them is about ankle replacement,
Mhm.
where people have arthritis. Is that one of the surgeries and
That
procedures?
is, you're correct.
And I certainly heard from a number of podiatrists, their perspective. I've also heard from orthopedic surgeons, their perspective as well. And one of the things I just wanted to make certain I'm clear about is dealing with ankle replacement surgery. That's something that podiatrists in their training, they're trained to do, or is that something they need to go on and do something specialty training, similar to if an orthopedic surgeon just wants to focus on ankles, then he or she might do a fellowship or extended training?
This is training that we are getting now nationally. So these residents are being trained to replace ankles, coming back to the state of Connecticut, getting board certified, and simply can't do it here because the law prohibits it. So these are procedures that we can do and we're trained to do. We're coming back, and many of these people live in Connecticut. And these podiatric residents can't come back here because they can't do what they're trained to do and spent the hard, laborious time to do. And they simply can't do it because the law prohibits it. So this is training that is being done across the country for our foot and ankle surgeons.
Thank you, Mr. Chairman.
Thank you so much. I think many of the other questions were answered already, so we appreciate you being here. Thank you for your help.
Thank you, Senator Auer, and everyone in the committee. Thank you so much.
Thank you. Next is Senator Looney. Welcome, Senator Looney.
Good morning, Senator Anwar and Representative McCarthy, Vahey, and members of the Public Health Committee. I'm Martin Looney, State Senator of the 11th District, representing parts of New Haven and Hamden, and would like to comment on two bills on today's agenda. First is Senate Bill 180, an act concerning adverse determination and utilization reviews, and Senate Bill 182, an act prohibiting certain health carriers from requiring step therapy for prescription drugs used to treat a mental or behavioral health condition or chronic disabling or life-threatening condition. Senate Bill 180 would require health carriers to bear the burden of proof in appeals of healthcare denials and redefine clinical peer to ensure that the peer is actually a specialist in the same field as the treating physician. And third, require health carriers to provide certain clinical peers with authority to reverse health insurance coverage denials. The core of this bill is the belief that the treating physician should be in charge of the care of the patient, and that it should not be an uphill struggle to get approvals and to have the when there are denials of care, it needs to be a peer-to-peer discussion thereafter in order to be equitable. And the legislation would provide a number of innovative protections for patients. It would create a presumption that treatment that's ordered by a physician is medically necessary treatment. And what this would mean is that the burden would be on the insurer to prove why it is not if the physician believes that it is. It would allow physicians to practice medicine, limit the ability of the health insurers to interfere with patient treatment by making medical decisions which they're not qualified to make. So normally, legally, in most cases, the burden of proof is placed on the party who has the relevant information and knowledge. And in this case, it's really not that way. Senate Bill 180 would bring appeals of adverse determinations in line with the way the law handles most of these kinds of disputes. So there are under the current framework, the burden of proof in these situations is on the patient and the provider. And in fact, prior to Public Act 12-102, the patient and provider didn't even have the right to access the record that the insurer used to make these decisions. So it's been an uphill battle even to get to the point where we are now. And also Senate Bill 180 would create a more stringent definition of clinical peer in the appeal process, and would require that the peer that is provided for the peer-to-peer conference have the authority also to overturn the adverse determination, because the process becomes too drawn out and bureaucratic. Senate Bill 182 would offer relief for patients and providers who've been forced to use suboptimal prescription medication by health insurance companies, use of step therapy, the so-called fail first policies. My office has been contacted in recent years by patients with disabling diseases and physicians who treat these patients, and it's a source of extraordinary frustration for both patients and their physicians when the patients are unable to access appropriate medication due to insurers' fail first requirements. In fact, there was an article last year in the Wall Street Journal by a columnist for the Wall Street Journal, who was the mother of a child who had juvenile rheumatoid arthritis, and documented what her son suffered when the treatment that the child's physician knew would help him was not allowed to be given for more than 2 months, and the child was bedridden and crippled most of that time. And when he was finally able to access the treatment that his physician had recommended in the first place, was back mobile and moving around comfortably within a short time after that. These are the kind of things that happen in step therapy. So while there may be
Senator, your time is up.
while
Your
there may
time
be
is complete.
uses for step therapy, too often it's implemented in a manner that interferes with patient care. Thank you.
Thank you so much. Just 2 seconds over, right? Senator Looney, can I clarify this a little bit? I think in simplistic terms, what you're saying for the clinical peer is that if there's a person who has a cancer and a cancer oncologist is making a decision that the person be on the treatment, and if the insurance company is saying no to that, they need to have a cancer specialist who is dealing with that age group, that's a specific patient population with that experience should be the one to say no to that, right?
That's right. Absolutely.
Okay, good. Yes, Senator Gordon. I set that question up for you.
You did, actually. You stole my thunder, but that's okay. Thank you, Mr. Chairman. Senator Looney, it's always a pleasure to see you. And I just want to take this moment in a bipartisan way to thank you for your leadership on these issues. I know I was proud to work with you and members of your caucus last year on a prior authorization bill, and I welcome the opportunity on these bills as well. I think the points you raise are extremely important. And as our chairman just said, I can speak from personal experience as a cancer doctor almost every day having to justify FDA-approved treatments that I know are absolutely the standard of care. In fact, as an example, to follow your testimony, last week I needed to get a patient lung cancer chemotherapy approved. And they put a peer on the line who's a rheumatologist who admitted that she knows not a single thing about how to treat a patient with lung cancer, but could take care of rheumatology side effects of the treatment. So I think putting the burden of proof on the insurance companies to tell doctors and other healthcare professionals why what they're doing shouldn't be approved. But if we who are trained and are taking care of people in person feel this is the best way to treat their individual cancer, mental health disorder, any type of disease, then we should be the ones that should prevail. And in my understanding, and I'll ask you this question, is my understanding of all these 2 bills is this is really getting to making certain we're providing and continue to provide the very best of care for the people of Connecticut, not just us doctors providing that care and other health professionals, but my understanding is that's the crux of all of this is we have wonderful health care. We just need to make certain it's more accessible in a timely manner, and that we have less burdens for people to get the care they need.
Well, that's exactly what it is, Senator, and I'm pleased for your expert testimony on this from your own experience. So it seems like the peer that was provided to discuss the case with you was only a peer in the sense that it was also an MD, but in no other way an actual peer.
Seeing no other questions, thank you, Senator Looney, for your leadership and your help with this work. Thank you. This will save lives.
Thank you so much, Mr. Chairman, Madam Chair, and members of the committee. This committee does vital work on behalf of the General Assembly every single year, and it's an honor to appear before you once again. Thank you so much.
Thank you. And moving to the next person on our list is, if you see Senator Cohen come here, please let me know, because I know she's in the Transportation Committee right now. So she's going to probably pop in. Next is Peter Bloom. Peter Bloom is on remote, but has not necessarily entered the area. So we have Dr. Amanda Fantry. Dr. Fantry, you're on. You can turn your camera and unmute yourself. Go ahead.
You hear me?
Yes, we can.
Okay, great. Good morning. Thank you all for having me and for the opportunity to talk this morning. So I am an orthopedic surgeon in Hartford, Connecticut. I am predominantly at St. Francis Hospital. I am trained both in 2 fellowships, one in trauma surgery and one in foot and ankle surgery. I completed my trauma surgery fellowship in 2017 and my foot and ankle surgery fellowship in 2018. Since that time, I am in private practice and I work both at St. Francis Hospital and at Manchester. I take level 1 trauma call at St. Francis about 85 days a year. And last year I took 25 additional days of call at Manchester. So I am well-versed in all orthopedic injuries, both traumatic and post-traumatic in nature, and I take care of a myriad of problems, both across the trauma world and the foot and ankle world, which often collide as people experience foot and ankle trauma. My practice is made up about 15% Medicaid, and as kind of a more personal anecdote, you know, my dad is a truck driver. My mom did not finish high school. I am very well versed in taking care of economically disadvantaged members of society. And I certainly feel like being economically disadvantaged should not mean that you get worse healthcare. 15% of my practice is currently, as I said, Medicaid, and I take care of all problems, including ankle replacements, ankle fusions, post-traumatic arthritis, pilon fractures, across the board. And I know there's been a lot of testimony previously about access to care. And as one of the providers here in Central Connecticut, I feel like there is minimal or no limitation in access to care across the orthopedic surgeons, but particularly not in my office.
Could you just remind us what is your position and which bill you're speaking of, please?
Oh, sure. Sorry, I'm in the middle of my clinic day, so I need to just open the bill. But I am speaking on behalf of the podiatry bill. Oh gosh, the same one that Dr. Winters was just speaking on.
5196.
Yes, please. Sorry, 5196. I just opened that.
Okay.
And what was the first question? My position?
Yes, please.
I am an MD trained in orthopedic surgery.
No, what I mean is, you're supporting the bill or you're not
Oh,
supporting?
no, I am not supporting the bill.
Okay, all right. Thank you. Thanks for that clarification. Can I clarify a couple of more things?
Of course.
Right now, we have received calls and letters stating that the patients who have Medicaid are not getting these procedures done. Since orthopedic surgeons are the only ones doing these procedures, is there a suggestion that anybody with Medicaid is not getting any of these procedures done in the state of Connecticut? Could you help clarify that?
Of course. No, that's not the case at all. So high volume, I actually tried to look up this information last night. There are about 10,000 ankle replacements done per year, which is a very small number that pales in comparison to the number of like knee replacements or hip replacements that are being done per year by the hundreds of thousands. Of the foot and ankle surgeons in town, I would say a high volume ankle surgeon probably does about 10 ankle replacements a year. I did 12 last year and I went back and looked at my numbers, and 2 of those were on Medicaid patients. And I think it is like similar across, although I can't speak for every orthopedic surgeon. So that is certainly not the case. As far as pilon fractures go, pilon fractures are a traumatic injury. And so they typically come in through the ER and are managed by a combination of trauma providers and foot and ankle providers. My trauma colleagues at St. Francis often send me their pilon fractures, and I'm the only foot and ankle orthopedic surgeon at St. Francis. But between the 3 of us, we take care of all of them, and I manage all of their post-traumatic problems. If they do develop arthritis or need an ankle fusion or ankle replacement down the road, I manage all of those folks, and there has been no issue with access to care to my office.
Thank you so much. Thank you for clarifying that, and we appreciate you coming in to speak. Oh, wait, Representative Dauphiny has a question.
Chair, thank you. Oh, is she there?
Okay, we'll see you next time.
Hi, thank you for being here today. I just have a question. You're opposed to this bill, and Dr. Winters was here earlier and said that there has been no issues that she's aware of across the other 43 states. Can you just say why you're particularly opposed to expanding their scope of practice?
Yeah, I think that there are very specific nuances to both ankle replacement and pilon fracture surgery. So pilon fracture surgery involves like the actual joint of your ankle, and is very challenging surgery to perform, right? Having been both trained in trauma and foot and ankle surgery, I think that's a very specific niche, well qualified to do this. And for ankle replacements, again, if people are really only doing them 10 times a year as high volume ankle replacement surgeons in Connecticut, maybe, upwards of 20 times a year, there's not a shortage of people able to do these surgeries and do them well. We, in orthopedic surgery, we train in replacement surgery our entire residency, right? We do knee replacements, we do hip replacements, and then we do training in ankle replacements on our foot and ankle rotations. And so I think we are well trained in the biomechanics of joint replacement and how joint replacements work, the physiology, the pathology, and things that would just make us well qualified to do these as a very niche part of a practice. No one is doing an ankle replacement every day or even every week, right? These are rare things. Pilon fractures are not super common, but we take care of broken bones from your hand to your feet throughout our entire training, which makes you very well versed in fracture care, periarticular injuries, or injuries around joints, that I think really benefit us when treating these complex surgeries that can have devastating complications that can result in things like amputation.
Thank you for that. And are you aware of any particular issues that have happened in the 43 states that are now performing that with the podiatrists?
I don't have a particular study to present today. I know that Dr. Arano does, but I don't have a particular study demonstrating complications. So I can't speak to that exactly to say that here's the data.
Thank you.
Mm-hmm.
Thank you so much for your testimony. We appreciate you being here. And with that, we have Senator Cohen. Welcome.
Going to do something really quickly in anticipation. Good morning, distinguished members of the Public Health Committee. Thank you so much for being flexible with me. I am going to invite Dr. Moore to come up and sit next to me. But I do just want to say good morning, Senator Anwar, Representative McCarthy-Vahey, distinguished ranking members, vice chairs, and committee members. I am no stranger to this committee on this particular topic. As you may recall, we worked hard last session to pass an emergency department boarding and overcrowding working group. Dr. Moore is heading up that working group, and the bill before us today, SB 181, I'd like to testify in favor of. Let the record show I have submitted written testimony, and now I'd love, with the committee's indulgence, to yield my time to Dr. Moore.
Thank you.
Thank you so much, Senator Cohen. To Dr. Senator Anwar, Representative McCarthy-Vahey, Ranking Members Summers and Clarides-Dietra, and all of the members of the Public Health Committee. Nearly a year ago to the day, I sat here giving testimony to establish a work group on emergency department boarding and crowding. I'm here today to thank you for your confidence in establishing this working group and to speak in support of SB 181 so that we can continue our work. I'm an emergency physician and full professor at Yale, and have worked clinically at Yale New Haven Hospital for the last 23 years. I'm now co-chair of the Connecticut Emergency Department Boarding and Crowding Work Group. However, my comments today are solely my own and not meant to represent any larger entity. I want to assure you that the trust you gave us in establishing the work group through PA 2397 is appreciated, and we have been meeting diligently. It is an excellent and diverse group. If you have not had the chance, I would urge you to read the interim report from last month. I hope that in another year, I will be here again testifying for actual solutions. However, I'm here today to ask you to support a bill that will get us data and to ask that the data be publicly available. I can tell you from personal experience and from communications with colleagues around the state that anecdotally things are worse than they were 1 year ago. However, despite working hard on this with a large group with experienced people for more than 6 months, I cannot show you state level data to support this. Yes, we know ERs are crowded, but we do not know the details or the trajectories, which makes it hard to know where we're going and what effect any interventions may have. This is why it is such a crucial first step. I want to encourage you to understand and to use the word boarding. Boarding is when a decision has been made to admit a patient, but they remain in the emergency department for many hours or even days. Boarding is the main cause of crowding. It is unpleasant and unsafe for patients who experience it and causes conditions that make it difficult to care for them or other patients in the ER. We need to measure how much boarding is occurring. You may hear that getting this data is difficult. While putting it in the right format, at least at first, will take some effort. Most, if not all of what we need should be readily available in the electronic health record, particularly once the format is set. Periodic exports of de-identified data should not be onerous and are very feasible. You may hear that it would scare the public to make this data available. The essence of public health and the answer to a problem is not to sweep it under the rug, but to trust that with appropriate attention and scrutiny, we can all together work to solve it. Make no mistake, this is a public health crisis. The emergency department increasingly represents the place where all manner of health and social issues are addressed. It is highly likely that you or one of your immediate family members will end up in one of Connecticut's 30 emergency departments in the next year. We are doing our best, but need help to understand, shed light, and solve this crisis so that we can safely and effectively care for the citizens of Connecticut. Thank you for your support of SB 181.
Thank you, Dr. Moore. We have a few questions, I'm sure, and thank you for the opportunity to hear your testimony, but also the work that you've been doing. Can I clarify something, and it's just for the general public's interest? When there are a lot of people in the emergency room, it is because of a supply-demand issue. That's the first thing that comes to the mind. Can you help us break that down a little bit?
Sure. I mean, a lot of people think crowding is because there's lots of people coming in, which is true, but the number of people coming in has been very steady, and we're equipped to deal with that. The problem is when we make the decision that someone needs to be admitted to the hospital or to get psychiatric care or to go to a rehab facility, and we cannot get them out of the emergency department. We have a 60-bed emergency department at Yale. We're often boarding 30 to 50 patients routinely, sometimes over 80. So when that happens, we have no space to take care of anyone. So we're really trying to focus on boarding, which is, again, trying to find ways to make sure that we have the space. And you're right, it is supply demand. There's a lot of demand for hospital space, for rehab space, for psychiatric treatment space. But the appropriate place for those people is not in the emergency department. It's not the best place to care for them, and we need to figure out how to measure that and address it.
So if let's say there was somebody from a hospital executive in this room, what they would say is that, look, we are trying to hire more people. We don't have enough personnel. There's a crisis of healthcare workers. We cannot get enough ambulances. The ambulance services are crumbling because the payments and so on and so forth. So we can't get the patients discharged. We cannot get them to a rehab facility. How do we increase the throughput? And that's part of the reason that it's impacting the entire system.
There's an excellent New England Journal article called "The Canary in the Coal Mine," and it's about emergency department boarding and crowding, and we are that. I mean, the healthcare system needs help. We do hope to propose solutions in the year to come. Prior authorization is one. I've heard some other people talking about that. Connecticut could go much further in that. There are issues around capacity, particularly in behavioral health. And we do intend to present solutions to that, but we need the hospital administrators and the public to understand that it is a quality issue in and of itself to have patients that should be admitted or placed elsewhere in the hallways in our emergency departments. And we need to identify that, recognize it, measure it, and address it.
I can tell you the constituents that we are dealing with, everybody's complaining about this issue being a very big problem. I understand that your ask from the work so far that group has done is to start to measure this. And that's all you're asking.
This session, yes. Again, we would like to come back with solutions. We're not just trying to complain and say this is, and we know crowding is a problem, but we need to really look at the details of it. Like, where is it happening around the state? Which areas? Is it behavioral health? Is it pediatrics? Is it rehab? You know, is it just general medical patients? And how much is it happening? And we need to measure that so that when we make efforts to address it, are we actually making an impact?
Good, thank you. And Representative Claire Dietrich has a question. Sorry, Representative Kristen McCarthy-Vahey and Senator.
Thank you so much, Dr. Moore and Senator Cohen, both of you, for your leadership on this issue and your tireless work. Specific to the data that you're interested in collecting and learning more about, can you give us an example or two that is specific and that would help us understand exactly what you are hoping to extract from those electronic health records and how they would be de-identified?
Well, first of all, any data we would use would be de-identified, and that's easy to do. The main metric we're looking at would be the percentage of patients who are ultimately admitted who board in the emergency department more than 4 hours. That's an arbitrary threshold, but it's very measurable. You know, the data varies around the state. I've seen numbers from sometimes 30 to over 70 or 80%. And these are patients who need to be admitted, but they aren't getting the bed. So we need to know how often that's happening. That would be the core measure that we'd like to look at. Now you have to look at some other things to really understand that, the overall length of stay, how much time is spent in observation, where the patients are going. So there are some other details, but that would be the core measure. How often, what percentage of admitted patients are staying in the department more than 4 hours?
Thank you very much for that. Thanks, Senator.
Well, take Senator Gordon first and then Representative Parker.
Thank you, Mr. Chairman. Dr. Moore, it's nice to see you. I certainly know this issue very well, even though I'm not an emergency room physician. I spend a lot of time in emergency rooms when my patients get admitted, and that seems to be where they are hanging out more than 4 hours. Sometimes you can be talking days, unfortunately. And my understanding is, and I just want to make certain this is clarified, this is not an issue of the quality of care being provided in emergency rooms, which I know is provided very well at top quality, or the reasons patients show up in the emergency room. Because if somebody needs to come to the emergency room, they need to go to the emergency room. And you guys have open doors, all the emergency rooms all throughout. But the crux of this really is when the decision is made in the emergency room with the admitting team that if someone needs inpatient care, either they don't have a bed available, or there isn't enough staffing in the hospital for any reason, or the patient is in a community hospital and the type of care they need can't be done there, and they need to be transferred to a tertiary care center that has higher level of care, for example, high level ICU type care, and those hospitals are full. That really seems to be the crux of the issue. Am I correct that getting the patient from the emergency room into wherever they need to be in that hospital or to another hospital? And sometimes you're looking at hospitals in other states. And I've transferred patients to other states, even outside of New England, that have had beds for the care patients have need. But is that really the crux of the issue, is because patients can't then get to the next step? That's really the rate limiting step?
That's exactly it. It's boarding. As far as quality, I would say that boarding is both what we call an outcome measure and a process measure. It's bad for the patients themselves. If your mother was in the emergency department waiting 24 hours for an inpatient bed in a hallway, you don't want that. She doesn't want that. It's also a process measure in the sense that it affects our ability to care for other patients who come into the emergency department. Yes, we will always prioritize the acute trauma, the myocardial infarction, but it's hard, and it's hard on the staff when there's 30 admitted patients that the nursing staff have to attend to, and I'm often caring for 15 admitted patients in addition to the incoming patients. And I get calls about them all the time and texts, and I'm trying to attend to other people who have acute issues. So it's both an outcome and a process quality measure.
Thank you, Mr. Chairman.
Thank you, Rep. Parker.
Thank you, Mr. Chair. Thank you, Senator. Thanks, Dr. Moore. Your leadership and passion for this is really moving and noticeable and clearly making an impact. So I'm grateful for that and the chance to talk to you about it. Couple of questions. First, can you speak a bit about the history of this issue? I think that this is a similar title to a bill this committee's heard over a decade ago. Can you share a bit of that information with people?
In 2007, there was an act concerning emergency department crowding, which is essentially the same name as this bill. I was working in Connecticut at the time. I will tell you, it was nowhere near as bad as it is now. However, if you read the bill, it was a very comprehensive bill. Greg Shanghold, who will testify later, was involved in that committee. And it did involve measurement. It was actually supported by everybody to try to measure the issue. However, there were so many other parts of the bill, and they were trying to restrict inflow through fines, and there was a lot of complications. And basically, the bill never went anywhere. So now we're 17 years later, and we still don't really know the data of what's going on. Yes, we know it's crowded, but we've really not made progress on that. So, you know, there was some criticism and opposition to this bill that it's piecemeal. I would say it's not piecemeal, it's stepwise. We need to first take the step to get the data and then come to you with solutions that we can then measure and see the impact of.
Thank you for sharing that. My second question is about the process of collecting this data. So you referenced the 4-hour metric as what you think would be sort of a place to zoom in on. And it sounds like you've referenced that you actually have data around that metric at maybe your hospital and others. My understanding is there's about 30 EDs across the state. And can you speak about if this is being collected in some of those, maybe work you've done at your ED to collect this, and your sense of how it almost sounds like if you know it in some places, it should be an easy enough lift to get it and share it. But can you speak a bit about the details of what getting that looks like from your perspective?
Sure. And certainly at the large systems, I mean, they do track this data. Now you have to format it. We have an IRB through through Yale, just approved to look at pilot data from all of our systems. We're working with Middlesex, Meriden. There's some other hospitals in our group that are participating in this. And in fact, I have a data meeting in 2 days with our key data person. But we have a lot of this stuff on our dashboards. It's just a question of taking it and formatting it, de-identifying it. It's not, I mean, yes, it takes a little bit of work, but it's very much in the wheelhouse of what emergency departments and hospitals are doing already. The electronic health record, that's the benefit of it. We're so much further than we were in 2007. It's really not that hard to get this data, to de-identify it, to collate it and put it together so we understand the state level issue, because this is really beyond what's happening at individual hospitals. That's why I'm here in front of you today.
Sure. And to be clear, is that work that's going to be added to you as an ED provider, or is that more at an administrative level? I think the last thing we'd want to do is to overburden.
Yeah, it's certainly, it's not the individual providers that would be doing it. It's system level stuff. People, I mean, these systems have data people who do this stuff. And I'm sorry, it's a little bit more work, but it's important.
One more question, if that's all right, Mr. Chair. I'm going to look at you for a yes or no. I'm just going to keep going. Great. My question is about the national process around coming up with a metric and trying to solve this problem. I think you're aware of and can help us understand a little bit about what's going on, maybe specifically through CMS. Can you speak to your sense of if Connecticut takes this step, how does that align or misalign or get ahead of what's going on at a federal level with this problem that you're trying to solve here in Connecticut?
So CMS actually went into a contract with CORE, Center for Outcomes Research Evaluation, which is part of the Yale healthcare system. Rebecca Heckman, who is on our work group and a colleague of mine, I worked with her last night until 1 a.m. She was a key member of that. They put that out for public comment. Public comment closed last week. She told me they had an unprecedented number of public comments. She doesn't know how she's going to deal with them all. It's coming down the pike from the federal level, but it's very much aligned. The 4-hour boarding metric that we're talking about, it's the same thing. So this is probably coming, and to get ahead of it, there's no reason why Connecticut shouldn't be getting ahead of it. It doesn't misalign at all with CMS. It's completely aligned. And in fact, we have the people who are working on it at the national level in our working group. She's in the quality measures subgroup of our group.
Thank you. Thank you for all the time. Thanks for your work.
Thank you. Rep. Supkis.
Thank you, Mr. Chair. Representative Parker basically asked all my questions. So I don't think anyone wants to sit in an emergency room. My neighbor's mother literally 2 days ago was there for over 8 hours sitting in a bed, and she's 85. So, I mean, we all understand it completely. I guess, so if you have all this information already, and I would think you have Yale's, because that's where you are, have you implemented any of these things at Yale to help to progress or stop the waits and move forward?
I have no doubt that, you know, the hospital doesn't want this, and that we're trying everything we can to do it. It is somewhat beyond our control, which is why we need solutions that are beyond any individual hospital. And that's what we hope to present to you a year from now when our working group presents, you know, what we'd like to solve.
Understood, because we would want it at every hospital. We would want the wait time down.
Yep.
But understanding you're from Yale, have you implemented any of these things that you know by the data you have and what would work? Have you implemented that and seen any progress at Yale or not?
I mean, we have difficulties, challenges with staffing. Prior authorization is a big issue we've talked about. Many of these things are beyond the control of, again, an individual hospital. So I'm not an administrator. I'm not vice president. I'm an emergency physician. So I cannot implement these things myself. I can tell you that I know people are interested in it, but honestly, I'm not sure it's as much of a priority as some things are.
So basically what you're saying is you want the administration on board.
Yes.
At all. That's what you're telling us, right?
I mean, of course I do.
Right.
I want to work together with the administration. I want to work with DPH. I want to work with CHA.
Yeah.
I want to find solutions to this.
And just one more question. and I know nothing about, I worked in a hospital, but not in the ER. I give y'all a lot of credit because you don't know what you're getting at any minute. But the data that you want from all the hospitals, how much time and I would serve on another committee and they wanted data and it was hundreds of hours and it was terrible. So is this a flick of a button that you can get this data? Is it?
It's somewhere
people-
between that. I think it's on the order of hours for a system. I mean, I'm meeting with someone today. I think once you get it set up, hospitals can set up basically what they call dashboards with the electronic health record. And so they pull the data they want and then they push a button. So it takes a little bit of work, but it's not on the order of hundreds of hours. This is data that, in my experience and opinion, most hospitals have. They just have to take the time to format it and put it in a way that we can export it.
Okay, and my last question, and I'm not looking at the chairs like Representative Parker. Why do you think that people won't give this information? I'm curious as to, if you talk to the administration at Yale or at other hospitals, I would think everybody is concerned about quality of care, people sitting in ERs, all of those things. Is there a problem with getting that information? Is that?
Well, each healthcare
staffing?
system has their own information, but I mean, if I call up Hartford today and ask for that information, they're not going to just give it to me. They have it internally. I'm sure they're working on it. I'm sure they understand it, but we do not have a state level viewpoint of what's going on the hospitals, and the hospitals, they just don't voluntarily, share this. It is a little bit of work, but it needs a little bit of a push at the state level, which is why I'm here.
And CHA doesn't have any of that information.
It's unclear, to be honest. We are trying to work with CHA. They have some data, but I've asked them. I've asked DPH over the last 6 months, and I mean, we continue to want to work with them, and they do have some data, but they have not been able to provide this to our work group.
Did DPH give you the information you wanted?
Honestly, I mean, again, DPH, I've asked them, we are trying to work with them. They have a new data person, but they either do not have or have not been able to provide the data since we started working on this.
Thank you. Thank you.
Thank you. Again, just to put things in perspective, this is a quality issue and care issue for the individuals, but there's a safety part. Can you speak to that? It's a matter of life and death when these things are happening. I think we need to touch on that too.
Yeah, I mean, again, if somebody comes in with a trauma, we're going to drop everything and go in there and take care of them. Same thing with stroke and MI. There will be other people that will testify. And if you read the testimony that has been submitted, I can't tell you how many quality issues we've had with patients that are boarding in the hallway. I mean, elderly people with gastrointestinal bleeding who are vomiting in the hallway and need monitored bed, people that get lost. It's hard to, there are so many experiences, and I would just encourage you to read the testimony of people, because yes, it's a quality and safety issue. It's again, an outcome issue. It's bad for the patients, and it's also bad for our ability to care for them. So I don't want to discourage anyone from coming to the emergency department. If you need it, we will drop everything and do what we can to take care of the sickest patients. But it's the ones that are, kind of on the borderline, they're about to be admitted, and it's very, very hard to take care of everybody when there's so much boarding in the department.
I'll just add one more comment that the data is useful. The reason I say data is useful is about a few years ago, we saw that there were children who were with behavioral health challenges that were in the emergency room for 5-6 days across our state. And then we realized that there were not enough beds. And this entire body came together. We have started to look at this comprehensively, that the state can do better. And perhaps when we have the data, we'll find out if there are weaknesses in the number of beds that we have for various illnesses, very specific issues. We may be able to address that comprehensively. So it's very helpful. So thank you so much for your testimony, Senator Cohen. Thank you for your leadership. You've been, yes, please.
Senator, because I think it is important, to your point, we don't have the data, nor will we ever have the data on how many folks have been go to seek emergency department care in a mental health crisis, and then because they're unable to be seen right away, leave the emergency department and die by suicide. We don't have that data. I think that's probably happening. I also know that we've seen loss of life already because of this situation. It's what sort of prompted this and why Dr. Moore came to me before last year, certainly. This is a dire situation and potentially life-saving just to get this data and have them parse it out, analyze it, and really determine what the next steps would be. So I really encourage the committee to pass SB 181 out of committee.
Thank you. Thank you so much for your testimony and your words. We'll move to the next person on our list, which is Dr. Peter Bloom. Thank you for your patience and welcome.
Thank you for the opportunity, Chairman and the Legislative Council. I come to you today as a practicing podiatrist and podiatric surgeon in New Haven in the Westville section. I've been in practice for 28 years in a 65-year-old practice that my dad started. We've been in the same location for the 65 years. I'm here today to talk about the scope of practice for podiatric foot and ankle surgery. I have been in practice and fortunate to work at Yale New Haven Hospital. I operate there 2 full days a week. I am involved with foot and ankle reconstruction, ankle fracture management, diabetic limb salvage, and caring for the community of New Haven and the referral community. In my position, both in the community and at Yale, I am a lead medical director for the Podiatric and Podiatry group, where I do travel to the delivery networks all the way from Greenwich down to Westerly. And I have been heavily involved with providing the podiatry template for caring for foot and ankle patients, especially the indigent population in the state of Connecticut. With that being said, I'm also part of our residency program with 15 residents, which is a 3-year program, and involved with education, research, and publications. I am here today asking for the expansion of the scope of practice to include pilon fracture, the ability to utilize total ankle replacement, and also the ability to have foot amputations as part of our scope. The ask that I'm here today to discuss is based upon training, academics, and the ability to do these procedures. I personally can do an ankle fracture, an ankle fusion, but I can't at this point utilize a total ankle replacement. And I'll give you an example. I've got 3 podiatrists in the New London County area. They operate at Lawrence Memorial, one of our delivery networks. When they are going to do this procedure for a total ankle or a pilon, they must take the patient to Rhode Island. This must stop. We should be able to provide this care to our communities and these populations in the state of Connecticut. 44 states within the United States allow this privilege for podiatrists. We should not be the last state in the United States to do this. Based upon training, outcomes, patient safety, and the data that is available, we are qualified to do these procedures. We should be able to do these, and especially with the number of clinics we have set up in Bridgeport, New Haven, New London counties, and others. We care for our population, especially the indigent and the Medicaid populations. I personally am an international and known lecturer on saving limbs and diabetic limb salvage. I can use large external fixation devices, drill pins into the leg and the tibia, reconnect the leg. But there are these various laws that were put together 16 years ago when I came to the original committees to discuss these issues. And at this point, I think we owe it to the populace of the state of Connecticut, with the group that we have representing as a former president of the Connecticut Podiatric Medical Association and on faculty and here in New Haven. We should be able to do these procedures, and the evidence for that with respect to training, outcomes, and where we are today in providing medical care, especially in our cities, we owe it to our patients and our constituents to do that.
Excuse me, Dr. Bloom, your time is over.
Thank you so much.
Thank you. And we do have some questions and comments. I'll start with Representative Claridis Teacher.
Thank you, Mr. Chair. Thank you, Dr. Bloom, for being here today. Can you give us some insight on when you are becoming a certified podiatric surgeon, how many foot and ankle surgeries you have to perform in your residency compared to an orthopedic surgeon?
So that's a great question. When we're in our training program, which is a 3-year program, not including the optional fellowships for trauma and total ankle replacement, we're talking about over 1,000 foot and ankle procedures done within our 3-year period of training, in addition to 4 years of podiatric medical school. We're focused on the limb reconstruction. When you look at the national data of the orthopedic residency programs, they're doing hips, knees, they're doing extremities. Their numbers are much less significant. From what I'm told, they're less than 20 when it comes to the foot and ankle in order to graduate from a qualified orthopedic program. We are focused on foot and ankle reconstruction. We have significant components and parameters that we must follow according to the American College of Foot and Ankle Surgeons and the American Podiatric Medical Association. In order to graduate from the Yale Podiatric Surgery program, those numbers are well known, and we have provided lists of those cases.
Thank you, Dr. Bloom. And as a second and possibly follow-up, you are asking as part of this bill to add P-line fractures and ankle replacements, but currently you're able to remove a total ankle replacement. Is that correct?
Yes, we can do reconstruction, we can bone graft, we can do fusions, we can use external fixation devices, but we can't put the implant in.
Thank you. And my last question, in your opinion, do you think this will increase access for Medicaid patients?
Most definitely. This will provide a conduit for our patients, especially in New Haven County, to have access, just like New London and Bridgeport, to the Medicaid population to be able to undergo total ankle replacement and not just ankle fusion.
All right. Thank you for your answers. And I think to the point, we've heard other testifiers saying that there's not a need for podiatric surgeons to be doing this. But in the state, if we have more access with more options, I don't know how that could be a bad thing for the state of Connecticut. Thank you, Mr. Chair. Thank you, Dr. Bloom.
Thank you.
Senator Summers.
Yes, good morning, and thank you, Dr. Bloom, for being here. First, I want to say years ago, I was a wound expert, so I know how podiatrists are so well trained in the foot and ankle and saved many diabetic feet that I had to deal with years ago. So thank you for all that work, and not many people want to do that kind of work. As someone who represents Eastern Connecticut and Lawrence Memorial Hospital, I am really tired of having people have to go to Rhode Island to have this service done, especially those who are on Medicaid, I'm sorry. I do have a question. You know, I see this personally as a turf war. I don't think that there is anybody more qualified to operate on the foot than a podiatrist. You are schooled in that specifically. And I wanted to see if you had any follow-up data. I don't know if this is available. I have not been able to locate it. As far as what kind of aftercare results, i.e. infection rates, do we have when a podiatrist does a surgery in one of the 44 states that allows these two procedures to be done versus an orthopedic surgery? Is there any difference in the outcomes of the surgery that you could provide to us nationally?
There's one study that's published with data, I think, from 2007, which looked at over 1,000 orthopedic procedures, if not more, compared to podiatric. The data was skewed. They didn't look at the multiple comorbidities, especially the patients, as you stated so eloquently. Our population that we're seeing is the indigent diabetic population or the at-risk with peripheral vascular disease. So when they looked at the data of the one study done, the cohort did not reveal accurate data. It wasn't a 1-to-1 ratio of cohort. The study that was done, I thought was done well, was out of Kaiser Permanente by Glenn Weinrob, which showed there was no difference between ankle reconstruction for ankle fractures, including pilons versus non. They looked at thousands of cases in the Kaiser system in California, and there was no difference whether a podiatric surgeon or an orthopedic surgeon completed that study. And I thought that study was done in 2021. It was the most appropriate studies done that did not reveal data from more than 10 years prior.
Okay, and I would like to also follow up with just two more questions really quickly. We've heard some testifiers saying there's no access issues. I disagree with that completely because I see it in my area where especially those that are on Medicaid cannot get the care that they need, or they cannot get a total replacement. They can get a fusion, but that's a lot different than having your ankle replaced. And if they do try to go through an orthopedic surgeon, they get a response that the practice is full, or they go to the bottom of the wait list. And again, for me, I don't think that care should be doled out based on whether you're on Medicaid or you have private insurance. So do you see access as an issue? You mentioned the 3 cities and sort of the indigent population. We talked about those with diabetes and other comorbidities that make surgery even more difficult. Do you think that there is actually an access issue? And if we are able to allow you to perform up to your scope of practice that is valid in 44 other states, that you will see a decrease in the wait list, so to speak, for these types of procedures?
I fully agree. I think it's interesting that your area, New London, has the least access. And the reason being is you don't have an academic medical center right in New London. So the 3 podiatrists that are active with us, they have a new associate with them who is trained in total ankle replacement in Rhode Island. She has joined the group in your region. She is outstanding and cannot perform those procedures in the state of Connecticut. So your region, prior to her coming and prior to our other practitioners, if you tried to get a patient in on Medicaid to a private practice in New London County, you could not do that. That is 100% accurate. Access in New London, I think, is one of the most crucial parts. Yes, we have some folks that work in clinics in New Haven, but even access here for what we do is limited. But you are in the region that is lacking that access more than any region in the state of Connecticut.
Great. And I just want to add one thing, and then I'll stop here and pass it on to my colleagues, is L&M Hospital owns a Westerly hospital. So if you are in my region, you can't have a surgery in New London where you live, but because Yale owns a hospital in Westerly, Rhode Island, you can travel 30 minutes to a Westerly hospital and have the procedure done by the same podiatrist that calls on L&M and Westerly, which makes absolutely 0 sense for me.
Yeah, so Dr. Michael Saparza is the surgeon that I spoke with last week, who has a number of pilon fractures that were seen in Connecticut and operated on in Westerly Hospital. That must stop.
Thank you, Doctor.
Representative Kristen McCarthy-Vahey. No, we're going to go to Rep. D'Amico.
I'm happy to defer to the good co-chair if
I think our question was answered.
Oh, great. Thank you, Mr. Chair. Thank you, Dr. Bloom, for coming and testifying in front of us today. At the beginning of your testimony, you referenced the scope of practice review. So I just want to take a minute to take you back to that. So do I understand correctly that the Department of Public Health recently did a scope of practice review regarding this issue?
So this has been an ongoing process for the past, I think, 8 to 12 months, and that was trying to come up with an agreement between the Orthopedic State Society and the Connecticut State Podiatric Medical Association, trying to come to an agreement where we can include these procedures, and that has been an ongoing process without resolution.
But I'm not sure that answers my question. Was there a scope review or am I mistaken?
I don't know what that means by, I need to know what the definition of review, what does that mean? Because
I don't know what to say. My understanding is that in cases like this, the Department of Public Health authorizes a board or a panel to do a scope review to hash this all out. And I'd really be appreciative of that information in order to be able to make an informed decision about this.
I would lean more to, there have been committee meetings, and I've been involved in some of these meetings, but yet there has been no consensus reached from what I've been told. I have been involved, but I'm not sure about the definition of a formal scope review and what the.
So I appreciate, I don't mean to cut you off. I'm sorry.
Go ahead.
Well, I guess my only reaction to all of this would be if the people who are knowledgeable about this cannot come to some kind of a consensus on this issue, how is it that lay people like myself, and I realize that we have doctors on this committee as well as nurses, and they do a fantastic job, but by and large, we're all lay people on this committee. How is it that we're supposed to make a decision on something like this when the people in the know can't come to a consensus? That's what troubles me, Doctor.
I think what's happened thus far, and I think what you've heard from some of our legislators this morning, is that this has become a turf issue instead of a patient care and access and training and patient safety issue. So I don't think there's been any consensus we've reached with the Connecticut State Orthopedic Association. And thus far, we're hoping that we can come to an agreement, and hopefully we can get this bill raised so that we can address these issues from a state perspective.
Thank you.
Thank you. Thank you very much.
Rep. Daphne.
Thank you, Mr. Chair, and thank you for being here today. And I've asked this question a couple of times before. Can you share with us any issues or problems that they've had in the other 44 states that have expanded this scope of practice?
You're asking me to describe what's happening in the other 44 states? Is that correct?
I'm just asking if you're aware of any issues that have occurred in the other 44 states with this expansion of scope of practice for podiatrists.
Yes. So according to the American Podiatric Medical Association, the answer is no. I know that I have followed the data on the changes in scope of practice when we added ankle surgery and the additions to the surgical scope. I'm not aware of any reports to the Department of Public Health. I do sit on committees and performance improvement, morbidity, mortality at Yale New Haven Hospital, and we there have not seen any issues as well. I am not aware of any within the 44 states or any with respect to hindfoot ankle reconstruction.
Thank you for that answer.
Senator Marks.
Thank you, Chair. I'm sorry I got here late. I was at a appropriations public health meeting. So I want to thank you. I work with podiatrists all the time, and the outcomes that I see, as I'm a visiting nurse, so I look at probably not as many feet as you do, but I look at a lot of feet. So would you say with our Title 19 clients, because it's so hard for them to find surgeries, if you're a Title 19 client and you have a foot wound due to diabetes or poor circulation, and after every kind of treatment there was for that wound, you ended up that you had to amputate part of the foot, would you say that there are, and this is just from this, there's no scientific, nothing, no, this is just me talking as somebody who sees this in my day-to-day life, that Title 19 clients will end up having a below-the-knee amp because there is not the staff that could do the foot surgery. Do you know what I'm saying?
Yeah, so I do. So, my career, most of my career has been dedicated prior to this to diabetic limb preservation. My publications, all the chapters I've written have been on limb preservation. This is a national problem. It's an international problem. with 7 to 10% of diabetic patients having these complications. Access is an issue, and we are trying to address the rate of below and above knee amputations with that access. With that being said, I think the Medicare data that is now available in the United States shows that podiatrists provide the majority of wound care, wound reconstruction, amputation, and diabetic limb salvage. With that being said, are we always perfect? Can we always get them done? No, but we've got private practitioners like myself that do see Medicaid every day. We've got clinics in each of the hospitals, and you do have some salient points, and that is these folks are at risk. In addition to the patients that we're talking about today, in addition to those that need elective and non-elective procedures, that access is truly imperative in what we're talking about.
Yeah, thanks. I am from New London, Eastern Connecticut, as like Senator Summers said, and it is very hard for the Title 19 clients can get into a podiatrist. There's much more so now than before, and which is just so wonderful. But then when it comes to preserving the limb did not work, I see much more below the knee amputation when I'm not sure that's exactly what we needed to do. So thank you for your answer.
Thank you.
Representative Kristen McCarthy-Vahey, my co-chair.
Thank you, Senator. Thank you, Senator. On second thought, I will ask a question. You spoke about, and thank you, doctor, for being here with us. You spoke about ankle replacement versus ankle fusion, and this is one of the topics of conversation here today. Can you tell us, for those of us who are not medical providers, and as I often say at the 4th grade level, very basically, what the difference is and why that difference is important?
So that's really the crux, and that's an incredible question. And that is, I currently, on a monthly time frame, if somebody's got a dislocated arthritic ankle, or they've had a diabetic complication where they've got an infection, if we look at the arthritic population or the geriatric population, I personally perform fusions of the ankle where I take the tibial bone and I fuse it to the talar bone. So the ankle doesn't move, but it eliminates their pain and increases their stability. So I could put screws in plates with drilling, and I attach the tibia directly to the talus. That fusion is a solution to pain and instability and other problems. But there is another solution, and that is, instead of fusing the ankle where they can't move the ankle, we can put a metal replacement in the ankle so that the ankle can move unrestrained. And in some cases, if these patients meet the criteria, they can have a total ankle replacement, like an ankle replacement or a total knee replacement or a hip replacement. So if we can put this metal implant into the ankle instead of putting screws and plates to fuse the ankle, in some patients, it can be a much, much better alternative, because then they're able to move the ankle up and down, and sometimes their mobility is better. So there is data supporting why we should be able to offer a geriatric or a patient that has an arthritic ankle, whether it's from a previous motor vehicle accident or rheumatoid arthritis. We should be able to, if we can fuse an ankle with screws and plates, put the metal implant into the ankle to allow them unrestrained mobility or the ability to walk without pain.
Thank you. I appreciate that answer. Thank you, Senator.
Thank you, Senator Gordon.
Thank you, Mr. Chairman. My good colleague Rep. D'Amico mentioned about the DPH's scope review report, which I'm actually reading through. It's 44 pages and just recently came out. And a question, I don't know if Dr. Bloom is still on or not, but I had a question about what the findings of that report were and their conclusions. I don't know if he's still on.
I am still on.
And I think it's helpful for all of us to read this report. I know it just recently came out, and I'm going to delve with it into it in more detail. But when they talk about findings and conclusions, one of the things they talk about here was, quote, the review committee agreed on the withdrawal of pylon fractures from the scope proposal, as well as on the amendment to allow podiatrists to perform amputation within the foot only, end quote. I just want to know what your comment is about that. If the review by DPH, this committee that was tasked with doing a scope of practice review, is stating in their report that they agreed on withdrawing those two procedures and surgeries from the request to DPH. I'm not talking about the merits of if podiatrists versus orthopedic surgeons to do them, just more the findings of this scope review. And again, I quoted exactly what they said about withdrawing those two procedures, surgeries from the proposal.
So I wasn't at that meeting. I was not able to be part of that initial scope of the review that you're referencing. I was told that, again, they could not come to a consensus. There were some that wanted some of the request withdrawn. Again, I'm not familiar with exactly what was done at that meeting and what was agreed to. I've been involved with this process for about 1.5 years, trying to basically come up with templates as to why we need to expand the scope and what is the impact on our patients in Connecticut, which is what I'm trying to do here today. I wish I could explain more, but there would be additional speakers later today, like some of the folks that are on the board. I am not on the board. I'm a previous past president, but I wasn't at the board level to be part of those scope discussions.
Thank you, Mr. Chairman. I just wanted to highlight that part of the scope review and ask the question about what Dr. Bloom thought.
Thank you. So Dr. Bloom, just wanted to circle back. I appreciate your 2006 study and feeling that may not have been accurate. But the data is in a number of other studies too, even in 2019 from California. I'm looking at the study with Dr. Chan, who did look at 11,000 patients. And there's a significant and statistically significant difference in complication rate when a podiatrist operates versus an orthopedic surgeon, where the complication rates in non-fusion was higher when a podiatrist was operating on some of these cases. I don't expect you to know all these studies offhand, but I just wanted to put that out there. And if you know this offhand, that's fine, but you don't have to respond if don't have the study handy.
I know parts of the study. I haven't looked at it in a while, but from what I remember, it was 4,000 orthopedic surgeries versus 600 podiatric surgeries. And again, when we looked at the meta-analysis of the study, this one study did not pan out. So it didn't provide the subset analysis of looking at the comorbidities, the number of cases. It wasn't a one-to-one cohort ratio statistical analysis. And there were many statisticians on the national level that felt that there were a significant number of pitfalls in that study.
We're not talking about that one. Sorry to interrupt you, because I'm talking about the one with 11,000 cases rather than the meta-analysis. The meta-analysis have their own issues, but I'm talking about a much larger study that out of California. But I think we can probably talk about some of these things during the course of our conversations today. But I just wanted to make sure that we have that information. There is a technical component and a complication rate component as well. I see Senator Summers' hand is up, second time. Please go ahead.
Yes, just quickly, I just wanted to follow up, and I'm sorry, I feel like you're in the hot seat today, Dr. Bloom. But one of the things that I think is important is if this were to pass, if we were to be able to go ahead and allow podiatrists to work up to their potential scope of practice like they do in 44 other states, you still have to be credentialed by the hospital credentialing board to do these procedures. Isn't that correct?
That is correct. So you cannot have I, as the lead, physician executive at Yale New Haven Hospital for the York Street campus and St. Raphael campus, I, with 2 other individuals, am responsible for that credentialing. So if you apply to Yale New Haven Hospital and this is approved, if you do not have total ankle training in your residency, we do not give you the privilege. You have to have the appropriate training in these fields in order to do these procedures. If you apply to Yale New Haven, the New Haven campuses where we are responsible for credentialing, if you apply for ankle privileges and you do not have ankle trauma training, you do not receive that privilege. So the credentialing is done at the hospital level, and that's what we do in order to ensure, obviously, protecting patient safety and also protecting the community at large.
Right. And so it would be unreasonable where somebody would be credentialed if they weren't qualified. It puts a risk to the patient and to the hospital. Also, I think that's important for people to recognize that there's sort of almost like a second layer of review of somebody being credentialed to be able to perform a procedure in the hospital. One thing that I do just want to caution, if people look at the studies that may be out there, it's really important to look to make sure we're talking apples to apples as far as the patient population. Many of the patients that podiatrists see, as I said before, I've worked with a lot of wounds on feet in the past, is the patients that you typically get are very complex. They have a lot of comorbidities going into the surgery. So we may not be looking at apples to apples when we're looking at the outcomes of surgery. So I wanted to just make sure that that was said during this conversation. So thank you for that.
Thank you.
Thank you. Thank you so much for your testimony. We'll move on to the next person. And just before that, I just want to mention that these studies were adjusted for morbidity and mortality risks. Moving on to the next is Dr. Melissa Welby. Welcome. Thank you for your patience with us today.
Hi, thank you. Good afternoon, members of the Public Health Committee. I'm Dr. Melissa Welby, and I am a private practice psychiatrist in Milford. I'm here to comment on HB 5198, an act concerning telehealth. Telehealth has been shown to be a safe and effective modality for seeing patients. The demand for this is certainly not going to fade, and I support these protections not only be extended to 2027, but be extended in perpetuity. Because of telehealth, I'm able to provide improved care. It's easier for patients to access their appointments without jumping through hoops in terms of excess time off, but also I'm able to pivot more quickly when unexpected emergencies arise. And for example, arranging same-day crisis family meetings would have been near impossible previous to telehealth, but now, we can facilitate. Continuing to mandate that insurance companies not only cover telehealth, but also continue to cover it with the same rates as in office is essential to protect access. The current law provides many guidelines that support safe standards for remote care. Beyond extending telehealth protections, this bill could be improved by making it clear that audio-only communication should be protected as an option for all patients for whom it's appropriate, and not just patients being seen by in-network providers or who are enrolled in Connecticut Medical Assistance Program. I have several out-of-network non-CMAP patients who are too uncomfortable to use video conferencing and have not left the house since COVID. I would be unable to continue with them if coverage for this audio-only communication was not protected. These are vulnerable populations, and they would struggle to navigate finding new care. In addition, dictating that an out-of-network provider who sees patients remotely can only charge the same rate as Medicare, while the same limitations are not in place for in-office visits, will disincentivize out-of-network providers from continuing to offer telehealth appointments. Patients have many reasons why they may choose to see somebody out of network. Often it is related to not being able to get an appointment in a timely fashion at network, or the desire to have an extra layer of confidentiality when they see a psychiatrist. Protections against surprise billing are already in place with the requirements to provide a good faith estimate. So those that choose to see an out-of-network physician have a full awareness of fees. These patients have already experienced barriers to accessing care, and restricting rates for out-of-network telehealth visits will further enhance these obstacles and hurt patients. Thank you for your consideration of this important matter, and I'm more than happy to answer any questions today or in the future regarding telehealth.
Thank you so much. This is very helpful, and you bring more credibility to why we should keep doing what we are doing and increasing the capacity in future. So thank you so much.
You're welcome.
And we move on to the next person is Linda Alderman. Welcome. Thank you for your patience with us.
Thank you. Esteemed members of the Public Health Committee, my name is Linda Alderman, and I live in West Hartford. I'm the State of Connecticut Vice Lead of the American Cancer Society Cancer Action Network, and I strongly support House Bill number 5201, which allocates $22.7 million of the Tobacco Settlement Fund to the Tobacco and Health Trust Fund. This bill is of particular urgency because of the governor's decision to remove tobacco control program funding from the federal year 2025 budget. And if this bill does not pass, Connecticut will once again be left with $0 in funding for these programs. Tobacco education and cessation program funds have only been in place for 2 years since Connecticut started funding it again. And to date, the Tobacco Trust Fund has only received the funding for 1 of those years. The program hasn't even had the opportunity to get started before the governor's proposed budget is shutting it down. The $12 million that are being cut from the budget is roughly half of the $22.7 million that CDC recommends Connecticut should be spending at a minimum for statewide tobacco control programs. Connecticut receives $367.3 million annually in tobacco-related settlement and tax dollars, and we are asking for only 6.2% of that amount to save Connecticut lives from the effects of tobacco use, including vaping. Connecticut's egregious lack of funding for tobacco control programs prior to 2022 is having a significant impact on Connecticut residents, and most importantly, is detrimentally impacting Connecticut's children. 5,300 Connecticut kids try cigarettes for the first time each year, and over $2 billion is spent on healthcare costs in Connecticut that are directly attributable to smoking. All of this is happening while the tobacco industry spends approximately $60 million annually in our state on advertising. My family was directly and detrimentally impacted by my father's inability to quit smoking. My father, who enlisted in the U.S. Army Air Force in 1942 at the age of 17 to defend our country in World War II, quickly became addicted to cigarettes because the tobacco industry targeted the military to create a generation of cigarette smokers. Although he desperately tried, my father was never able to break his addiction to nicotine, and he eventually died of lung cancer after years of suffering. He often told me that his addiction at such a young age led to his inability to quit smoking. I'm here today testifying because my father cannot be. Connecticut's residents need $22.7 million to meet the CDC's recommended minimum for tobacco control programs, which will save not only the enormous financial impact of tobacco, but Connecticut lives. For these programs to be successful, they need to be consistent. And for that to occur, the Tobacco and Health Trust Fund requires an annual transfer of at least $22.7 million. Please vote favorably for House Bill number 5201. Thank you for this opportunity, and I'm happy to answer any questions you may have.
Thank you so much for your testimony, Ms. Alderman, and thank you for your patience with us. And I'm so sorry about your father's loss.
Thank you. Appreciate that.
My co-chair has a comment.
I will echo my good chair's comment. I just would like you to repeat the number that we receive in Connecticut from the settlement. If you could share that once more.
Sure, $367.3 million.
Thank you.
Seeing no other comments or questions, we move on to the next person on our list, which is Mr. Bright Johnson. Welcome.
Good afternoon. I'm Bright Johnson, Connecticut Government Relations Director for the American Cancer Society Cancer Action Network. We are in strong support of HB 5201 and have submitted written testimony which details the cost of tobacco use in Connecticut, the disappointing and uneven history of tobacco control funding over the decades, and indisputable evidence in support of the vital role tobacco control plays in helping people quit and preventing kids from ever starting. I'd like to use my time today to simply urge this committee, don't harm progress because of the process. Despite the clear intent of the General Assembly in 2022 to provide continuous, ongoing, and appropriate annual funding for tobacco control programs, the budget revision before the legislature would suspend the 2025 annual deposit of $12 million for 1 year. This suspension, just as implementation is underway, is due to the time it took to reconstitute the Tobacco and Health Trust Fund Board. The budget that restored tobacco control funding for the first time in 7 years passed in June of 2022. The first funding of $12 million was made available 10 months later in 2023 as part of the annual master settlement deposit that takes place every April. The Tobacco and Health Trust Fund Board was reconstituted over the interim and has allocated all $12 million of the available fiscal year 23 funding last month. For the moment then, the work of the board is already all caught up. The second round of annual funding of $12 million for fiscal 24 will not be available for allocation until April of this year, again, because that's when the MSA payment takes place. So even if the board scheduled a meeting for tomorrow, they can't allocate money that isn't available yet. Once the 24 funds drop, the board can make recommendations for allocation, theoretically before the end of this legislative session. Any future funding couldn't occur again until April of 2025. In the meantime, RFPs will be going out, operationalizing existing funding and providing time to learn from the experience of that funding. If enacted, this suspension of $12 million for fiscal 25 would be the 84th time the fund has been swept, cut, reduced, or redirected in its 22-year history. Continuity of services and programs is essential as not everyone reacts or benefits the same way from utilizing the various FDA-approved quit methods. Some take longer to be able to quit. Some react better to some therapies, for example, than others. Interruption in services due to fluctuating funding will only exacerbate the problem and reduce the number of people that would benefit. We are not asking for a new funding source or to create new bureaucracy, only to utilize a portion of that which comes to this state every year for this very purpose. We applaud this committee for making a strong public health statement that not only should funding that follows CDC best practices continue, but be increased to $22.7 million annually, the minimum level recommended by the CDC. Don't let Connecticut fail us once again by inadequately funding proven strategies intended to reverse this entirely preventable problem. Thank you for your time.
Thank you. I wrote some numbers down. I want to make sure I have them correct. So we're asking for some 22.7 million out of the 367.3 million that the state gets, which is less than 5.9% of what the state gets, to be able to help prevent smoking and address smoking, which is the #1 cause of the people of the state of Connecticut. And this would be the 84th time in the history of the state of Connecticut the money is being taken away from the requirements. Did I get that information correct?
Yes, let me just clarify one point. The 360 million that comes in, that's a combination of both the 110 million that comes in through the master settlement, as well as the cigarette tax revenue.
Okay, that's good to know to separate them out. Thank you so much for that. And we have Senator Gordon has a question or comment. Oh, before that, my co-chair. Sorry about that.
Bright, thank you very much for your testimony. You two were perfectly aligned in the lottery today, so that worked out well. This one is hard to swallow. It has been, and this is why you'll see this committee continuing, and it's been wonderful on a bipartisan level to be supporting that minimum CDC 22.7 million. Can you just briefly, because I have a couple questions, so I want to keep it brief. How does the CDC come to that number?
It's determined through a number of ways, geography, population, current smoking rates, what sort of hospitals are in the state, research. There's a number of factors that go into that, and it varies from state to state. Again, population is a huge portion of it. The full amount that's recommended by the CDC is 32 million annually. And I think cumulatively, since the fund has existed, we've barely touched that. And that was only in the last couple of years. But the minimum that they recommend is 22.7 million annually.
Thank you for that. Of the $110 million that Connecticut receives in the master settlement, we had the 12 million. Where does the rest go?
It goes into the general fund. It's considered revenue and it goes into the general fund.
Thank you for that clarification. Similar to the opioid settlement, which we have very clearly designated and are using those funds to properly target this. We know that it's important for us to be targeting these dollars. So the one last question, I'm going to give you an opportunity to give a quick commercial, if you would, for the quit line, which is how we're using some of these dollars. Can you just say briefly what the quit line is and how Connecticut residents can access that resource?
Absolutely. The quit line is a service that has been provided for, I think, over 20 years now. And it's for people that are looking for help in quitting. Quitting tobacco use, as you know, for some people is harder than quitting heroin use. And not everybody knows where to go or who to turn to for help. And so the quit line is a number to call. I actually don't have it in front of me. I'm sorry, but it's a number to call, and they can provide counseling. And depending on the funding level, in years past, through the quit line, folks have been able to get access to nicotine replacement therapies, which are one of the 7 FDA-approved quit methods. Again, if funding is available, and it has been proven to be one of the more successful and proven methods for folks to access. Oh, actually, I've got the number right here. It's 1-800-QUIT-NOW.
Oh, that's so convenient. 1-800-QUIT-NOW. That's wonderful. Thank you for that. And Senator Anwar was also doing some quick searching for us. I want to thank you for this. We know this committee has and will continue to have conversation about our young people, about the use and role of flavors, about the role of vapes. And we understand the tremendous health impact on our residents, and that once you start, it's impossible to quit. And I want to say congratulations to every Connecticut resident who has been able to quit and provide encouragement, as we have with giving you that number, 1-800-QUIT-NOW. Do I sound like a commercial? But thank you very much. And I thank you, Mr. Chair, for indulging me with that.
Can I give you a quick warning?
Sure.
Not to set foot in a different issue area, but if you want to make sure that opioid funding is used for the purposes that it's intended for, make sure that language says shall and not may. Otherwise, they're going to have the same problem as we've been having for 20 plus years with tobacco.
Thank you. We obsess about that for a lot of other things too. You're right. With that, Senator Gordon, followed by Representative Radar.
Thank you, Mr. Chairman. Mr. Johnson, it's good to see you again. I appreciate the work that you and your colleagues do, certainly with the American Cancer Society, which is an organization dear to me and the work I do at being a cancer specialist doctor. I just wanted to make certain that I highlight one item, and it's my question, which I think is the important part of your testimony is, number one, this is money that we're getting or have. It's not new funding, if that's correct. And that the money that we're supposed to be using for tobacco use prevention, which is the best way to try to deal with things as opposed to waiting for tobacco-related medical problems to develop later in life, which is not only a big detriment to the quality of life of our residents of the state, but also huge cost to the medical system, that this is money that would be earmarked and used, in a sense, for prevention services and trying to encourage people who are already using tobacco to quit and seek a tobacco-free life. Is that correct?
100% correct and very well said. Yeah, to reiterate, the state brings in about 110 million each and every year in perpetuity. And the purpose of that was to help offset the healthcare costs relating to tobacco use. This is paid out by Big Tobacco as part of the master settlement agreement that was reached 22 years ago now, I think. And unfortunately, because the language within the settlement is permissive rather than requiring, every time the state has hit a fiscal bump in the road, this has been an easy target, and it's come at great expense in terms of lives lost and huge amounts of money that the state has had to spend over the decades combating tobacco use.
Thank you, Mr. Chairman. And this is an issue that I did submit legislation on, and I think if the money is supposed to go to its purpose, we should make certain it goes to its purpose. Thank you.
Thank you. Representative Radar.
Thank you, Senator Anwar. And thank you, Mr. Johnson, for being here today. This is an issue that is very near and dear to my heart. I lost my father. He was only 54 to lung cancer, and he was introduced to cigarettes at the age of 13 or 14, back when no one thought it was dangerous, and struggled much of his life with quitting, and quit a decade before he actually passed. So I just wanted to share that. But my question is, and I'm sure many members of this committee would love every single dollar of that settlement money to go towards efforts that your organization and others like it support. We've seen an uptick in nicotine addiction in our children and our youth, specifically around vaping, maybe not as much cigarettes, but I'm curious from you, if you could think of some of your most effective programs that you've seen around combating this wave of addiction with our younger folks, and what could you see being expanded if more funding was available? And I know that's a broad question, but that's where in my district, I see the biggest struggle, and probably around the state. And I would love to reemphasize how valuable investing in that would be for our constituents.
Well, thank you for the question. The good news is that the Tobacco and Health Trust Fund Board has already met and has already allocated the first batch of $12 million that was available for fiscal 23. And what they did was they allocated it according to CDC best practices. And what I mean by that is these are programs and services that have proven to work across the country, in other states, and in some respects here in Connecticut. What they did was they allocated to 5 different CDC best practices, including state and community interventions, mass reach communication interventions, cessation interventions, as well as surveillance and evaluation, and then some money for infrastructure administration and management, because this doesn't all just turn on a dime. What I think would be very successful, or would provide the biggest bang for the buck, quite honestly, would be the state and community interventions, an ad campaign, a statewide ad campaign, and then also just making sure that cessation interventions are available at the local level. I think the biggest challenge, or one of the biggest challenges is, as I lose my voice, is that an ad campaign here in Connecticut is incredibly costly given our proximity to New York and Boston. Excuse me, I apologize. The board voted to spend 12% or almost $1.4 million of the 12 million on communications, on a media campaign. I think that you could probably spend the entire 12 million on an ad campaign and make it compelling, and it would be effective. Because for anybody who's my age, this is your brain on drugs. I learned it from watching you. These are PSAs that aired back in the 1980s that we still remember. And if you hit the nail right on the head with an ad campaign, people are going to remember it, and it becomes part of the vernacular. I mean, we're still cutting up plastic Coke wrappers to make sure that the birds don't eat those, and that's another ad campaign from the 1970s that we still do. If you nail it people will remember it, and it will be effective. But unfortunately, we live in a really expensive state for that sort of thing. So money to that, money to the state and community interventions, I think is crucial. Keep funding the quit line, make NRTs available, because not everybody reacts the same way to the same medications. Some people, no problem with counseling or group counseling. Some other people, that doesn't work at all. They need the patch, or they need Shantrix, or some of these other methods that are out there. All that stuff needs to be available, and it needs to be available on a continual basis, because people don't quit at the same speed as everybody else. Some people, it might take a month or two. Some people, it might take a year. And if the funding goes away in the middle of all of that, then you're starting from scratch.
Thank you. Thank you, Bright. Thank you so much, Representative Radar. We don't see any more questions or comments. We move on to the next person on our list, which is Brandon Bartel. Thank you for your patience. Welcome.
Good afternoon. My name is Brennan Bartel. I'm the operations manager for American Medical Response of Connecticut, the Hartford division. AMR is the largest commercial ambulance provider in the state, in a critical role in our state's EMS system. I'd like to thank the committee today to provide testimony in support of Raise Bill 179, an act concerning rates for ambulance and paramedic services. So I filed testimony, so I'm just going to talk through a few points. We know our EMS system is challenged. We have pretty significant challenges with our recruitment and retaining of staff. And we also experience a pretty significant funding challenge. Most of our funding that we receive from our insurance and federal payers, are not covering the costs for us to provide service. A little bit of background, our rates are regulated by the Department of Public Health. They set rates for ambulance providers, and those have been the maximum allowable rates. What this bill proposes is changing that language to the acceptable or the approved rates, enforcing our commercial insurance providers to pay those rates. I've been a paramedic in the state for 11 years. And, our EMTs and paramedics each and every day are called into people's homes in their most vulnerable times of their life to provide care. And we're expected to do that every time we're called. We treat everything from birth to death and everything else in between. There's countless stories of folks who, have lived to see another day because of the work of the EMS providers in this state. The only way that's possible, though, is to ensure that we have a sustainable funded EMS system. We heard testimony this morning about boarding in the emergency departments. EMS agencies provide transport from hospitals, from the floor, and from the emergency departments. If we don't have properly funded or staffed ambulances to do so, that contributes to those delays as well. I'm testifying again in support of Bill 179. Thank you.
Thank you so much. Thank you. Would you be able to repeat the part about the DPH overseeing this part of because this is very unusual, and many of my colleagues asked me a question, why are we addressing this bill in this committee? But there's a very good rationale for this. If you speak to that again.
Yeah, so the way the rates are set, there's maximum allowable rates for the different, the services that we provide, which is, providing, either advanced life support or basic life support care and transporting them to the hospital. There's two ways that that's done. Every year, the EMS agencies could choose to accept the rate that the Department of Public Health has decided is appropriate for an increase, or you could fill out what's called a long form process. And with that, it's a lot more involved. It's producing financial statements of your organization, and they determine what % increase you're going to receive to those rates. But all those rates are, that has no impact on the Medicaid reimbursement that we receive. It has no impact on our Medicare reimbursement. These are rates that commercial insurance providers are we're asking for them to reimburse us at. And because we're using the term maximum allowable, that allows these providers to negotiate or work to reduce that payment. We had testimony last week about the challenges with Medicaid funding and the cost for us to provide service and to be ready. And I think what's important to understand is we we bill, it's a fee for service model. And so when we transport someone to the hospital, we're billing, insurance for that. That doesn't cover the cost to have an ambulance staff 24 hours a day, 765 days a year in case somebody calls for an ambulance. So the readiness cost just to be available to respond and have those resources there is very large. So again, in this sense, we're asking to have some language changed, from maximum allowable to the set rates and support with our commercial non-federal payers to pay those rates.
Thank you so much. Representative Dauphiny has a question or comment.
Hi, thank you for being here today. My question is, so you're saying that the maximum allowable rate is not high enough?
So, well, what I'm saying is that we're not getting the maximum allowable rate. So if our maximum allowable rate is, I'm just going to throw a number out there, $1,000, we're not getting $1,000 reimbursement from our commercial insurance payers.
So just so I can be clear, you're asking us to mandate a maximum allowable rate. Is that correct?
So we're asking to change get rid of the word maximum, and this is the rate for ambulance services, and then we're asking that our commercial insurance payers pay those rates, because we have to subsidize, right? So 73% of our at least speaking for AMR of our patient transports are Medicare and Medicaid, and it's statewide. Those reimbursements are below our cost. And typically what we've been able to do is offset those losses based on our reimbursement from the commercial payers. And we've, as our costs have increased to recruit, retrain, medical supplies, risk insurance, et cetera, purchasing ambulances, the ability to recoup those costs has basically dwindled. So what we're asking for is, that the rates are the rates and that the commercial insurance companies are paying those rates.
So if this bill were to pass, it would be a mandated rate, correct?
It would be to mandate the payment. So because each agency has different rates, right? My rates might be different from another provider. Those are set by DPH, and there's a process for that. We're asking that those rates are the rates that were reimbursed by the commercial insurance.
Okay, thank you.
Yep.
Thank you so much. Again, it's no secret that EMS service in our state is going through very significant challenges, and we need to make sure that you are there when somebody needs them. So thank you for your time and thank you for your testimony.
Thank you.
The next person on our list is Albert Sue.
You got the pronunciation right. Good morning, Madam Chairwoman and Mr. Chairman and esteemed members of the committee. My name is Albert Sue, and I come before you wearing two hats: as a patient grappling with depression and bipolar disorder, and as the facilitator of a mental health support group. And I am in support of HB 5198, an act concerning telehealth. I've battled bipolar illness for decades, and for the last 14 years have been receiving care from psychiatrists and psychologists within a community health care system based in Connecticut that provides behavioral health care services alongside other medical care to various constituencies. In recent years, telehealth has revolutionized mental health care. Personally, I've benefited greatly from remote sessions with psychiatrists and therapists, finding them not only convenient, but surprisingly impactful. The heightened focus demanded by telehealth fosters deeper engagement, amplifying therapeutic outcomes. From 2020 to now, I've utilized telehealth services, and I found the care I received to be excellent. Telehealth services can offer ancillary benefits beyond psychological support, such as assisting those in challenging socioeconomic situations and those who are technology challenged. As a support group facilitator for the last 14 years, I've witnessed firsthand the transformative power of virtual meetings. Amidst the 2020 quarantine, transitioning our in-person meetings at St. Vincent's Behavioral Health Center in Westport to video conferencing was met with resounding success, enabling broader participation, especially since mental health needs increased dramatically. Evidence of this was demonstrated by the addition of group members in an expanded New York, New Jersey, Connecticut tri-state area. I was pleasantly surprised that members joined from England, Portugal, Ecuador, California, Florida, Texas, Pennsylvania, and elsewhere. Telehealth's convenience is often cited as a primary advantage, but it also elevates focus and attention for both provider and patient, maximizing effectiveness. For those juggling work and therapy, telehealth offers a lifeline, eliminating the fear of having to disclose to employers compromising private information, such as HIPAA, and easing the burden of travel and time constraints, including those that cannot drive, the elderly, such as my mother-in-law, and those with high social anxiety. In conclusion, the shift towards telehealth represents a pivotal leap forward in mental health care accessibility and efficacy. As we navigate the evolving landscape of mental health support, it is imperative that we recognize and embrace the profound benefits that telehealth brings to both patients and practitioners alike. Thank you.
Thank you for your testimony. All right. I thought there was a question. I'm going to go to the next person on our list. Seeing no questions or comments, we appreciate you being here. Lending your voice as a patient really adds more value for our understanding. Thank you. Next is Steven Straub, Connecticut Athletic Trainers Association. Welcome.
Good morning, members of the Public Health Committee. My name is Stephen Straub of Southington. I work in North Haven and Hamden at Quinnipiac University, where I'm a professor of athletic training and sports medicine. I am currently the president of the Connecticut Athletic Trainers Association, whom I represent here, and I'm here supporting House Bill 5199, an act creating a task force to look at the shortage of athletic trainers in the state of Connecticut. To be clear, I would like to just take a second to express who athletic trainers are and who we're not. If you look through your list of submitted testimony, there's quite a bit of confusion between certified athletic trainers and personal trainers. So certified athletic trainers, who we are board certified and state licensed. We work underneath a practice act that is passed through public health and is passed through our Connecticut legislature. Typically, we work under standing orders from a team physician or a school doctor, and we are not personal trainers. So how do we get to this point of a shortage of athletic trainers in the state of Connecticut? One of the things that you may not be familiar with is that in 2015, an Athletic Training Strategic Alliance determined that the entry-level degree for athletic trainers be elevated from the bachelor's degree to the master's degree. And now over the last 9 years, this has been being implemented nationwide. So in Connecticut, 4 schools have currently made the switch from teaching at a bachelor's level to teaching at a master's level. And 1 school is in the process of actually teaching out its bachelor's cohort. They made a strategic decision that they would not switch to a master's degree. So over the last 3 years, 107 students have actually passed the certification exam within Connecticut. But as we look at this, more than half of these students have been undergraduates. And when we consider the master's programs, they require additional time, resources, and commitment from the students. And our early master's cohort sizes indicate that we will likely be graduating fewer students than we have in the past in the state of Connecticut. People are leaving the profession. One of the big things, and this has been mentioned here a few times as I'm sitting here during the day, is the effect that COVID-19 had and its impact on the number of educators in the state and the number of healthcare professionals who are leaving their professions. And in particular, when we consider high school athletic trainers, they're sort of at this intersection of education and healthcare in the roles that they play. And we have lost a number of our athletic trainers as they've headed off to different areas where they've been able to use their expertise that they picked up in an athletic training education and as professionals there and moved on to different jobs within the state. So this presents a challenge, in particular when we think about our high schools as they try to hire full-time athletic trainers. There have certainly been some successes, but there have been many challenges throughout the state. In particular, we see PT-based or physical therapy-based and or hospital-based athletic training service contracts that are being dropped. So these facilities can't hire the physical therapists, they can't hire the athletic trainers, therefore they can't maintain their contracts with a number of high schools.
Excuse me, Mr. Straub, but your time has ended.
Thank you, ma'am. Thank you,
Well,
members of the committee.
My question would be if you want to wrap up in a few seconds or 30 seconds.
The biggest concern really is impactful in some of the urban areas as we look at places like Hartford, Waterbury, and New Haven. And the fact that they do not have, many of these schools do not have athletic trainers within their schools. In contrast, places like New Canaan and Glastonbury, two athletic trainers in a high school, they're doing wonderful. They're providing a standard of care that we would expect, but this has really resulted in a large healthcare inequity.
Thank you so much for your testimony and
Any questions I can answer?
yes, I wanted to start by saying that one is, of course, the physical activity has its benefits, but there are secondary benefits with all the emotional challenges our students are facing and the loneliness component we are all talking about. Just speak to that a little bit, if you could.
I think you're talking about one of the great advantages of having an athletic trainer in a high school in a full-time role, that you have this healthcare professional there who has an opportunity to interact with these students in a way that other teachers or other faculty members of the school may not be able to do that. And whether you're standing on a sideline or sitting on a bus with them or having some interactions, and we do see many times our athletic trainers do have that opportunity to interact with a student and to see some of these healthcare issues that come up.
Thank you for that. And our ranking member, Nicole Claridis teacher, Representative Claridis teacher has a question.
Thank you, Mr. Chair. Thank you for being here today. And I appreciate the explanation, the clarification from athletic trainers versus personal trainers. And we know there's a huge difference. You explained that you do see athletic trainers in high school and college, but what are some other areas where athletic trainers are employed?
Good example is Amazon. Athletic trainers are working within Amazon. We've actually recently lost some of our employees at Quinnipiac who have shifted over to Amazon. One working as an actual healthcare provider on the floor, trying to prevent injuries for those individuals and working with the initial injury, and others working in an OSHA role through them, where they're looking more at injury prevention. The military is also a very popular place for athletic trainers to be making a shift towards.
And do you also see athletic trainers in being employed by police departments and fire departments?
Absolutely. Absolutely the same type of thing where you have physically active individuals who are getting hurt. They can get immediate point of care, and we can also be looking at injury prevention for these individuals.
And do you believe that employing athletic trainers in these non-traditional school settings will help a bottom line of a town or a city's their injury, what's the word I'm looking for? Their injury quotient, quote, if we have less injuries, less insurance claims, athletic trainers are helping people stay healthier. So they're working through their injuries on the job, and that's less time that they have to spend off the workforce.
Absolutely. This has been shown in a number of places. In particular, it's been shown in the military, but that model that you're talking about within fire departments, within police departments, that's being enacted across the country.
And then in the school settings, what are some of the issues that you're seeing that schools that don't employ athletic trainers?
You mean what's happening with
Yes,
those schools?
yes.
It's interesting to sit here and listen to the gentleman from the emergency room talk about overcrowding in the emergency room, and the gentleman from AMR talking about emergency transports. Typically, when you have an athletic trainer in a facility, those incidences go much down. I can think of, over the course of 9 years in clinical practice, probably counting on the number of on two hands, the number of times that I needed to call an ambulance or needed to send somebody to an emergency room, because we have the ability to work with that right away, work with our team physicians, work with our parents about transport, and keep people out of emergency rooms and keep people out of ambulances.
And then my last question, what is the training for certified athletic trainers as far as emergency management, emergency situations?
That is a large part of what we do within our educational processes here, whether you're going to be talking about CPR and AED use, whether you're talking about spine boarding, any type of traumatic injury that you would see. And I think right back to one of my early students who graduated, the first day that she went to a high school, she actually performed CPR on her athletic director. So those are the types of trainings that at the first day that hit her. So those are some of the trainings that athletic trainers engage in to be ready for those types of emergencies.
That's great. Thank you for all the important information. I think it's important to educate people as to exactly what we as athletic trainers do on a daily basis, and we do end up saving lives many times. Thank you. Thank you, Mr. Chair.
Thank you, Representative McCarthy.
Thank you very much, Mr. Chairman. Very quickly. So the bill in front of us today is to establish a task force to look at the shortage of athletic trainers and the retention. Have you been able to look at the bill? Do you have any other recommendations that perhaps the task force should be looking at as we're concentrating on athletic trainers?
I think we're looking at it from a couple of areas. One is making sure that there are enough students coming out in the area who want to continue to do this. And then two, making sure that the work environment is a work environment that will keep people there. Unfortunately, currently nationwide, a typical athletic trainer will work in its profession for approximately 7 years before they move off to some of the alternative pieces. So they'll start in high schools, they'll do some of these things, but then they move over. But we have some excellent examples in the state of athletic trainers who have been at high schools for extended periods of time because they've generated a good environment. It's a good place to work. I saw somebody from East Haven is here. I'm not sure who covers East Haven, but East Haven High School just happens to be an excellent example. Marcosito's been there for probably over 12 years, and he just has built a fabulous relationship with the town. And if every town could have something like that, that really benefits the school system. It benefits our student athletes, and it's in position to take some of the pressure off of the medical system as a whole.
Thank you.
Thank you so much for your testimony, and this is very helpful for us to clarify our issues, and it's very important. Thank you.
Thank you for listening to me today.
Of course. Next on our list is Miss Morrison, Emily Morrison, online. You're welcome. Please go ahead.
Hello, thank you so much. Senator Anwar, Representative McCarthy Vahey, Senator Summers, Representative Clara Stitra, and distinguished members of the Public Health Committee. My name is Emily Morrison. I'm a Putnam resident and Director of Development at United Services Incorporated. United Services is a nonprofit certified community behavioral health clinic serving 21 towns in northeastern Connecticut. We operate more than 30 programs under our one administration, including outpatient mental health for adults, children, and families, substance use treatment, including medication-assisted treatment for opioid, alcohol, and tobacco use disorders, crisis programs, domestic violence programs, parenting programs, primary care, comprehensive services for individuals, serious mental illness, and an array of services for business and industries, as well as prevention services. United Services urges you to support HB 5198, an act concerning telehealth. United Services provides services both in person and via telehealth. And while we prioritize in-person services, telehealth services allow for us to continue to provide services when medically necessary. So for example, if an individual is sick, they do not need to delay their appointment with their therapist or psychiatrist. This only currently represents about 5% of our appointments, so about 400 to 500 per year. But if it prevents that 5% from experiencing a crisis or hospitalization due to delayed regular care, it is worth it for us. We appreciate that this bill at HB 5198 extends the expiration date of the current telehealth law to 2027 and includes several important provisions, including paying for telehealth at the same rate as in-person visits and allows services to be delivered from any setting, allows telephonic and audio-only sessions when appropriate. This is important to assuring access to care for people who need it when they don't have access to technology needed for video conferencing, as well as allowing the use of any HIPAA-compliant platform. United Services supports HB 518 and would further encourage this committee to permanently codify these telehealth provisions in state statute. Thank you so much for your time and consideration.
Thank you so much. Your testimony is very helpful. Seeing no questions or comments, we'll move to the next person on our list, which is Miss Betty Burgess. In-house, are you here? Not seeing her here. We'll move to Dr. Sean Peden online.
Hello, everyone. Thank you, Senator Anwar, Representative McCarthy Vahey, and distinguished members of the public health community. I'm Sean C. Peden, and I'm an orthopedic foot and ankle surgeon working with Greenwich Hospital for 10 years, and it's the same hospital in town where I was born and grew up. I'm now an assistant professor of orthopedic surgery at Yale University. I have been involved in this issue of podiatry for quite some time now, directly involved on the recent scope request committee, and I'm happy to discuss that further. But today I'm here on behalf of the Connecticut Orthopedic Society, and really I'm here as an advocate for my patients and for the patients of Connecticut with foot problems. I thank you for the opportunity to share my testimony in strong opposition to House Bill 5196, an act expanding the podiatric scope of practice. So as a foot and ankle orthopedic surgeon, I see firsthand the dangers of expanding scope, in particular to a vulnerable public, which may not know the difference between an orthopedic surgeon and a podiatrist. So you've heard a lot of opinions about this from speakers and even members of the committee, but what I want to focus on is not my opinion, but the facts about the issue. So first off, the facts are that these are two of the most complex surgeries. And when I speak about these two surgeries, I'm speaking about what's called a pilon or pilon fracture. That's the worst kind of ankle fracture you can get, as well as an ankle replacement, which is an extremely complicated surgery, much more complicated than just a regular hip or knee replacement. These procedures should only be done by the best. And this is something that I do and my colleagues do. And really the question is there a need, or would there be a benefit to this bill? And you're hearing about some very rare anecdotal things, but Yale has 38 surgeons who accept Medicaid in 6 counties. 30% of our patients have Medicaid, and 29% of those surgical cases are Medicaid. Any patient, regardless of an insurance, can get an appointment with me or my partners in New Haven County within a matter of days. I challenge you to call and see how hard it is to get to see us with a pilon fracture or with discussion of a total ankle replacement. But what's much more important is the data. And we've talked about it a little bit peripherally, but you've heard a lot of excuses for why the data is different. There are numerous scientific studies, and some of these are demonstrated in this podiatry scope request committee report, that patients do worse when they're treated by a podiatrist when compared with an orthopedic surgeon. We talked about the study of 11,745 patients. We're not talking about just a few patients. Patients have double the risk of complications when a podiatrist does the surgery. So it's pretty clear that patients are going to have more problems if we expand scope. But taxpayers will do worse too. There's also ample data, numerous studies that show that podiatrists are less efficient and cost effective. And so they end up costing more to patients, taxpayers, and hospitals. And there's no data to refute this. Their podiatrists have been in 44 other states doing these procedures, but they can't report and show us one study with equivalent outcomes comparing orthopedic surgeons and podiatrists for any procedure.
Excuse me, doctor, but your time is up.
I have a question that I wanted to ask you, and I think many of our colleagues have questions as well. Thank you for your testimony. The issue that we are dealing with right now is that whenever we are talking about a study, people say, well, they're apples and oranges, because for some reason, all the research that has ever been done on this topic, they are selecting the sicker patients to be taken care of by the podiatrist and relatively healthier by the orthopedic surgeon. How do you reflect on that?
Well, first of all, that's not true. Some of the studies do, and it's reflected in the data, and that there may be slight differences in some of them, but not enough to expand to cause double the complication rate. Many of the studies, which I'm happy to provide and discuss in further detail, there's no difference in terms of the patient characteristics or comorbidities comparing them, but yet the outcomes are worse and the costs are increased when podiatrists perform the procedures. So while that is a convenient, you can always poke holes in any one little study. But if I was going to come to an important committee like this and request to expand my scope of practice, I think the responsibility should be on the people requesting the expansion of scope to prove that patients won't be harmed. Number one rule is do no harm. And we have ample data to say that increased costs, increased complications are going to come. So that's why I strongly oppose the bill.
I just wanted, how would you reflect if I was to say, look, the orthopedic surgeon is spending 4 years and operating on multiple different joints, not restricted to the ankle. And the podiatrists are spending 3 years training in part of one specific area of the body. So by definition, they have more experience to address that.
Well, so someone like me does 5 years of orthopedic training, which does include all over the body, but we are doing some of the most complex operations, whether they're hip, knee, spine, hand, and all of that experience I still use today when I perform complex foot and ankle surgery. But in addition to that 5 years of training, every orthopedic foot and ankle specialist has done an additional year of fellowship training, where we often do 500 to 1,000 cases in a year. And that combined with 5 years of training, there's just no comparison. And we can compare our training, and say it's apples and oranges, but there's no other specialist surgeon at Greenwich Hospital, where I work, or at Yale New Haven Hospital, where my colleagues work, who've only done 3 years of postgraduate training, except for podiatrists. They are the least trained doctors performing surgeries in the hospital.
Can I ask you, from what I was gathering, orthopedic and podiatrists work very well together, taking care of the patients. Why don't you guys figure it out yourself?
Well, we tried, and we had a scope committee, and we did agree on some things. We agreed that pilon fractures are too complex for podiatrists, and that was agreed upon. And it appears that now this bill is going against that agreement. We also agreed, for the most part, about the need for, I haven't spoken much about amputations, and diabetics perform a very important service, podiatrists perform a very important service for our diabetic community. There aren't enough orthopedic surgeons to take care of there's probably about 100 podiatrists for every one of me in the state. And so we do work together very well. But when it comes to these two issues, we tried. And my only answer is to say that we're putting patients first, and what we care about is safety, and the data is not there to support expansion of practice. I don't care what happens, and neither should you, what happens in other states. There are plenty of exceptionally trained doctors to perform these two procedures, pilon fractures and ankle replacements. And when it comes to amputation, I think we agree that expanding it to include the foot is reasonable for podiatrists.
Thank you, Representative Claridis teacher.
Thank you, Mr. Chair. Thank you for being here today. You spoke briefly, I believe, and I apologize if I didn't hear, about the scope review. What was the compromise, and why did the compromise not go forward?
The compromise was that, and I don't want to misspeak because I know it is available to you, and I would take very seriously. I don't want to get the facts wrong, but the compromise, I believe, was that the orthopedic surgeons, as well as the podiatrists, the podiatric community, agreed that including amputations to the level of the ankle joint is acceptable and appropriate. We also agreed that not including expansion to pilon fractures was appropriate. We did not agree on ankle replacements at any point, and I think that upset them, and I understand it's their profession. This is a personal matter to them and a turf matter, and I respect that, and I value, and I have worked with many podiatrists, and I respect the importance of their involvement. But we can't, when we have this data from thousands of patients that says that patients do worse and costs are higher, I can't in good faith support expanding that to our citizens in Connecticut.
And where are you getting the information that's stating that costs are higher going to a podiatrist versus an orthopedic surgeon?
I can state multiple papers. There's a paper from 2021 about the cost of operative fixation comparing orthopedics and podiatry, published by Joshua C. Lugenbuehl. That was a study of ankle fractures comparing orthopedics and podiatry. And it demonstrated that the operating time was longer, that the cost of the equipment that was used was higher, and that it was significantly less when compared with an orthopedic surgeon. That's one study. There's another study with the 2018, 2019 Journal of Bone and Joint Surgery, which is the top most prestigious magazine or journal, from the orthopedic community that shows increased costs with total ankle arthroplasty, increased length of hospitalization with with ankle fusion. And we're talking about big numbers here. This is 5,000 ankle fusions, 4,980, and 3,674 total ankle arthroplasties.
Okay, thank you.
And there are other studies to support that. Sorry.
Thank you for the information. And I think we all know we could find a study to support anything we all say on any given day, but it matters where those studies come from, if they're peer reviewed and where the data is used. But you also mentioned that podiatric surgeons only have 3 years of surgery in the foot and ankle versus orthopedic surgeons that have how much training?
We do 5 years of residency training and I did 1 year of fellowship specific in foot and ankle. So 6 compared to 3, double. And to answer your question, we can your comment from before, we can all come up with studies. I suppose there are no studies showing equivalency between podiatrists and orthopedic surgeons when compared. There are no peer-reviewed studies, period. So they can't come up with that, the podiatric community.
Thank you. In your residency, how much time and how many surgeries do you do as an orthopedic resident in foot and ankle? Only.
Well, I was interested in foot and ankle, so my experience would not necessarily reflect everyone out because you do get a little bit of choice in the matter. And I was interested in foot and ankle from the time I was a second-year resident. So I was seeking out more cases than the average orthopedic surgeon. I did 400 foot and ankle surgeries in my 5 years, and then I did 800 during my fellowship.
Okay, thank you. And that answers my question. To your point, you said you specifically wanted to do more foot and ankle, but as the general population, I think when we go to have a surgery, I want to have the surgeon that has performed the most on that body part. I'm getting my hip replaced. I don't want to go to someone that does mostly ankle. So I'm going to go to a specialist in that field. And I think 3 years strictly in foot and ankle is a considerable amount of time in that specialty. Thank you, doctor.
It is. Absolutely. It's a considerable amount of time, but it's not just quantity, it's quality of training. And the data just doesn't support. Obviously, everyone has a choice, but what's sad is some patients don't know the difference between podiatrists and orthopedic surgeons. And then they have a complication and they don't realize.
Another question with Representative Parker.
Thank you, Mr. Chair. Thank you, Dr. Peden, for being here. I'm trying to understand the magnitude of these procedures in a provider's overall scope of work. So I think we're talking about total ankle replacements, fractures, and amputations. We heard a little bit this morning about how one of those is not that common. I think we were talking then about the replacements, but I could be wrong. So maybe first, can you just help me get a sense of, are these 3 procedures pretty common? Are they happening a lot? Are they a big part of your practice?
Well, to start with amputation, I don't want to focus on that too much because I do think there's a role for podiatrists performing amputation at the level of the foot. It's as uncommon as we can possibly make it. We have great doctors like Dr. Bloom you heard before, who for years has dedicated himself to diabetic foot ulcers and to try to prevent amputations. But moving on from that, what I'm talking about, or what I want to focus most on, is ankle replacement. That is, for every 100 hip replacements and every 100 knee replacements performed every year in this country, there's 1 ankle replacement performed. So it's a less common problem. and it's a less common solution as a result. So this is a situation where having more choice isn't necessarily a good thing. You'd rather have a doctor who performs, as our representative said before, the most of these surgeries. So having an additional 100 podiatrists who could potentially do ankle replacements is going to lead to more doctors performing less surgeries. So it's very uncommon. About 10,000 ankle replacements are performed in the entire country. So a busy orthopedic foot and ankle surgeon in the state of Connecticut right now might be doing 10 or 15 or 20 a year, whereas my partner who does hip and knee replacements does hundreds in a year. 200 joint replacements is common. So it's a very different, and to kind of compare it to a hip or knee replacement isn't really fair. It
Sure.
has higher complication rates too. And then
How
to
many-
answer Pilon, go ahead.
How many do you perform?
I perform on a busy year, 5 to 10,
And how many overall surgeries are you performing a year?
in the neighborhood of 200 to 300.
Okay, so it could be like 5% of your overall practice?
Yes, yes.
Okay. I'm sorry. And you were going to
That's
share
not
then
necessarily reflective of everywhere. Some people do more, some people do less. It's really depending on the practice.
Okay, it sounds like you're probably on the higher end though, given your focus. Is
Right.
that what I'm understanding?
Correct.
All right, I
Yes.
think you're going to make one other point, but I don't want to take up
And
too
then
much
just
time.
regarding the
Briefly.
pilon or pylon fractures, thank you, sorry to cut you off. Those are more common. They are crushed fractures of the lower leg at the level of the ankle. And this is where experience comes in. I mean, someone training with the podiatry residency that's in New Haven isn't going to get to do any of these, right? If you're in podiatric training, you're going to do 0 of these because it's not allowed by law. And it wasn't allowed by law for a good reason, because it's a very complicated fracture. And when I do an orthopedic residency, to speak to the experience, we do crushed fractures of the knee joint, the hip joint, the shoulder, the wrist. So a lot of those same principles go into when I do a pilon fracture now. These are more common depending. I don't do that much trauma. I probably do about a similar amount, 5 to 10 of these a year, but of pilon fractures. But some of my partners in New Haven do dozens, and they are often trauma trained orthopedic specialists. And then some of my partners who are foot and ankle specialists may do more too, depending on their practice. If they work at a very busy trauma center, which I don't. Greenwich Hospital is a relatively moderately busy hospital.
Thank you. And then just to be clear, that was the part of the agreement that in the scope was maybe brought out as a part of the compromise, those pilon fractures?
Yeah, to be clear, it was agreed upon we had 3 meetings, and it was agreed upon during the second meeting. And then at the end of the third meeting, the podiatrists reneged on that agreement because they were upset.
Thank you for what you shared. Thanks, Mr. Chair.
Thank you, Representative Reddington Hughes.
Thank you for being here today on screen. I just wanted to ask a question as far as the orthopedic surgeons doing surgeries. In the state of Connecticut, obviously, they are the only ones allowed to do the pylon fractures and the ankle replacements. So listening from what you have said before, the state of Connecticut should have better outcomes when compared with other states, correct?
Yes, you'd think.
Just asking, is this true?
I don't have any data that's published to support that. There's been no study in the state of Connecticut comparing our results on ankle replacement versus other states.
Okay, thank you.
Representative Wiehlander.
Thank you, Mr. Chair. Good afternoon. I was wondering if you could explain for someone like myself who is not a clinician in any way, if there was another profession, medical profession that was the equivalent of a podiatrist and what would the orthopedic surgeon, excuse me. Is there another comparable relationship that you could share with us about that?
Well, I take this conversation very seriously, and I think you can all tell I care about it a lot. And I don't want to expand the metaphor and, step on anybody's toes or, what their job is, because we all have very important jobs to do, especially you all. There are other areas with these kinds of overlap, like, for example, neurosurgeons and orthopedic spine surgeons both perform spine surgery. But the difference being they're all board certified by the medical boards as opposed to a separate podiatric board. And they all have 6, 7, or 8 years of postgraduate training as opposed to 3. So there's nothing really all that close. There's no other that I know of invasive complex surgeons that have a totally different standard of care and medicine board overseeing them. Like, for example, if I'm a neurosurgeon or a rheumatologist or an orthopedic surgeon, I have the same oversight and peer review, whereas podiatrists have their own oversight and peer review. So I don't think there's anything that's even close to equivalent to this, because like I said before, there's no one with this substantial of a difference in terms of their training and their standards and their outcomes and data to support that as there is under this question.
Thank you very much. Thank you, Mr. Chair.
Thank you. Can I also clarify something? So I want to explore a little bit, if 43 other states have done this, how did they come to that conclusion? Because they may have had similar data.
I can't speak to how they came to the conclusion. I'm not sure that they went to this depth of thought that we're going into in discussion. I'm speculating. What I can tell you is that nationwide, podiatrists are consistently looking to expand their scope. And this is not a Connecticut only thing. And they've been successful in some states and they've been unsuccessful in other states. And to be honest, I look at this as a very grave safety issue. And that when I talk to my colleagues, and I'm trying to stay out of giving anecdotal, I'm trying to stick to the evidence. But when I talk to colleagues from other states, they have serious concerns about the extent that podiatrists are now doing surgeries up to the level of the knee joint, and in many states. And I don't think that's what we want here. And based off of what I can tell, I would strongly oppose that. And this bill does potentially allow for that, because it allows for dealing with the complications of ankle replacement, which means tibia fractures, which would mean then they can do surgery and put a rod in someone's leg that goes all the way up to their knee. And I don't know how much experience they get. They don't have much transparency when it comes to the experience, but we know that in the state of Connecticut, they're not getting a lot of experience, the podiatric residents, with that. And I don't think that's what any of you would want for your family. And most importantly, we talk about Medicaid a lot. I see Medicaid patients. It's a huge part of my practice. Like, we should not change our decisions based on our standards of care shouldn't change based off someone's insurance. Those are our most vulnerable patients. And expanding for the sake of more choice does not benefit them. In fact, puts them in harm's way. So think about what you would want for your family or yourself.
Again, because of many other states have some of these laws in place, is that how you're looking at the outcomes data and the differences? Is that the piece?
Correct. Sorry, apologies. Yes, that's where this data comparing total ankle arthroplasty comes from multiple other states. It comes from states like California, where they can perform total ankle replacements.
Okay, good. This is helpful. And would you be able to share the studies as well in your testimony, if you want to upload them more, if you want to look at the specific studies, if you don't mind, please?
Absolutely. I'll upload everything.
Thank you.
Thank you for the time.
Seeing no other comments or questions, we appreciate your testimony. The next person on our list is James Icobalis. Welcome. Thank you for your patience with us. Good afternoon.
Thank you. Good afternoon, distinguished members of the Public Health Committee. It's an honor to be here. My name is Jim Macabelis. I'm the Senior Vice President of Government and Regulatory Affairs at the Connecticut Hospital Association. We submitted testimony on 7 bills, but I'm only going to highlight 2 of them today. The first one is House Bill 5198, an act concerning telehealth. I will not detail the importance of telehealth. This committee has long been at the forefront of telehealth and the use of telehealth across the continuum. We support this bill as is. However, we would ask the committee to be bold and to extend telehealth to 2029, to 2031, or even make it permanent. We think it is time to do that, but be clear, we support the extension, but we encourage the committee to think about extending it further. The second bill I want to touch upon is Senate Bill 181, an act concerning emergency department overcrowding. This was a bill and an issue that we spent a lot of time last year talking about. We all know emergency departments across the state of Connecticut are overcrowded. We've had many conversations about the solutions. We know the solutions are many. There isn't a single bullet that will solve this issue. This working group is doing, I think, terrific work, and they're looking at a variety of different issues. They're beginning to look at prior authorization, which impacts emergency room overcrowding. The behavioral health crisis in Connecticut for both adults and children. We know that they will look at data collection. That's what this bill provides for. And we believe that data collection will be part of this solution. However, we encourage the committee to wait until we get the full list of recommendations prior to acting upon one or another. Now, why do I say that? I say that because we know that when we look at the issues that I just raised, whether it has to do with behavioral health, whether it has to do with prior authorization, or maybe even has to do with increase in Medicaid rates, that we can keep some patients from going to the emergency department because they have a primary care physician and have care in the community. Each one of those is going to have a financial impact. And knowing where we are when it comes to the budget, I'm going to go from here to testify in the Appropriations Committee, and I'm sure your colleagues are all going to say the budget is tight. We can't do everything we want. We believe we should have the full array of recommendations before us. And let me say that again, we think data will probably be part of that solution, but let's have everything in front of us as we go forward. Also, when we look at data, I found the conversation, and I have to tell you, the chairs of this working group I think are really doing a great job in beginning to look at all of the issues. That we know that CMS through CORE, which is works out of Yale New Haven Health System, is looking at creating data reporting requirements on the federal level. We would hope that they would be aligned, and I think it's terrific that there's a member on both who's doing work on CORE as well as part of this working group. But one of the things that I think would be concerning is if they are different at all, and we have 2 separate reporting requirements. So I'm not saying that's going to happen, but as we look at waiting until we get the full list of issues, one of the benefits will be, we think we know where the federal government will go, and we may want to look at other things, but not make them different and conflicting. Because the conversation about collecting data, I think the question from Representative Zufkis was, is it flipping a switch or is it hundreds of hours? And we don't know where it falls, but it falls somewhere in between then. So we're saying, let's keep the work that we're doing, that this committee recognized it was going to take some time when we get the full list of issues. And again, let me say, we think data will probably be part of this. We know it will be. But let's make that decision when we have the full list. Thank you.
Perfect timing on the dot.
I can see Kathleen's name come up and I know to stop.
Yes. I have a couple of questions. For the telehealth, the reason we were looking at this from a 3-year perspective was because it needs some tweaking. Both Representative Christine McCarthy-Vahey and I have been meeting with a number of people and our ranking members who do want to tweak the telehealth bill. Because it's a short session, we actually timed it for 3 years to be in a long session to actually make those tweaks and then make it maybe for much longer duration. So there are some weaknesses in the existing system, and that was the rationale. But I hear you when you say that.
I think if the committee and when the committee gets into those conversations about tweaks, we would clearly want to be part of that conversation as well.
Perfect.
But some of our concerns we know are being addressed on other issues related to data privacy and reproductive health and gender affirming health. So we're solving some of them over here, but you're right, we do need to add them all together.
And the second part that you're talking about, the overcrowding. So my sense is that in the last year, when we started the conversation, even in the middle of the last session, earlier than the last session, we have started to see worsening of the position. And then the longer we stay the course, the more complex it's going to get. And if we can actually start to, from the looks of it, relatively speaking, a low-hanging fruit on getting data, we will save ourselves 1 year of a plan in place. It's almost like you can't wait forever for something that's impacting so many, all citizens of our state who have to go to emergency room for emergency. That was the rationale to start to have this conversation now.
I appreciate that, but I would ask that if we're going to do some low-hanging fruit, I think all of us around the table can find some other low-hanging fruit as well. Fixing the prior authorization system, looking at ways in which we can provide the behavioral health services in the community pre and post hospitalization, increased number of beds. I'm just worried about doing this in isolation and thinking we're going to solve the problem, because because I think we all know they are overcrowded. And I think we're also concerned that as we look through the list of where the state, let me back up. I'm not sure. I think we're concerned about having the chairs and ranking members do the magic that they can do and find funding for this, because we think it will cost funding, and then be sort of behind the 8 ball that we have to find additional funding next year for other things. We just think it may be cleaner to do it all at once, but I understand your point.
And again, the issue comes down to is that if I understand CHA's position, you feel majority of the issue is throughput, because the insurance and the transfers and the bureaucratic process between the insurance and beyond is resulting in the hospitals not being able to be as efficient, because you need to discharge patients, and the discharge process requires the insurance to approve, have enough beds for rehabilitation or long-term care or home environment and so on. And that's part of the throughput weakness that is in the system. That's the perspective that CHA has, and you feel that's the majority of those cases.
No, I don't think it is the majority, but it is one of the issues, right? And we know the others are related to behavioral health.
Yes, I agree with you. So that's very helpful. Representative Zupkus.
Thank you, Mr. Chair. Thank you for coming today. I do hesitate when it comes to the data, not so much about giving up the data for the study, because everyone wants data and that proves what needs to be worked on and fixed. But I am concerned about the time. And if it is a flip of a switch, that's very different than it taking time, hundreds of hours, as I said before. On another committee I sit, we did data and it took people hundreds of hours. And so I do get concerned about that, how long the data will take when we know we have nurses shortages, all of these things. So I am interested to see how all of that plays out. But you mentioned federal timing. What do you know what the federal timing is for them to put these into place? Because I agree with you. If we create something and then the federals comes out with something different, then we have to fix it and more time and money.
I don't know when they are expected to come out with their final results, but I do know, and I and I do agree with Dr. Moore's comment that the comments, as the federal government does, they seek comments. And that period is closed. So now it's going to be taking all the comments and pulling them together. I'll see if I can find if there's any information on exactly, or maybe one of the other individuals that come up after me will know exactly, but they put it out for comment, and then now they're going to accumulate and review all the comments.
Great, thank you.
Thank you. Representative Parker.
Thank you, Mr. Chair. Thank you, Jim. I want to try to understand the process and draw out the opportunity for where collecting this data plays into that. So as we've been hearing, I think it sounds like everyone appreciates this problem. We can think of it in our own lives, from our family members that have had to be in the ED, or from the professionals that we've heard. So there's no doubt. We want to come up with solutions for that. My understanding is that the working group is tasked with trying to come up with some proposed solutions that we can put in place. Furthermore, my understanding is that getting this data is actually critical to getting to those solutions at the endpoint. So the opportunity to ask for and get that data now informs the working group immediately, so that by January 1 of next year, they're not just saying, hey, give us this data and then we'll come up with solutions later on. It's let's get the data as soon as possible, so that, to Dr. Anwar's point, we could try to come up with some of those, we can try to deal with the issue as soon as possible. So can you speak a little bit to your sense of, does the working group have what they need to come up with solutions now, or do you think that there's a role for that data to play sooner rather than later? And am I understanding that correctly, that we want to get to solutions, but we're just not there yet because we can't even appreciate the problem as it exists? Does that make sense to you?
Yeah, no, I understand your point, which is, don't we need the data to give us the solutions? I think that you will continue to hear when we talk about this conversation, we know what some of the solutions are, right? So we can start on those just as easily as we can start on the data piece. I think that we don't yet know what the data request is going to look like, right? The Department of Public Health would be tasked to working with under this bill, tasked to working with the working group in order to create the data, how it should be submitted. My guess is this bill is going to come out of this committee, and we're going to hear from the Department of Public Health that it's going to have a fiscal impact because it's not in the budget. They're going to require some resources in order to get there, that it's not going to be a flip of the switch to begin the process in May when this bill is signed, or June when this bill is signed. We're going to be down toward the end of the year, which is when the final report's coming anyway. So I think that's a concern, because everything, when we're at the beginning of the public hearing process, anything that's not in the proposed budget will come out with an added cost, and that the cost means they need additional resources or additional personnel. It's not simply going to be, okay, here's the document, and here's the information that must be collected. The department is tasked here with working with the working group, and pleased to work with an association of hospitals to begin to craft all of that. And my guess is it's going to take us toward the time frame when the final report's going to be done. So that was also part of our thinking of, and then let's then outline it all together, and then take a real strong push at the beginning of the biennium and look at the Medicaid rates, and look at prior authorization, and look at behavioral health. This committee in this legislature did significant work on children's behavioral health, but we all know it's not enough. We all know that we need more beds. We need more community services. So that is also low-hanging fruit. I just think together we will have a more complete package.
Thank you for that. Mr. Chair, can I ask one more question? I'm asking this time. Thank you.
And you're looking at me too. I like it. Good.
Thanks for that, Jim. That makes sense to me. I suppose a response would be, if it's going to take us 6 to 9 months from when we ask for it to get it, then we might there's an argument to be made to start that clock sooner rather than later, but your point is well taken about sort of lining up those processes. I can hear that. The other thing I just want to give you a chance to respond to a little bit is the nimbleness of a potential system here So I'm hearing that if CMS puts us in a different direction, it might be a lot to get up. And if we've gone down this path to have to go over here, I have no sense of how nimble our ability is to jump over there. I'm wondering if we can use, I would like to think that if CMS says you should be collecting this also, then it's easy enough to add that in. But to my colleague's point, we don't want to take a whole bunch of time. Can you use the, as an example, what you had to deal with during COVID-19 and the immense amount of data that was being collected and reported on in what I think was a pretty nimble way? Is that a reasonable, as an outsider, I look at that and I say, man, if they could pull this off, it should be easy enough to get this pretty straightforward data. Am I misunderstanding that?
What, I think it all goes to what we're going to collect, who's going to collect it, who's going to report it. A lot of the work, it was sort of all hands on deck. We worked with the hospitals and did some at the Hospital Association for the state. The state did some. Some was required to go through the federal government. And then when we started to collect issue data, we had to revamp what we were collecting in the state because the federal government was doing it. It all depends on what it is and how it is collected and how is it collected in Manchester versus Yale New Haven. They're two completely different types of ED settings. So we don't really, I mean, we have an idea what it is, but we don't know what the it is on the federal side. What I've learned going through COVID was that when everybody pushes everything else aside and focuses on what they have to focus on to get done, we can do remarkable things.
Thank you.
Representative Christian McCarthy.
Thank you, Senator Anwar, and thank you to Jim. Thank you for being here today. And this whole conversation is so important, and we appreciate you continuing to engage in that. I've had a tremendous opportunity as part of the Milbank Fellows Program to interact with colleagues from around the country, other Medicaid medical directors, public health leaders from other states, and brought this up to them in the past couple months in conversation. So as we often do, and I know you consult constantly with colleagues from around the country, in your experience or knowledge, are you aware of what kind of data collection is happening in other states around the emergency department crowding? Because this is an issue all over. And I have heard that clearly from all of them as well.
I hear what you're hearing and what your families are hearing and what your constituents are hearing. We hear it, long lines in emergency departments. So we are doing, I should put it this way. I'm reaching out the same way that you have been reaching out to my colleagues across the country to find, is there another state that is ahead of us in beginning to collect this data? I don't have that answer yet, but we have done the same thing to say, okay, who's out there and who's collecting it and how difficult is it to collect? What are the lessons that you have learned? I don't have that information yet.
Okay, thank you. I do know that I can't remember off the top of my head which states, and I know I had some conversations, and I'm happy to connect both you and members of the task force, the committee, to that, so we can see, obviously can learn from other states. We all think differently about things, to reference the earlier comment, so I think it's helpful. Thank you so much.
Thank you.
Senator Marks.
Thank you, Chair. Thank you for being here. It's good to see you. So I just know that the workforce in emergency departments are just so burnt out. They're so overwhelmed. They've just had 3 years. That's so hard. And it's just going to be hard forever. That they're just looking to us for answers. They're looking to the legislature. They're looking to public health. Please help us. Please do something. So although I understand you waiting for the task force, although I was just reading some testimony, I guess there was a task force in 2006 that nothing ever happened from that task force or working group, that wouldn't this be such a simple way? We know we're going to need we know we're going to need these numbers, that it certainly can't hurt by getting this data now before all of the task forces
recommendations have been implemented, isn't this a little bit helping our workforce and helping those working so hard in the emergency department to say, we are listening to you and that we are going to get this data? So then when we do implement what the task force says, we're already a little bit there. Do you think that would help the spirits, let them know that they're being heard? I don't see how it can really hurt. I think just by taking care of the staff a little bit, I think it will help.
I think that you will see in the testimony, there is testimony submitted that there is not unanimity among the emergency department physicians about the collection of data. Though I will say to you, going back to Senator Onwarth, you will probably see a majority of the emergency department physicians supporting this. However, there are some that will say it is going to be an additional burden and we can't, and we shouldn't do that in isolation without solving the problem. My point, and I tried to make it a couple of times, is we think that at some point the collection of the data is going to be part of this. But if we're going to have limited resources and the state is going to have some fiscal impact on this, we'd like to have it in context of prior authorization or add prior authorization changes to this, right? We know that's a problem. You know that's a problem, right? Wouldn't that be a great morale fixer? Maybe even more than collecting data. So, I mean, I do think it is part of the conversation, and to have places where an adult or a child can be discharged to for behavioral health. I think that'd be also, so as I said, I think it's part of it. We think it's going to be part of it, but I don't want to give the impression that we need to have the data to solve this, because we know what some of these issues are. And if we're going to start to solve them, let's solve them.
I hear you. Prior authorization, I would love to have a huge bill about prior authorization.
I know you would.
I think you know that. And I think that maybe the bill should also say that all insurance companies need to work 24/7, including weekends, just like the healthcare industry has to work.
Indeed.
So maybe we can add that into the bill too, Senator Anwar. So thank you very much.
Thank you. Senator Gordon.
Thank you, Mr. Chairman. It's good to see you today, and I appreciate all the work that the hospitals do here in Connecticut. Have you looked at, or has the Connecticut Hospital Association looked at what they do in Massachusetts? For example, I know that the Center for Health Information Analysis gets quarterly data from emergency departments, and Massachusetts certainly is facing ER overcrowding and boarding issues just as bad as we are and many other states are. In fact, it's not uncommon patients in emergency rooms in Massachusetts get transferred out of state. And I can attest to that personally, that happens on a daily basis. But they do get data submitted every quarter on a whole host of things, payer mix, demographics, a lot of different stuff. And I don't know if they actually are also, through that quarterly data provided to the state and the working groups they have, getting data on emergency room boarding issues. Have you liaisoned with the folks up in Massachusetts to see exactly what they're doing? Because if they're doing stuff, and they tend sometimes to be a leader in how they set up some of their processes, and I give credit to former Massachusetts Governor Baker, who understood healthcare issues very, very well, given his prior career before he was governor. Instead of reinventing the wheel here, it'd be interesting to see what a state which has a huge healthcare complex and footprint in Massachusetts is actually doing with its quarterly data to the state.
Yeah, I'm gonna circle that question, sort of circle around it, if you will. We know that Massachusetts does do some reporting. I can't tell you exactly what it was, but I know you're right. They also do a significant amount of reporting on the boarding in emergency departments and the issues related to that. So the data hasn't solved that. They're still also dealing with the boarding issue. they're still having those issues in addition to having an agreement that waives prior authorization. It may have been from the beginning of the year for a couple of months. So we know there's a lot of different factors in relation to this. So as I answered Representative McCarthy-Vahey's question about reaching out to my colleagues, we always reach out to New York and Massachusetts because they are clearly sort of on both sides of our borders, and we do follow them. So I don't have a direct answer, but I know they do some reporting, but I also know they still have a boarding problem, and they're even trying to deal with the prior authorization. So we have to come at this in a variety of different ways, and we simply don't want data to be the answer and think we've solved this. And I think by doing it sort of in whether it's in piecemeal or in stages, we're just concerned that that could be the result.
Thank you. I just wanted to, Jim, if you can tell us, and I know a little bit about this, but this is a beautiful success story. When our children were waiting in the emergency rooms for a very, very long time, the Connecticut Hospital Association has come together and they have created a dashboard of how many children are waiting, how many beds are available, and in trying to do a statewide coordination of care, which is nothing short of heroic to be able to get the children to the best place for the best treatment. And you collected data for that and you're coordinating statewide. And when you started to collect, you've been able to make a very big dent in that issue. Can you explain a little bit about how you have been able to do that with DPH? And
this is probably about a year ago, maybe more than a year ago, when we all read the newspaper articles about the increased number of children showing up at Connecticut Children's with behavioral health issues and their need for beds, and began to work with the state, and we became sort of the incident command, and it goes on today. My colleagues, Karen Buckley and Brian Canoyer, every other week on a Friday morning have conversations with Connecticut Children's and Yale New Haven Health, and then connect back in with the Department of Public Health. And we create information, and the state even provides information about the beds that are available. But I'll tell you, a lot of it is, we know Connecticut Children's has a backup in their emergency department. It is picking up the phone, can anybody help? And it's really a lot of that legwork, which is okay. And we know that the opening of the beds at ECHN had a significant, so it was a significant relief valve. And that's how we know we've made some progress there. But it's constant work. It's constant understanding where the beds are in the state, who has the ability, especially on the children's side, because there are only a few hospitals have inpatient children's bed. But it's really to pick up the phone, to implore, to plead, does anybody have any room so children aren't waiting in the emergency department? So it's a combination of things, and we provide the information to the state every day, and the state has information about their beds every day. But what we know, notwithstanding if the numbers are 2 or 4, is we need more. We need more behavioral health beds. We need more services so children don't need behavioral health beds. We need more services post-inpatient so they don't go back into crisis. But thank you very much for that, because I know my colleagues and the colleagues across the state do a lot of work on that, because it's so vitally important.
it really has helped our children in many ways. So thank you so much for your testimony. Seeing no other question or comments, we appreciate you and your thoughts. We'll keep that in consideration.
Thank you.
Brian Lynch, I do not see them online, and I still do not. But I have next is Dr. Robert Brody. You're on, Dr. Brody.
Hello. Hi, chairs, Anwar, McCarthy, Vahey, ranking members, Clarity, Tetra, and Sumners, and members of the Public Health Committee. Thank you for raising Bill 177. I am Dr. Robert Brody. I'm the president of the Connecticut Naturopathic Physicians Association. I'm a naturopathic physician practicing in my insurance-based practice here in Newtown, Connecticut, and I'm a cash-based practice in Fairfield, Connecticut, where I work with an integrative allopathic cardiologist. a board certified fellow from the American Board of Naturopathic Gastroenterology. I'm here to state my opposition to Senate Bill 177, an act concerning authorizing naturopathic physicians to prescribe medication. After I assumed the association's presidency, I met with the Department of Public Health and members of the Public Health Committee to better understand the pursuit to scope expansion for medical professionals in the state. While we know a major increase in scope of practice will greatly benefit countless patients in Connecticut, we also more fully understand the process it will take to make it a reality. Unfortunately, the far-reaching request of this bill as written may not be a successful approach. We greatly appreciate the committee having the conversation into exploring the possibility of expanding naturopathic scope, and in particular, Senator Alston championing this bill on our behalf. However, we respectfully ask the committee to consider instead a small change to scope to allow naturopathic physicians to administer vitamin B12 intramuscular injections. Our current scope includes oral administration of natural substances, and we feel that increasing access to therapies via additional administration routes, injectable vitamin B12, would greatly benefit our patients and our practices. Once again, I thank you for your time and consideration for the future of naturopathic medicine here in Connecticut and your service to our state.
Thank you so much for your testimony. I just wanted to make sure I heard you correctly. So you're saying you're interested in the vitamin injection intramuscularly, and you're not, as an organization, do not want the antibiotic component. Is that a fair understanding?
Yes, at this point, we're just asking for IM or intramuscular injection of vitamin B12, prescribing it, dispensing it, and utilizing in our patients.
Okay, we appreciate your testimony. Yes, Representative D'Amico, please go ahead.
Thank you, Mr. Chair. So I have to do my usual thing of asking the obvious question. Dr. Brody, from whence did this proposal come, if not from your organization?
This proposal came from a champion of naturopathic medicine, Senator Alston, who I believe is in the eastern side of the state. And she's been a supporter of us for many years and still is. We just had, we've been through this process so many times over the last 10 years that I can remember that it just keeps getting pushed down, pushed down, pushed down. So we're going for the low hanging fruit at this point, something that we're overly qualified via our training to administer for the patients of the Connecticut.
Thank you, sir.
Thank you. Yes, Senator Gordon.
Thank you, Mr. Chairman. Dr. Brody, thank you for testifying. I just want to make certain I'm clear. I did read your testimony. So to be clear, this is not a bill that for the naturopathic physicians, the Connecticut Association is proposing. You're not wanting to do, as an organization, to propose anything beyond an intramuscular B12 injection. Is that correct?
At this point in time frame, we are looking for that low-hanging fruit. So we're in opposition of full scope of practice, knowing full well that after our conversations with the Department of Public Health, that it will most likely not succeed. So we're just asking for B12 IM injections at this point.
Thank you. And just one quick follow-up question, if I may, Mr. Chairman. And I'm assuming, and I know B12 treatments well, ordering a lot for patients. I'm assuming that through the training to be a naturopathic physician, one understands the difference of when to use oral versus when to use intramuscular. Is that part of the training?
That is part of the training. As you know, Dr. Gordon, naturopathic medical students complete a minimum of 1,200 clinical training hours before residency and are direct supervision of learning hands-on techniques like venipuncture, IV, and injectable therapy. By comparison, MDs and DOs complete about 1,700 hours and nurse practitioners complete about 1,000 hours. Additionally, licensed naturopathic physicians are required to complete between 100 and 220 hours of nutritional education, depending on the school they graduate from. And this is significantly higher than the allopathic and osteopathic nutritional curriculum, between 0 and 70 hours, and nurse practitioner nutritional curriculum, which is between 10 and 19 hours on average.
And just one quick question, if I may, and then I'll be done. Is there a dedicated part of training on pharmacology itself? For example, as a doctor, I had to take an entire year in medical school, and then my 3 years of residency training and my 3 years of fellowship training, that's 6 years, pharmacology was all throughout it, day and night. I just want to understand the training in school, and then I don't know if there's a residency program to be a naturopathic physician regarding pharmacology training and management of medicines.
Yep. Thank you very much, Dr. Gordon, for that question. Yes, there is training in pharmacology from day one of medical school, depending what school you're in. So we have a full year-long course of pharmacology. We also have year-long courses in botanical medicine and vitamins and minerals medicine throughout our training as well. 4 years of medical school, that's post 4 years of the undergraduate degree. And then later we can go ahead and do residency training and fellowship afterwards.
Thank you. Thank you for your testimony. Seeing no other questions or comments, we appreciate you. Oh, sorry. Representative Daphne, sorry about that.
Thank you, Mr. Chair. And I just want to clarify, so what you're asking us to do is to tweak this bill and make it just for IM B12. Is that correct?
That is correct. We want IM to be able to prescribe it, administer it, and use it. So yes.
Thank you.
All right. Now we want to thank you again. Thank you for waiting and spending your time with us this morning. Next person on our list is Dr. Hakeem Zargar. Welcome, Dr. Hakeem.
Thank you so much, Dr. Anwar. Good afternoon, Senator Anwar, Representative McCarthy, Vahey, and distinguished members of the Public Health Committee. On behalf of more than 240 orthopedic surgeons of the Connecticut State Orthopedic Society, I wanted to thank you for the opportunity to share the Society's testimony. I was originally going to talk about Senate Bill 177 about the naturopathic physicians to prescribe medications, and we were going to oppose that, but it sounds like it just got rescinded, and I'm not sure what to say about the tweaking just because it's not my area of expertise. So I think IM injections of B12 might sound benign, but I'm not sure if this is something that basically will end up causing more scope creep. So when he's describing that, oh, we're just going to go for the low-hanging fruit, does that mean next year they're going to come back and say, okay, now we want to give IV antibiotics for this treatment of this, that, and the other, and then the next day we're going to do IM injections for Botox for people with CP. So I think just having heard this and thinking on my feet, I would still oppose that on my own behalf, not on behalf of the Orthopedic Society, because I haven't had a chance to talk to my colleagues about how they stand on it. But I'm Mariam Hakeem Zargar. I'm an orthopedic surgeon, solo practice in Torrington. I happen to also be a foot and ankle subspecialist. I did hear some of the testimony earlier from Dr. Bloom and Dr. Peden, and I just wanted to clarify a couple things about foot and ankle surgery that came up. One is the idea that there's no access in the New London area. There is Dr. Emily Vafik and Dr. Arkand, both practice out of Bacchus Hospital, and Dr. Vafik actually practices out of Lawrence and Memorial. The hospital has employed podiatrists, and the reason these patients end up in Rhode Island is because the hospital will self-refer the patients to their own employed podiatrist and not send the patient to the most highly qualified person in their facility, which is Dr. Favik, who's a orthopedic foot and ankle trained surgeon. So the patient ends up going to Rhode Island when there's a perfectly capable doctor right there in their own system that they just prefer not to refer to. So I think just to reiterate also what Dr. Peden said earlier about total ankles, these are rare cases. I practice in the Northwest corner. I have patients. I draw from the entire Northwest corner of Connecticut, Southwestern Massachusetts, and the eastern side of New York. That I have a very large practice base. I'm a foot and ankle trained orthopedic surgeon. Because I'm practicing in a rural community, I do a lot of general orthopedics as well. So foot and ankle is anywhere from 30 to maybe 40% of my practice. So I'm only seeing about 2 patients a year who are candidates for total ankle replacement. It's so rare that I don't feel, as an orthopedic surgeon, total ankle, and I'm trained in total ankles, was trained in my residency and fellowship, I don't feel that I do enough of these cases to be any good at them. So I don't do them. I refer them to my colleagues in Hartford who do more than 10 a year. And that is kind of what you need to do to be proficient and good at these procedures. The podiatrists are saying, when we were in the scope of review, the DPH scope review committee meetings, they said, oh yeah, we're not doing them. We haven't done them in Connecticut. We're just going to go take a weekend course and learn how to do these cases and start doing them on patients.
Excuse me, doctor, but your time is up.
Okay.
Thank you.
I'm happy to take any questions.
Thank you for your testimony. So I think you're finishing your sentence up about doing a weekend course, because that doesn't sound right.
No, it isn't right. The total ankles have traditionally had a very high failure rate. The technique for doing it is very complicated, and it really needs to be done by someone who's doing a lot of them every year. If you're only doing one here and there, you're not going to be good enough at them. So even I don't do them, and I'm an orthopedic surgeon, foot and ankle trained. I don't do them. I just don't do enough to be good enough at them. The complication is potentially amputation. So if I personally, like Representative D'Amico was saying earlier, the DPH needs to come to some sort of consensus and understanding and help the legislators figure out what's the right thing to do here. And I think patient safety is paramount. I can get paid to do a total ankle, but if the complication of that could potentially be someone getting an amputation, I don't want that on my hands. I don't think a legislator would want that kind of a decision on their hands, as somebody may have, ended up with an amputation because we gave people scope of practice expansion that maybe they didn't deserve or don't have enough training to do. So, and the other issue with Medicaid and access really has to do with the fee schedule. The orthopedic surgeons have not had a rate increase in the fee schedule since 2007 or 2008, whereas the podiatrists have. So they end up seeing more Medicaid patients maybe than we do. I don't know if they do or not. They claim that they do. I have 12 to 13% of my practice in general is Medicaid. And on the months that I take a week a call, it's closer to 25%. So I definitely see a lot of Medicaid patients, and I don't turn people away because of their insurance status. So, but the Medicaid population does overutilize the ER, and that's something that if we fix the fee schedule, that will help patients get timely appointments in the regular doctor's office and not have to go to the ER. And the other issue is transportation. If somebody doesn't see a patient in their local area, if the Medicaid wants to pay me $40, New Milford doctors say $40 to see a patient with Medicaid. And if that doctor doesn't see the patient, the state will pay for a cab ride $100 each way to come to Torrington. So that's $200 so they can pay me $40 to see the patient. It just doesn't make any sense. So that's something I know is in the Appropriations Committee. I've testified there as well. But those are the things we have to fix. These are multifactorial big issues. So I think expanding scope of practice, is not the answer for access.
We do have another couple of questions. My co-chair has a question.
Thank you. Thank you, Senator Anwar. And thank you, doctor, for being here with us. So a question we heard from a fellow orthopedic surgeon earlier who talked about agreeing with the expansion to include the foot amputation. And is that your testimony as well, or would that be your position as well?
Right. So I was on that scope review panel as well. And the agreement, I'll just correct Dr. Peden, and maybe he didn't remember the details of that particular part. So I think what the podiatrists were asking for was total foot amputation. Total foot amputations means the ankle is a hinge joint. There's the tibia, which is the leg bone, and then there's a hinge called the talus. So the foot ends at the talus. So disarticulating or taking apart the leg bone from that ankle bone, that would be a total foot amputation. Take the whole foot off. That is not a procedure. That leaves behind the part of the hinge with two nubbins on the side that you can't walk on. So that is not a described procedure to do. So the agreement was, right now the podiatrist can go up to what's called the tarsal metatarsal joints, which is kind of at the top of the arch in the midfoot. And the agreement was that they could go one joint up to what we call the talonavicular and the calcaneocuboid joints, also known as Chopard's joint, that would be a reasonable functional type of amputation. It is not a reasonable thing to do a disarticulation of the ankle. That's just not a described procedure. So the idea was to let them go a little bit higher than where they are currently. And that was thought to be a reasonable thing to do. That's definitely within their scope of practice, would be considered reasonable to include in their scope of practice, given all the diabetic patients that they're taking care of.
Thank you. Thank you for that clarification. I appreciate it. I will note that you described earlier a conversation that talked about a weekend certificate. And I think, as I sometimes say here, it's best to let others speak for themselves, but I hear that's what you're saying is that's what you heard during that process. Is that correct?
Correct, because none of the podiatrists that are currently practicing in Connecticut, unless they train somewhere, I think someone mentioned there is a doctor who trains somewhere else to do total ankles. The ones that are currently practicing in Connecticut, who've been here for years, who are not new from somewhere else where they trained to do these procedures, do not do these procedures. They're not doing them. So they don't have the skill set to do them. So all of these podiatrists are now going to go somewhere and do a weekend course that's funded by the implant company, because all they care about is selling their implants. So they're going to fund a course for the podiatrist to go to practice on a cadaver. And a cadaver is not someone with end-stage arthritis. There's a lot of deformity when people have end-stage arthritis, and there are a lot of nuances to making this ankle joint work. It is not in orthopedics, I hate to say this, but a total knee or a total hip, those are easy cases compared to an ankle. Total ankle is a very complicated case that, like I said, even I don't do them because I don't feel like I do enough of them.
Thank you for that. And I have a lot more appreciation about how complicated ankles are, not just from this testimony, but from my own life in the past 2 years. I will say, I do think it's important to that we speak to our own intent rather than others when testifying. I really appreciate you taking the time to be here with us today. Thank you, Mr. Chair.
My pleasure.
Thank you, Representative Zupkus.
Thank you, Mr. Chair. Just a quick question. I heard that in 44 other states, this is allowed. And I'm curious, have you heard of any incidents or situations in other states?
So that would be anecdotal things that I hear from colleagues, and I don't really want to rely on any anecdote. I think Dr. Peden has already said that he's going to forward the studies that we have access to that show the complication rate, the increased cost associated with podiatric care. I don't have to go to other states. We gave podiatrists increased scope of practice to include ankles. And, I've definitely seen examples of cases in our own state where a podiatrist has had taken 5 hours to do an ankle fracture that an orthopedic surgeon would probably take 40 minutes to do. And then afterwards, the whole thing fell apart and his partner orthopedic surgeon had to come and fix it, who's a sports guy, not even a foot and ankle trained guy. So these are so simple that, even general orthopedic surgeons take care of ankle fractures. So we expanded scope of practice, and I've already seen complications of that personally. So I don't have data on it. Nobody's collecting data on these things, but we don't need to go nationally to know that. With respect to ankles and pilons, we will give you that data. That'll be forwarded to you.
Thank you, because I had heard it before and understand there's always a bad case of something somewhere. We can all find
Right.
that. But if it's done
Yeah.
in any other states, I was just curious is it 40% of bad surgeries? But we'll find out later. So thank you.
Yeah, you're welcome.
Thank you. I think what I've gathered so far, Dr. Hakim Zarkar, is that there are not enough of those surgeries around, and because there are not enough of these surgeries around, people need to do as many as they can to keep up with their skills, and that is one of the fears that is there amongst various other things.
I don't think that's really it. I think the biggest issue is that the podiatrists just don't have the training and skill set to do this. I mean, they try to present themselves of having these extraordinary skills because that's all they do is foot and ankle. But there is so much to know about bone health, the musculoskeletal system, and how everything works. And all the training that we do with the rest of the body transfers to the skill set that transfers over to foot and ankle. You know, I do hip fractures, I do broken femurs, I do periprosthetic fractures. I'm doing all these very complex things. So, you know, doing some of the foot and ankle cases are very simple to me because I'm doing so many more complex things that I have a very broad skill set. So doing a metatarsal fracture, an ankle fracture is a fairly easy thing compared to some of the other things that I do. So they're just doing foot and ankle cases. And in fact, they can get their training for the rear foot, hind foot ankle surgery without ever doing a single ankle case. They just
Thank you
have to
so
do a
much.
certain number of cases, right?
Thank you so much. We appreciate your testimony. Thank you. We see no other questions or comments, so we'll move to the next person.
Thank you so much. Thank you for this opportunity. Have a good day.
Okay, you too. And I have Scott Ferguson, Dr. Scott Ferguson. You're on. Welcome.
Yes, sir. Thank you. I'm Scott Ferguson. I'm a practicing physician in West Memphis, Arkansas. I'm a member of the American Medical Association Board of Trustees, a recovering state legislator who served on public health and was involved in many of the same issues I've heard this morning: telehealth, emergency room, overcrowding, prior authorization, scope of practice, tobacco settlement money. I applaud y'all for taking this all at once. We got it just fed to us as it came to the legislature, and y'all are taking a good step, I think, in doing this ahead of time. I know that Dr. Brody was going to pretty much remove everything but the B12 injection, but I think I need to go ahead and give you my testimony about why naturopaths should not have prescribing privileges, because these things come back year after year, as you know. Listening to the podiatry, I see in other states where they now want to come to the wrist and get away from the foot and ankle. So you'll be facing those. But to prescribe safely, a practitioner needs robust clinical training, a comprehensive education in pharmacology. And as you examine whether to extend the authority to naturopaths, let me urge you to recognize that a naturopath's education is distinct from a medical education. We implore you to question whether naturopathic education programs adequately prepare them to prescribe medications. I read the bill, and the first part of the bill, it says exactly what I think naturopaths do. They use natural things and not oral medications. So they complete 850 hours of patient care during their 1,200 hours of training, where a physician gets 12,000 hours or more. Accreditation standards impose no requirement that students see patients of any particular age or illness or condition as part of their training. Well, the naturopathic curriculum focuses largely on non-medical content. Accredited programs do include some coursework in sciences. However, the scientific content is muddled with principles and therapeutics that lack a foundation in medical evidence. This calls into question the integrity of the pharmacologic content where it is taught. The consequences of prescribing done incorrectly can be dire. We hope the legislature will take seriously the risk patients will face should practitioners with insufficient training and experience be trusted with a prescription pad. We urge you to oppose Senate Bill 177. And if I have any time left, I will let you know that Connecticut is my new best favorite state. They just took my son-in-law to Yale Law School, #1 law school in the country. So we're very proud. And I expect to spend a lot of time up there.
Good. Thank you. You're very welcome to come here as well. And this time of the year is probably not as fun compared to Arkansas, but I have one of my colleagues has a question, Senator Gordon.
Sure.
Thank you, Mr. Chairman. Dr. Ferguson, thank you for testifying. Just so you know who I am a doctor, and I've been an American Medical Association member for going on to 34 years. So I do appreciate the work you do on the Board of Trustees. I know it's a heavy lifting and a lot of work that you do, but thank you for taking the time to testify. I just wanted to make certain I was clear on one of the points of your testimony, because I think that is important in general when we're talking about prescribing for naturopathic physicians, even though now it looks like it might just be for B12 injections. But you had made a comment about that the training for someone to become a naturopathic physician and the training afterwards, especially when it gets into pharmacology and medication management and decision making for medication treatment, is different than where one stands to be a medical physician, such as an MD or a DO. If you don't mind just clarifying or highlighting that point, I would appreciate that. Thank you.
Sure. Thank you, Dr. Gordon. Thank you for being a member. The training that a physician receives in pharmacology, I'm a radiologist, so I don't prescribe. But to prescribe, I took 2 years of pharmacologic training to learn internship residency, where you go out and you write prescriptions, you see people in emergency rooms. There's a lot of hands-on training that goes into it. Naturopaths, we have people who have said they can get by with one course in pharmacology and that's it. They have very little oversight of the training. It's 12,000 hours versus 1,200 hours of education, basically. So I think that's quite a difference. And thank you for the question.
Representative Zupkis.
Thank you, Mr. Chair. Thank you, Dr. Ferguson, for coming and testifying today from a Mississippi girl that's mother was born and raised in Arkansas. It's nice to hear that Southern accent. Makes me feel home a little bit. But I actually go to a naturopathic doctor and a regular doctor and take kind of what I want from both. And I hope that of the naturopathic doctors that what they have given me has worked. And so, but I have to pay for it. So I know that's kind of a different issue than what we're talking about now, but I do hope that the minerals and the things that naturopathic doctors prescribe would be covered, because I think it's, I don't think it's right that you have to pay for what they give you and everything else, all these other medicines are covered. So I really just wanted to say hello, and it was great to hear you.
Thank you very much. We think those things ought to be covered as well.
My esteemed co-chair, Kristen McCarthy.
Thank you, Senator Amar. And thank you, Doctor, for joining us today. I'd just like to extend an invitation to come visit when you're here visiting your son-in-law at Yale. We'd love to hear from you and learn from your experience serving as a state legislator, and hope you'll take us up on the offer. Thanks for testifying today.
I would love to come in September to get them settled in. So I'd love to visit with you.
Excellent. Seeing no other questions or comments, we appreciate you being here. The next person on our list has been Dr. Arano. Dr. Arano just had to go to the operating room, so we will probably, as soon as he's back, we will try to take him in. Next is Dr. Noah Chinitz. Sorry about the pronunciation. Welcome.
That's okay. Hi, guys. Thanks for having me today. Members of the Public Health Committee. So I'm speaking about the request to increase the scope of podiatric care. I'm a practicing foot and ankle orthopedist. I go to Greenwich Hospital. I do total ankle replacements. I do pilon fractures, a lot of ankle trauma, a lot of foot trauma. At the end of the day, certainly there are excellent and very wonderful and well-meaning podiatrists out there. Some are experienced and well-trained, and I worked hand in hand, foot in foot, with a lot of podiatrists. But I think at the end of the day, it's a matter of training. And the issue, access, we have access. Whenever patients come in with trauma, we take care of them. There's plenty of access for patients to get total ankles, have their trauma taken care of, but the training is vastly, vastly different. Orthopedic training is, first off, it's medical school, which podiatrists don't go to. And then it's 5 years of rigorous orthopedic surgical training. And then in the foot and ankle world, or in general, orthopedists will do 1 additional year. So the foot and ankle path is what we have chosen. And there, total ankles and pilons and any ankle trauma or advanced stuff they're very, very difficult, really difficult. I don't want to oversimplify things. There's a lot to them. I think nuances is even the wrong word. I think there are tons of details that rely on years and years of experience. So these courses offered for a weekend are just not adequate in the least. There's tremendous detail in terms of deformity. There are many considerations with respect to total ankles. So it's, at the end of the day, it's about patient safety. Orthopedic surgeons are the ones who need to be doing total ankles. When I have a total ankle to perform, it's days of preparation, weeks of preparation, tremendous thought into it. It's one of the most complicated surgeries, and it's very high risk. It's a much higher risk than total knees and total hips. The definition of pressure is force per area. It's a very high pressure joint with a smaller implants, and tolerances for error are really zero. Medicine and surgical training is really very much an apprenticeship. And the podiatric world, their training is 3 years. They used to have a 4th year sometimes for a quote unquote hindfoot training, which is even going by the wayside in the first place. And I actually have podiatric residents that assist me for some of my cases sometimes at one of my surgery centers. And even the 3rd year residents, some of them are okay, and most of them are almost just they're not up to speed. Let's just put it that way.
Excuse me, doctor, but your time
yeah.
is.
Okay. Happy to answer any questions.
Yeah, Representative Parker has a question.
Thank you, Dr. Anwar. Thanks, Doc, for being here. Were you a member of the scope review committee?
No, I was not a member of that committee.
Okay, got it. That's helpful. So, and my question then, I'm trying to understand if there's let me say this too to our folks here. So with the scope review process, ideally that will move forward when there's unanimous, or not even ideally, literally there needs to be unanimous agreement at the end of that process, which, as this report shares, was not the case. We heard there was a lot of disagreement there. So it comes to us to see if there is any compromise that could be found to move something forward this year. So I want to get into that a little bit. It seems like from previous folks who have testified, we're hearing that there might not be that much agreement to be found on the total ankle replacement, but the within foot amputations could move forward. So I wonder if you comment on your thought about allowing the expansion for within foot amputations. And then I'll also ask you to speak about the fractures. I'm not keeping up quite on that. I'm wondering if you have a thought on, is there a compromise to be found this year on scope specifically around the fractures?
Yeah, I'll say this, and those are 2 different topics, and they're vastly different topics. In terms of the within foot amputations, there is a lot to within foot amputations, but I think that podiatrists probably can do a good job with them, and I know that they and vascular surgeons do within foot amputations. But the issue, of course, is as you get more proximal, so as you get more into the midfoot and hindfoot, they become very technical surgeries as well, and you're still going to want those done by foot and ankle orthopedists. Now, in terms of fractures, I've seen ankle fractures and pilon fractures that have come to me for opinion after podiatric surgery somewhere else. And it's a very hard thing to study, but I'll just tell you anecdotally, a lot of the hardware implants, it's almost as if these techniques were just made up. I remember one pilon in particular that was such a mess, and you couldn't make heads or tails of what the surgeon had been trying to do. Even ankle fractures, it's a myth to say that because podiatric training is 3 or 4 years of only the foot and ankle, that they should be able to do ankle fractures. I mean, I have I have podiatrists that refer me ankle fractures and don't even know how to speak to patients about them. They just don't have the training. They don't have the training, and ankle fractures can get real complex real fast. Even a quote unquote simple ankle fracture that somebody might think might take 30 minutes and often does. Sometimes you get in there and it ends up taking an hour, hour and a half. But ankle fractures increase in complexity exponentially. And a pilon fractures is sort of a higher energy ankle injury. It's a higher energy ankle fracture. And you only want orthopedic foot and ankle, or maybe orthopedic trauma. Those are two sort of subspecialty fields that can handle those fractures.
All right. Thank you for sharing that. That's helpful. Thank you. Thanks, Mr. Chair.
Thank you. Seeing no other questions or comments, we appreciate your testimony. We move on to the next person on our list. It was number 26, Lauren Gainey. You have not, oh, you are. Good. Welcome. Join us.
Thank you. So Senator Anwar, Representative McCarthy-Vahey, and distinguished members of the Public Health Committee, thank you for the opportunity to submit testimony in opposition to HB 5196, an act expanding the podiatric scope of practice. My name is Lauren Gainey. I'm a board-certified foot and ankle orthopedic surgeon and associate professor of orthopedic surgery practicing at UConn Health. I completed my residency training here at UConn from 2008 through 2015, and then completed a year of fellowship at Mercy Medical Center in Baltimore before returning to faculty here in 2014. In my practice at UConn, I serve the greater Hartford area and beyond. I take care of complicated deformities, sports injuries, and high-level Division I athletes, arthritis of the foot and ankle, patients who have had complications from other surgeries, amongst other things. These are patients and surgeries with complicated pathology beyond what the average podiatrist would see and manage. Additionally, a large portion of my population is Medicaid or underserved patient population. In fact, the most recent numbers quoted to me were that between 30 and 40% of my practice is Medicaid. At UConn Health, I also am currently the fellowship director for the Orthopedic Foot and Ankle Fellowship Program, and I was also the residency program director for 5 years, just recently stepping down last year so I could take on the fellowship role. Orthopedic surgery recruits the best and the brightest of all medical students and is consistently one of the most competitive specialties in medicine. In fact, we just completed our interviews for the 2024 incoming class. We had 800 applications for 5 positions. This highlights the fact that the students that enter into orthopedic residency are at the top of their classes. These are the best trained students, we believe, in medicine, and we get the best and the brightest. Residency is a 5-year process. By the time our residents graduate from their 5th year, I'd let almost any one of them operate on myself or a loved one. A resident only completing 3 years is a very different provider in terms of competence as well as confidence. So I appreciate your time. I know you've heard from many of us. So with respect to your time, I will complete it just with a little bit of that background, but I'd be happy to answer any questions.
Thank you so much. I think my co-chair has a question.
Sure.
Thank you, Senator Anwar. Thank you, doctor, for being here and for the work that you're doing, educating our students to help provide care to all of us here in Connecticut. I am wondering, you are at UConn, you're a professor and you direct the fellowship program. Does UConn educate podiatrists?
We do not. We do. I have 3 podiatrists who are in faculty with me here. I have 1 partner here at UConn and 2 out in stores that I work with, but we do not train podiatrists.
Thank you. Thank you, Senator.
Thank you. I just wanted to also, Representative Cook has a question. Representative Cook.
Thank you, Mr. Chairman, and I really don't have a question. I just wanted to thank Dr. Gainey for the great work she does, and she's been an incredible doctor to my husband. So, and it's great to see her here and testify. So thank you very much.
Thank you, Representative.
Representative Gainey, I just want to clarify. I thought that the best and the brightest became pulmonologists. You said
I don't feel like I should get into that conversation.
All right. Thank you so much for your testimony.
Thank you.
Yes. The next person on our list is Dr. Arma, Tiziana Arma. Welcome.
Thank you. Thank you so much. Good afternoon, Senator Anwar.
Representative Vehi and members of the Public Health Committee. My name is Dr. Tishiana Arma. I'm president of the Connecticut Psychiatric Society, representing 600 psychiatrists in the state. And I'm also the chief psychiatry officer at the Community Health Center Incorporated and an assistant clinical professor at Yale School of Medicine. And I reside in Norwalk. So like my colleague, Dr. Melissa Welby testified earlier, I'm joining you today really to support HB 5198, an act concerning telehealth. And I have really three asks to make this important bill even stronger. One is, rather than an extension into 2027, we're asking that telehealth be covered permanently. You know, my patients still express anxiety induced by knowing that this remains temporary. And I hate to have to tell them that it's not secured when they ask, which they do really often. And also, second, the specific language really securing just something additional to secure voice only as a viable modality for care in psychiatry visits. And then the third is ensuring payment parity and covering voice only visits at the same rate as video and on-site appointments, because if you have a lower reimbursement rate, it really makes it more difficult for psychiatrists to continue that care for patients who are limited to voice-only visits due to various challenges that you all know of, but equipment, knowledge, comfort. And this is really vital because maintenance of voice-only psychiatry visits is really a matter of health equity. So studies have shown that voice-only telehealth modalities are highest used by populations that are rural, Hispanic, Spanish-speaking, Black, those who are 65 and older, and people who are earning less than $25,000 a year. The list kind of goes on: Medicaid, Medicare, VA recipients, and the uninsured. So all of these people really need that continued flexibility because other things are going, sort of difficult in their lives. Being able to have access to the care is so important. So here in Connecticut at the Community Health Center where I work, and we treat over 150,000 patients a year, we looked into our data basically because of what I was seeing with my patients. And what we saw for your constituents all over the state were the same trends as the literature was showing. Spanish-speaking Latino patients and Black both opting more for phone rather than other modalities, more than other groups. And they also, not just that they were opting for it, they were reporting greater satisfaction and quality of care given than other modalities, which I think, actually probably shocked us a little bit. And at least a quarter of them said that they're not able to join by video for whatever reason. It doesn't even mean that they don't have the technology, but they're not able to. It may be that they can't, step away from work in a way that they're going to be able to access internet in that time.
Excuse me, doctor, but your time is up. Thank you.
Okay. Thank you very much. Well, that was actually it. I just wanted to also say that we also support SB 180 and 182. Thank you.
Thank you so much for your testimony, Dr. Arma, and your written testimony was very powerful and helpful as well. We appreciate your insight. I think your point about the digital divide in Connecticut and the access related to that through telehealth is very real, and we'll talk a little bit about that. One of my colleagues, Senator Marks, wants to speak as well, and then my co-chair after that.
Thank you, Chair. Thank you, Doctor, so much for your testimony. And I agree with you 1000% about the voice only when it comes to telehealth. I have helped many a patient get onto the Zoom when they had to, over COVID, when they had to have their telehealth appointments. And the only reason this 60-year-old woman knows how to use Zoom is because I'm a senator. That's because otherwise I'm not sure I would know how to use Zoom. And if I wasn't there to help people figure out, and then they end up getting another phone where because they, their plan couldn't pay their bill. And so then they get another phone and then re-hooking up to that Zoom so that they can have the telehealth is so overwhelming. The anxiety is so hard. And if they don't make that appointment, then they don't get their psych meds, which I think that is what we all have to think about so much, is that they don't get their psych medication if they miss a visit, which I don't really agree with that either. But and then the whole spiral starts all over again. So I thank you for your testimony, and thank you for all you do at the Community Health Center.
Well, I appreciate that so much. And I've sat with patients myself in the office because I've been in the office for over 2 years and they still have continued to opt for not being in the office. But I've sat down with them and started to work through the Zoom, and especially my patients who are Spanish speaking, just Spanish speaking. I noticed that the extra little hurdles, in fact, we found some problems with Zoom where we realized, wait, this part is in English. How can you have this part in English? This is someone who's already opted and says it has to be Spanish. So we've even seen some improvements, but it is very, very challenging.
My co-chair, Representative Christian McCarthy.
Thank you, Senator Anwar. Doctor, thank you so much for your work and for representing the psychiatrists of the state who are members of the society. 600, you said, is that correct?
Yes.
And it's amazing. We have 600 psychiatrists and we still need more. So hopefully we will continue to support that effort. I just wanted to, yes, you're nodding. I see you nodding vigorously. Earlier today, you may not have heard when Senator Anwar was talking with another person who came to testify about the telehealth bill. And very much it is our intent to be able to continue to look at the pieces of the bill that may need tweaking. And the audio portion is one. I will just, in full transparency, as we often always do here, talk about the fact that we know how important this bill is. It is a major priority of this committee. And because of the timeline, we would like to do this bill quickly and early in the session because we understand that patients have made appointments and providers have made appointments, and we want to have that predictability for folks. To that end, we were talking about just making sure that we were keeping this bill as simple and clean as possible with simply a date change. And I say that here for everyone to hear because that clear message allows all of us within all of our caucuses to share that clearly. However, as you're speaking today about this audio portion, I recognize, and I think we recognize the clarity of the differences in access, especially for our Hispanic and Black communities. And this is a real priority for us as a committee as well. So I thank you for taking the time for both the written testimony, as Senator Anwar referenced, but your verbal testimony, and wanted to share that with you as well so that you could share with your colleagues what our thinking is at this point. And we always, that's why we're here. We're here to hear, and we continue the conversations together on our leadership team and with our entire committee. So thank you for that. Thank you, Senator Anwar.
Thank you so much for your tireless work, and thanks for that clarity. I think that is really important. And we definitely at the Connecticut Psychiatric Society would love to be of any help in terms of tweaks down the road. We're here for it all. Thank you.
Good. Senator Marks.
Thank you. Just one more thing, as I was just remembering some of my experiences. You're not allowed to use FaceTime, right? Because then you can't charge for the visit, or you don't get as much money for the visit, which that to me just made no sense. Like, life is just so hard enough that why can't you just push the FaceTime and do a face-to-face visit? Am I correct in saying that?
So two things. One, and I actually wanted to go back to the other one where you were talking about the not being able to get the medications out. I will tell you, when my patient can't make it for their visit, I will bridge them until until I can get them in. But we do want to make sure that we assess them. But in terms of the what modality we use for the visit, it's more about concerns around privacy and things like that. So we use very secure lines. It's a clinical Zoom. It's not the same Zoom that we use, every other day. It's a clinical Zoom. So that's for their privacy. It's not really about whether or not one is getting paid. It's really about the concern around the privacy element.
Thank you. Appreciate that.
No problem. Thank
Thank
you.
you. Thank you so much for your testimony. We don't see any more questions or comments. We'll just say that Can you help us get appointments for our constituents?
Oh, that's my every week. I get sometimes 3 different calls from people and text messages. That's par for the course. And I just wanted to mention 2 things. One is that there are new residencies that have opened in the state of Connecticut. And so we would love to be in conversation about, one, making sure we keep folks who come and get trained here, but just the opening up of new ones is a part of the solution, because last year, 900 different medical students wanted to join a psychiatry residency program, and there wasn't a spot for them. So the floodgates are kind of open, but we've got to have some place to train everybody.
Thank you. Thank you for the comments. And we'll move to the next person on our list. That is Carrie Dyer, should be here. Welcome. Thank you for spending time with us this morning and afternoon.
Thank you. So my name is Carrie Dyer. I am the CEO at Reliance Health in Norwich, Connecticut. We serve all of Eastern Connecticut, providing services that are based in mental health and substance use, primarily through DMIS and DDS. Our very small clinic is purely funded through insurance, so Medicaid typically. So I am here to speak in support, as those before me, of the Act Concerning Telehealth. When this came up in 2021 or 2020, I came and testified on the bill to really encourage folks to look at telehealth and the flexibility that it provides. For when we work with individuals who have chronic mental health and addiction diagnoses, being flexible is critically important. Telehealth reduces isolation, it sustains meaningful connections, and it allows for the provision of treatment despite financial, emotional, or physical barriers. Telehealth services provide a contemporary and flexible solution to enhance access to care in a meaningful way, while also serving as a vital avenue for critical healthcare support. I think it's just really important to show that we're able to adapt to things that happen. So we had to quickly adapt. When the pandemic happened, we had to get materials into the hands of folks who didn't know how to use these items. So folks have adapted, and this is just one of those things that as time goes on, we need to adapt accordingly. So I appreciate what was said earlier, that this is a simple and clean process with a date change. I think there are a few nuances that need to be tweaked within the bill, but those are things that over time I think will make more sense. But extending the time frame is really, I think it's very wise, and we would be very appreciative. So thank you.
Thank you so much for your testimony. Thank you for being with us.
Thank you.
Seeing no other questions or comments, we move on to Gretchen Raffa. Gretchen, thank you. Sorry for a little delay. We had you wait. Welcome.
Thank you. Thank you for taking me. I know I was late, so I appreciate you still fitting me in. My name is Gretchen Raffa, Vice President of Public Policy, Advocacy, and Organizing with Planned Parenthood of Southern New England. To you, Senator Anwar, Representative McCarthy-Vahey, and honorable members of the Public Health Committee, we are here testifying in support of raised House Bill 5198, an act concerning telehealth. As the state's largest provider of family planning and reproductive health care to over 45,000 patients last year at 14th health centers across the state, we believe all people should have access to quality, affordable health care as a human right, regardless of who you are, where you live, your income, or if you have health insurance. For folks that don't know, Planned Parenthood of Southern New England Telehealth Services has expanded access to high quality, affordable sexual and reproductive health care, especially for those who often face systemic barriers to healthcare and who have been disproportionately impacted by the COVID-19 pandemic. Our ability to offer telehealth services was crucial then, and we continue to see the benefit for our patients today. Our experience has shown that patients overwhelmingly appreciate this flexibility and availability and access. Making the care available by phone or video is essential to residents across the state, no matter how far they live from one of our health centers. Our telehealth visits have provided uninterrupted access to things like birth control counseling, STI counseling and treatment, gender-affirming hormone therapy, HIV prevention medication, and more, and connects patients to the health center, the healthcare providers that they know and trust. Since March 2020, PPS&E has conducted over 33,000 telehealth visits, reaching patients who might otherwise have struggled to take time off or arrange transportation or childcare to come in person to a health center. Patients and providers need the certainty of the continuation of telehealth as currently in state law, and we thank the committee for raising House Bill 5198 to ensure the critical components of current telehealth policy, which has made it so impactful and successful, will continue, and we strongly encourage you to make it permanent policy in Connecticut. It's been one option to ensure continued access to care at Planned Parenthood of Southern New England for thousands of patients through the pandemic and beyond, and is a crucial option for our patients that must continue permanently, which is why we strongly support House Bill 5198. Thank you so much for your time and consideration of this important legislation.
Thank you. You were right on time, and thank you for your testimony. Very helpful. Seeing no other questions or comments, we will move to the next person on our list, which is Richard Taylor. Welcome.
Great. Good afternoon, distinguished members of the Public Health Committee. My name is Andrew Taylor. I'm here as an emergency physician with almost 2 decades of practice in Connecticut. Today, I'm here before you not only as a medical professional, but as a concerned citizen and a friend to those who have personally suffered due to emergency department crowding. I come to support SB 181, a crucial measure that seeks to address and mitigate the growing crisis of emergency department boarding and crowding. ED boarding adversely affects the quality of care. In the landscape of healthcare, where integrity, patient-centeredness, respect, accountability, and compassion are not just expected, but are the pillars of our service, it is heartbreaking to see these values compromised by the systemic issue of ED boarding and crowding. As an empirical example of the effects of boarding, studies indicate that patients, especially older patients, who spend the night in the ER waiting for a hospital bed, face a significantly higher risk of death. But beyond statistics, there is a human element, a moral injury we inflict on our healthcare workers and our patients when we fail to provide the timely, dignified care they deserve. Electronic records have evolved, and almost all EDs now have the capability to collect pertinent data electronically. Contrary to the concerns that you've heard earlier, integrating the proposed measures into EHR data extraction pipelines is not only feasible, but would require minimal effort, likely just a few hours of work. This is not an insurmountable reporting burden. It is a step towards transparency and improvement. I urge you to consider the real implications of ED crowding. It is more than just a logistical hurdle. It is a threat to the well-being of our citizens and a stain on the fabric of our healthcare system. The data that we collect, the transparency we uphold, and the measures we implement will serve as the foundations for more responsive, effective, and compassionate healthcare system. SB 181 is not a piecemeal approach. It is a necessary first step towards addressing a public health crisis. It paves the way for us to understand the scope and impact of the ED boarding and crowding. It enables us to make informed decisions and to implement solutions that will save lives and preserve the dignity of patient care. In conclusion, I implore you to support SB 181. Let us not wait another 15 years to take action. Let us not gather here again still searching for solutions to problems we can start solving today. It is time to act to uphold our commitment to our patients, to our values, and to the future of healthcare in Connecticut. Thank you for your attention and for your commitment to the health and well-being of our residents. And I'm happy to take any questions.
Thank you, Dr. Taylor, for your powerful testimony and then bring about the human suffering from this whole challenge that we are facing. So we appreciate you and you're very compassionate. I'm sure all your patients appreciate that. Representative Parker has a question or comment.
Thank you, Mr. Chair. Thanks, Dr. Taylor, for being here and continuing what the good chair said. I appreciate you bringing in the healthcare workforce and the impact on those folks and the moral responsibility to support them and doing their work well, doctors, nurses, every other provider that's in that system, like yourself. So we thank you for that. Dr. Taylor, I wonder if you can speak a little bit about the barriers to data extraction and reporting. I believe you have a little bit of experience here, and I wonder if you could share with the committee what puts you in a position to be able to help us understand this, because I feel like it's been a really important question. Is it the click of a button? Is it hundreds of hours? I think we have some more to learn on that, but anything that you can help provide would be very helpful.
Sure. And I did leave off that I'm also an associate professor of emergency medicine, in biomedical informatics and data science and biostatistics. I work all the time in the electronic health record. What the working group is asking for is a very minimal ask from the standpoint of an EHR data extraction. In fact, almost every ED I can imagine in the state is already collecting this data. They already have scripts or programs that are doing data extraction for these exact elements that they're asking for. And it's not very hard. It's a very simple, almost click of the button to be able to turn that into a data extract that then can be submitted to the state. Now, the state's going to have some work on their side of things, being building dashboard or something for display, and those types of things. But from an ED or hospital perspective, the data extract is a pretty minimal ask. And then you worry about, I think there was discussion earlier about, well, what if the measures potentially change? That's the wonderful thing about code, is that you don't have to, it doesn't take much to change whatever the extract is within that. So for instance, let's say that, the CMS comes out and they want 6 hours versus 4 hours. Well, from a coding perspective, you just change one number. You just change the 6, the 4 to a 6, and then that's it. And then you just rerun the extract and it comes out. So I don't think that should be an excuse for this, significant of a crisis.
Thank you for that, Dr. Taylor. And just a quick follow-up then, given your expertise, I want to confirm my sense that if we go forward with this, it's not an additional ask on the providers when they're in the ED. It's folks like you that are working behind the scenes a little bit. I just checked testimony again, and I don't see any opposition from ED docs. I don't believe it's association. So for the people that are providing this front lines, doctors, nurses, other providers, do you think that this would be an ask for them, or if it's as simple as what you're saying, it really happens elsewhere?
Yeah, I'm a little bit different because I work both within the databases and also as an emergency physician, but you're exactly right. For the average emergency physician, there's no ask from them. This is going to be an ask for a data analyst to spend a few hours of their time to build out a report, to be able to submit to the state. And that's really all the ask is initially.
Thanks so much. Thanks, Mr. Chair.
Representative Zupkus.
Thank you. Thank you for that explanation, because as you know, I'm the one that's been saying that. So I appreciate that. Do you see a problem with any hospitals giving up the information, or it's pretty mundane information that they would just give?
As a willingness to give it up, or as just a complication from not being able to do that type of?
Both, I guess.
That's a good question. So, I mean, I think, there are smaller community hospitals that are going to have, a harder time with some of these components as far as getting extracts out and everything else. I think, for the larger healthcare systems that we have, all of these things are going to be fairly easy for them to do. So do you think we have to, be able to be collaborative and supportive and help those hospitals try to, do those types of things? But, I'm willing to help. I know there's others that would be willing to help to share code. I would say 80 to 90% of Connecticut is on one EHR vendor. So the code is going to be almost exactly the same across all of those ED systems. So that's one thing to consider within this. Yeah, the other part of me, I think that's why we're asking here is to support this particular bill, is so that people will have to be able, hospitals will have to be able to provide this type of information. And a lot of this is also about accountability. It's about providing public information, so that we can start to kind of work on those solutions moving forward.
Well, that kind of leads me to my second and last question, was the information itself. When I hear codes, I think of numbers or whatever it is, but information, patient information, I know there's
Right.
HIPAA and
yeah, I think that's very important to point out. So, the only thing that is being asked is for aggregated data. So this is going to be like, X number of patients per year per hospital. You're not going to see individual level data unless you start moving forward and those things are being asked. But that's not the initial ask that's coming out of this.
And just what would be, because we heard before that the state Department of Health wasn't giving information they were being asked for. And you just said it's going to rely on some work on the state. So that's a little hesitation for me because they're not doing what you're asking them to do, but yet we would mandate them to do more work.
Right. And I only brought that up because you have to have somewhere to report it and it has to go to some dashboard. I don't know enough about, the state informatics systems to be able to say how easy or not easy that would be. I mean, I know they report on many other things, so it would conceivably not that hard, but I think that's something for the state to be able to figure out.
And the state would house all this data.
I think that's one option is that they would be the ones receiving the aggregated data from the hospital system.
Thank you.
Thank you. Can I just clarify for your data extraction that you're doing, you're using Python?
I mean, most of the time database extractions are done using SQL. So, but you can use a lot of different, we definitely program in Python and R and a lot of other languages as well. So.
Okay. And if the program, if some of the smaller hospitals don't have nodes to be able to go after, would there be a crawler system or something that can be created? How would they?
Well, I would be shocked if every hospital did not have a relational database that you could use SQL on the back end to be able to pull out information related to ED visits, et cetera.
Okay, perfect. This is very helpful. Thank you so much for your testimony. And sorry, Representative Reddington Hughes.
My question has to do with when this data is extracted. Do you feel that it may give some additional insight that we're not examining right now as to why we are having some of the problems that we're having?
Sure. And again, I wasn't a part of the working group, so I think that just needs to be known. But, the point of reporting data is so that you have metrics that you can use for comparisons and to know where you are in a current situation, and then to be able to, drive change and see that change within the metrics moving forward. I think that's the intent, and it's to uncover then further downstream what factors are driving those things, and to see if doing stuff like changing scheduling with surgery or something actually has changes on the metrics that are available to you.
Thank you. I'm just also wondering if this information is brought forward, do you think that perhaps we're missing something and that this would be very helpful?
Yes. Are we missing something? Yes, because yes, do we know boarding is an issue, but we don't have a clear idea at the state level how bad of an issue it is, where it's an issue, how much variation there is from hospital to hospital, and what factors may be driving that.
Thank you.
You're welcome.
Okay, thank you so much for your
Thank you
testimony.
very much.
Thank you.
Appreciate it.
Next is Mr. Bruce Baxter. Thank you for being here. Thank you for being with us this morning and afternoon.
Good afternoon, chairs, vice chairs, ranking members of the committee. My name is Bruce Baxter. I'm the CEO of New Britain Emergency Medical Services, one of the state's busiest nonprofit 911 EMS services. And I'm also the past president of the Connecticut EMS Chiefs Association. I seem to show up here every year talking about the fiscal cliff, most recently that our industry is facing. We stand in strong support of Senate Bill 179. We thank you for raising it, and we ask that you continue to support that and see it through to the point it becomes the law of the state of Connecticut. We're here talking about this because we have a standoff. We have Medicaid, which is the lowest insurance reimburser in our state. We have Medicare, which does not reimburse the cost of doing business. We have commercial insurance. And we have a rate setting process that's been in place for 40 years. And the rate setting process is not somebody sitting behind a magic green curtain room coming up with magic numbers. It's based on factual data. based on each individual service's cost of operations with a modest built-in profit margin. Unfortunately, we're challenged by the commercial insurance industry because they see the terminology of maximum allowable rates. And within that is an assumption, well, they're maximum allowable rates. There's margin there for us to negotiate down. When I first started as a chief here, we were pretty much guaranteed that if the patient had commercial insurance, we'd get 90 to 100% of our going rate. And that worked well for us 28 years ago because it recognized the fact that we were losing money taking care of Medicaid and Medicare beneficiaries. But the commercial industry has changed. And the commercial industry has more permutations of insurance plans that require a lawyer to translate them for the beneficiaries than existed before. And I can tell you that it's a rare exception where I get 100%. It's more likely that we turn around and get 30%, 40%. Medicare Advantage plans are all tied in, which are not part of the commercial product, but run by the commercial industry. They have automatic $300 deductibles on zero cost plans that are going to our most vulnerable Medicare patients who qualify for Medicaid as coinsurance. And those people are caught in a gap. We need a very clear-cut ruling that we're asking for here that just says, pay our rates. Our rates, because of the rate setting process, are less than the rates of our neighboring states and far less than what are charged in other parts of the United States. It is designed that way to protect people when they're at their most vulnerable moments. But the problem is that the commercial industry is saying, hey, we're not paying 100% of your rates. We have Medicare and Medicaid that don't pay our rates. And on the other end, we have the taxpayers that are screaming in the local municipalities, no more increases. We can't afford it. I'm in one of the 25 municipally distressed communities. My service does 18,000 responses a year. We transport 14,000 patients, and 88% of those patients turn around and rely on government insurance. The number one payer is Medicaid. I lose $200 on every Medicaid transport that I manage. I lose $180 on every Medicare transport.
Dr. Baxter, excuse me, but your time is up.
The system is at a collapse point. We need this bill, and I'd be more than happy to answer questions.
Thank you so much, Bruce, for your testimony and speaking. Would you be able to tell us a little bit about the sustainability of EMS in our state and in the fact that it's eroding in the rural parts and in many parts of our state, it's going downhill, and how this bill and the Medicaid rate is going to help that?
So this bill helps because it brings in a consistent amount of net revenue into the system from the commercial payers. 9% of my market that I serve has commercial insurance. There are many permutations of that. There are high deductible commercial plans. There are plans that will just outright pay 90%, and there are plans that'll lowball you because you're not in network with them. It'll bring additional money to every single ambulance and paramedic service that is life-sustaining for them. The Medicaid bill, Medicaid, we're here for 28 years I've been here talking about needs for Medicaid increases, as have my colleagues, and it's on a deaf ear. We expected 20%, a 20% increase. The state's share of that 20% increase was $5 million, and it would have brought another $13 million into our system. We don't get that. Your urban areas are going to be underserved. My city is underserved because I only have revenue to put 4 ambulances on during peak hours when I need 6 ambulances. Every day I sit and keep my fingers crossed when I hear that I'm at status 0, which is I have no available assets in the community to respond. Mutual aid comes into our city 1,200 times a year. 1,200 times a year, and it takes 20 to 25 minutes for a mutual aid ambulance to get in. It's economics. I have a city that's on the municipal distressed municipalities list. We all have taxpayers that don't want to pay more. And we have the primary supporters of the EMS system are fee-for-service revenue by billing the health insurance companies. And if they're not paying their share, we're at a break point. So it's not only, Senator, the rural portions of our state, it's every single community in the state is struggling because of really the rapid escalation of costs in a post-COVID environment.
Thank you. Representative Dauphiny.
Thank you, Mr. Chair, and thank you so much for being here. A couple of questions. Is this something that the legislature has weighed in the past? Are we the ones that determine rates?
The Department of Public Health, Office of Emergency Medical Service, through its commissioner, have the power to determine each ambulance service's charge master or rates that they can charge for services rendered. They have done that for 41 years. It has worked fairly well. It has protected the consumer because prior to rate setting, there was wide variations in what a service would charge without any consistency, and where some people got a deal of a lifetime and some people felt they were being gouged. The legislature, as well as service chiefs, are winding up getting calls from their residents who they've cared for, who are complaining about bills. How dare you charge $1,000? You know, you did nothing for me. It was a taxi cab ride to the hospital. And it's amazing when that fight or flight kicks in when you're sick. You don't remember an awful lot. You don't remember that you wound up getting a 12-lead EKG, IVs, medications, and all of a sudden, because your health plan has a $6,000 upfront mandatory payment from you in a community where few people have $1,000 of disposable cash, let alone $6,000, where people are hard pressed. And, you know, if I could wave a magic wand, I'd sit there and pass a law that said, you know, ambulance transportation is exempt from copays and high deductible plans. But that's unrealistic because I'm kind of a fiscal conservative. But at some point, you know, I think the state's doing the right thing there. The problem is the people that we rely on to pay the bills aren't paying, or aren't paying our set rates, which are cost-based.
Yeah, thank you for that answer. So the maximum allowable amount that you speak about, is that determined by us? And if we took that language out, would it then change?
I think would it change? It might. It's a step in the right direction. There has to be a rule, and this is legislation that's going on in every state right now, being sponsored by EMS, that the minimum payment should either be the rate set by the community, the rate set by the state, or between 325% and 400% of the Medicare allowable. I can tell you in Texas, California, it's 325% of the Medicare allowable. In Massachusetts, they've turned around and made some changes to Medicaid, where they're reimbursing ambulance services at 80 to 90% of the Medicare allowable. They're in New Hampshire, one of the most stingy states. I've lived there a long time in my life. On the first go around, they raised the Medicaid payment to 100% of the Medicare allowable. So, you know, we need money to survive. We need money to be able to meet the needs of our citizens, and it's just not here. So we need your help.
Thank you. Thank you for being here today.
Thank you for very powerful testimony. Yes, Representative Wielander.
Thank you, Mr. Chair. Sorry for the late ask. I was wondering if you would be able to speak to the practices of other states and whether or not there's any differentiation between what you run, which is as a nonprofit emergency response team, and other organizations that might be for profits, and if there's a difference in those rates in other places, or your thoughts on that.
There's an old saying that I learned early on. There are 80 different styles of EMS systems that are all shining examples of excellence and maybe examples of systems that need help. Once you've seen one community EMS system, you've seen one community EMS system. I've worked in the for-profit sector. I've worked for agencies that are high-performing systems, and I've worked in the municipal sector, the hospital sector, and now the nonprofit sector. And they're shining examples of really well-operated run systems in all of those sectors. For me to sit there and say, I think there is unity by all sectors that reimbursement has to improve. It's got to go up. And when I take a look at, and I'm not calling out a very large agency that may extend across the United States of America, but when I see them withdrawing with 3 months' notice from a number of communities every year, because the communities, they're not making money, they're losing money. And when I hear maybe that there are communities in Connecticut that are on their dashboard because the reimbursement doesn't support the model. If it doesn't support their model, I can tell you the reimbursement factor is going to push ambulance services to the brink where they are going to reduce the number of staff trucks. They're going to reduce the clinical level of service they have and then not be available whatsoever. You're on the precept of a very steep cliff that once you go over it, the patients are going to suffer. I've been doing this for 53 years. And the fact that the Medicaid increase this year was withdrawn, the first time that I've ever seen a sitting governor withdraw that in my 28 years here, is alarming. And while I understand the rationale behind it, we're at that cliff with 1 foot off. And that 20% that I mentioned earlier is a down payment on, if you will, the Medicare 80.
Thank you so much for that. I appreciate your answer.
Wow. Thank you for your powerful words. And we all hear you loud and clear. This is our moment to be able to be part of the solution. And thank you for all you and your entire team have done.
And I appreciate everything that you have confronting you. And I look forward to continue the journey with you. Thank you so much.
Thank you. Okay, the next person on our list is Tammy Freeberg, who is over here today. Thank you. Welcome.
Good afternoon, Co-Chair Senator Anwar and the rest of the members of the committee. I am here to join the chorus of voices supporting the extension of telehealth provisions that were adopted as part of the COVID pandemic and extended previously by the committee and the legislature. Who am I? I am a member of the executive team at the Village for Families and Children. I am the co-chair of the Children's Division of the Connecticut Nonprofit Alliance, and I'm pleased to serve on the Transforming Children's Behavioral Health Policy and Planning Committee. There is more information about the village and our experience implementing telehealth in the submitted testimony. So again, thank you for your efforts to date to extend the telehealth provisions and for this bill, which will further extend them. I think you all know for a time, telehealth was the only option that we had for providing behavioral health care to village clients, but over time, it's become a really essential tool for increasing access, improving continuity, and meeting the individualized needs of the people we serve. We, about a year ago, we undertook, just about kind of a comprehensive look at data that we could see about the telehealth services that we provided. So we looked at over, I think it was about 138,000 sessions, more than 7,000 clients. And our review provided substantial evidence that telehealth services were at least as effective as in-person services, and in some cases, the better option. There's more detail in the written testimony about that. I want to highlight, I think people before me already have said things that are important to continue, that exist and continue, of course, that payment parity. I also want to speak for the necessary need to keep audio only as an option in certain circumstances. One thing I didn't hear today yet, and I just want to make sure, an important provision in our telehealth legislation, which does allow providers to prescribe in treatment of particularly substance use services, using telemedicine. I think that is a really important piece of low barrier access to evidence-based medication-assisted treatment for substance use disorders. And I think that is one of the provisions that should continue to be part of our statute. And then in closing, I just want to say I would also love to see it made permanent. And I think that even if you make it permanent, there's nothing that prevents you from tweaking it later. So you could do both and I totally support that option. Happy to take any questions.
Thank you so much for your testimony. Thank you for being with us. We hear you. We'll keep all of this in consideration. Thank you. Thank you. And the next person on our list is Melanie White Lane. Welcome.
Good afternoon. Thank you for having me. Most of you know me, so I'm no stranger to sitting before you. It's a hard act to follow after Tammy. She's pretty much said everything that needed to be said, but I thank you for your time. As you know, we appreciate, I should tell you, I'm the executive director of the Connecticut Association of School-Based Health Centers. We're a statewide organization that supports over 315 school-based health centers throughout the state. I very much appreciate the support of this committee and our school-based health centers, and we are completely 100% in favor of the proposed telehealth services. I just want to say, I agree with Tammy. This is not a permanent solution till 2027. So we ask that you consider a permanent solution. As you know, in 2020, all of our school-based health centers went to telehealth in some shape or form, and we survived. We provided service to an enormous amount of school-based health center students over the 2021 school year. And now looking forward, we're not just providing services to those students who are out of school because of COVID, right? We're providing services to students and their families who suffer from barriers like work, transportation, schedules, all of those things that I've sat before you many times and discussed. And so I'll keep it short because I know you've heard me. I'm preaching to the choir. We ask that you continue to support this telehealth bill through 2027, make it permanent. Every child deserves to have access to care and eliminate as many barriers as possible. This bill allows all of our clinical staff to consult on a regular basis with everyone that child touches. So thank you for your time. I'll take any questions if you have them.
Thank you. Seeing no other questions or comments, we appreciate you being here and thank you for your testimony. The next person on our list is Jamie Rodriguez. Jamie, you're on.
Hello, good afternoon, Chairman Anwar, Chairwoman McCarthy-Vahey, Ranking Member Summers and Clarice Ditria, and the members of the Public Health Committee. My name is Jamie Rodriguez, a licensed marriage and family therapist and the advocacy chair of Connecticut Association of Marriage and Family Therapy. I'm speaking on behalf of support of HB 5198. CTMFT represents over 2,000 MFTs employed in various settings throughout the state, and a significant percentage of our members utilize telehealth platforms to serve their patients. As so many of the amazing speakers have highlighted before me today, the various reasons why extending these telehealth protections is important, I would like to highlight a few others. So since 2020, we have seen telehealth become a tremendous clinical resource for many clinicians and patients. The use of confidential telehealth platforms has increased access to care, increased consistency of care, improved outpatient clinical outcomes, and provided a safe and secure option for both the patient and the clinician. A sizable segment of our MFT members report that they continue to use telehealth for either hybrid treatment model or solely. And these are for various reasons, including but not limited to ongoing patient and or clinician health conditions, patient barriers to care, such as transportation, time demands, work schedules, childcare needs, inclement weather barriers, or brief or sudden illnesses or injuries. This means that a sizable number of our Connecticut residents have consistent and extended access to mental health care providers all across the state. And without the protections of this extended telehealth, then those would be taken away or at least restricted. The protections of the reimbursement parity that are also extended through HB 519 continue to allow mental health professionals to provide these services to their patients. Without that reimbursement parity, many providers will face the moral and financial dilemma of choosing between continuing to treat people via telehealth for reduced income or turning those clients away and barring them from the mental health care that they need. So this will indisputably decrease the number of providers offering telehealth services and thus restrain the access to care, and also increase our workforce shortage. As mental health providers, we understand telehealth is not appropriate for all providers, patients, or all clinical circumstances. However, those determinations should be up to the patient and their provider to decide within their scope of therapeutic relationship. Many providers have invested great thought, effort, and financial commitment to utilize telehealth platforms that best fits their treatment modality, their patient population, and HIPAA compliance, as you've heard the discussion back and forth about live stream versus voice calls. Without the protections of HB 519, providers will 5198, excuse me, providers will have to comply with the ever-changing policies and platforms of privacy of private insurance carriers. We applaud the public health committees for recognizing the importance of telehealth in the mental health care, and ideally we seek permanency and its protections for parity, reimbursement parity, and platform choice. Thank you so much. If you have any questions, I'm available.
Yes, sometimes a senator doesn't support.
Perfect timing. Kathleen just joined, and so thank you so much for your testimony. I see no questions or comments, so we move to the next person on our list, which is Jason Shirley. Jason Shirley is here or was. All right, Tracy, you're on. Tracy Wodak, welcome.
Good afternoon, Senator Anwar and distinguished members of the Public Health Committee. My name is Tracy Wodak. I'm the president and CEO of the Connecticut Association for Healthcare at Home. I am also an RN with 40+ years experience in home health, hospice, long-term, and acute care. The Connecticut Association for Healthcare at Home is the united voice for 21 of the 25 hospice providers in Connecticut, all of whom are licensed by the Department of Public Health and certified by Medicare. The association supports SB 176 to establish a pediatric hospice program with a request to add palliative care to the bill language. For clarification, let me first define both palliative and hospice care. While the objective of both hospice and palliative care is pain and symptom relief for serious illness, the prognosis and goals of care tend to be different. Hospice is comfort care without curative intent for someone with a prognosis of 6 months or less, should the serious illness take its natural course. The patient no longer has curative options or has chosen not to pursue treatment because the side effects may outweigh the benefits. Palliative care is comfort care with or without curative intent, so they can receive concurrent care under palliative care. When considering children with a serious progressive illness, families often struggle with foregoing curative options. Hence, the choice for hospice, the terminality of it, can be very overwhelming. Also, physicians aren't always comfortable determining a prognosis of 6 months or less for a young child. Please consider adding palliative care along with hospice care to this bill language. I am also a member of the statewide Palliative Care Advisory Council, a legislatively mandated DP-run council tasked with analyzing the current state of palliative care in Connecticut, as well as advising DPH on matters related to improving palliative care and the quality of life for people with serious or chronic illnesses. The council is also required to submit an annual report to DPH with our recommendations and findings. Since 2018, our report has identified a gap in hospice and palliative care specifically for children in Connecticut. As a result, we hosted a statewide pediatric palliative and hospice care training in November 2019 for nearly 120 nurses. Since then, I have received many calls and pleas from Connecticut Children's and Yale, both seeking home health or hospice agencies able to take pediatric cases, some seeking palliative or concurrent care, some seeking terminal hospice care. Unfortunately, we do not have the capacity of a trained workforce for this specialty. It breaks my heart that we have such limited options to offer. Please pass SB 176 to develop a plan for both hospice and palliative care programs for children in Connecticut. Tasking DPH with this initiative would be best met by including the Connecticut Association for Healthcare at Home and our statewide Palliative Care Advisory Council, as they have the subject matter expertise to guide DPH, who can then serve as the technical experts. In addition, I have also submitted written
Excuse
testimony.
me, Ms. Wadash, your time is up.
Thank you. Just support for both the Social Work Bill 5197 and the Telehealth Services Bill 5198. Thank you.
Thank you so much for your testimony. Your points are well noted, very, very valuable. So we will absolutely look at that seriously. Senator Marks has a question, and then we have others. So Senator Marks,
Thank you,
go ahead.
Chair. Thank you, Tracy. My first job was at Sloan Kettering on their pediatric floor.
Wow.
And that's what I wanted to do, pediatric oncology, but it's hard.
Mm.
And we definitely, we need this. I've done hospice at home too, and I've taken care of children. What happens to the kids now that are discharged home needing hospice care? Do the hospice agencies kind of do the best they can? And or what happens now with those children?
Generally, it's a very difficult referral to find someone to take the admission. I have been successful with certain hospice agencies and having them work collaboratively with either Connecticut Children's or Yale, specifically for dosing as well as for support. It's very different for hospice providers who are used to caring for people who are in their 70s, 80s, and the children thereof, the support that they need to give versus caring for a child who is dying and helping their family unit. It's just a very different form of support.
Yeah. So yeah, right there, it shows that we need it. And it's so not even just with the nurses, with the social workers, with the aides that go in, with every single discipline that's in there. It's a whole different set of just how you feel. Expertise. Yes. Yes.
And comfort, expertise and comfort level, both.
When you speak with the Chair, may I ask one more question?
Go ahead.
When you speak with the hospice agencies, are they excited about this, do you think, or are they a little apprehensive?
Yeah, so a little bit of both. I heard a word this week, skited, excited and scared together. But you will hear from a couple of providers today who are very excited about it and very interested in it, but needing assistance in getting enough staff trained to be able to provide the service. So I think you can ask them for some specific stories. They have quite a bit to share.
Thank you so much. This is something that this bill came, Senator Hockedal had a constituent who needed help. And when they started to ask around, they could not find anybody. And then she reached out to me and said, wow, this is something we don't want to think about. Nobody wants to ever think about, but unfortunately it's real. And that's why there's a little weakness and we want to try to address this issue.
Yeah, I think one of the biggest issues too is that when you look at the numbers of the aging population that are appropriate for hospice or palliative care, it's a much larger volume than it is for the small number for children. And so when you spread that across the state and need to have the expertise of the care spread across the state, it's very difficult to get enough staff consistently trained.
Yes, yes. Representative Dauphin, followed by Senator Gordon.
Thank you, Mr. Chair, and thank you for being here today. I've one of my passions was hospice nursing for several years, so I can appreciate all that you do. And I wasn't aware that we weren't really addressing the needs of children. I guess it's far, thankfully, the need is far less. So I think that most of my questions were answered through Senator Marks, but what you're asking for is that we take an initiative to come up with a plan, I think. Is that clear?
Yeah, the bill actually looks to DPH to create the plan, and I think it puts them in an awkward place because they're not the experts in this. So I've been in touch with several people at DPH, and I think if we can approach it collaboratively so that our Palliative Care Advisory Council, who has a significant expertise, as well as our hospice providers, if we can put a group together to really work on this, I think we can be put together a good program.
Yeah, thank you. I had other questions, but I think it's premature. I think you're just trying to see how this is going to look and play out.
Yeah.
So thank you for being here.
Thank you.
Senator, go ahead.
Thank you, Mr. Chairman. Thank you for your testimony. And actually, one point during my career as a cancer doctor, I was a hospice medical director.
I knew that.
So I understand hospice and palliative care very well. I take care of adults, and it's not easy when someone's in their 70s, 80s, or 90s to have those types of decision making. And I've had to do it for people in their 20s and 30s. I can't imagine what it's like for a child. And I don't take care of children, but I'm aware that there is a lack of real continuous palliative and hospice care. And it's good that you highlighted both, because palliative care can, for some people, head into hospice care. So you're actually trying to be proactive. One of my questions was already answered about how the existing hospice programs have been viewing this. And we have a great history in Connecticut of being a national leader in hospice care.
50 years this year.
Going way back to its founding. Yes, very, very much so. But if I can just ask a question a little bit more about the existing hospice structures. Certainly pediatric care is very, very different from adult care. Kids are not little adults. So there's a whole range of services that have to be put in place for them. Are you looking through DPH to try to see what might be able to be done through the existing framework of palliative and hospice care and kind of build upon that to see what could be done for the pediatric population everywhere in Connecticut? Or are you also looking to see, would there be something standalone just for pediatric, or is it more just being open to what might be the opportunities that could move this forward? And I do support this.
Yeah, thank you. I don't want to assume what DPH might present. We already have regulations for hospice, and we already have regulations for home health. So either one of those would fit. The current regulations are very outdated, 1979. But the foundation is there. We just need to be very intentional about making it fit for the population of 0 to 18. And that's where it's a challenge. We just don't have the workforce. We don't have the trained staff, and we don't have the volume to be able to consistently offer it at this point.
Can you tell us a little bit more training that would be needed? Are there other examples that an existing nurse or caregiver who's providing it to the adults would need specialized training?
Well, I think our training, as I mentioned in my testimony, in 2019, we did a mass training specific for pediatric palliative care. It was about 120 nurses, social workers, support staff. And in order for us to do that training, we collaborated with Connecticut Children's, with Yale, Hartford Hospital, our hospice providers. It's really looking at the specialty of pediatrics for the medical part of it, your dosing for your medications, but also how you work specifically to support the families. As I had mentioned before, very different supporting perhaps a 60-year-old daughter and son caring for their aging and seriously ill 90-year-old mother versus a 3-year-old child with 2 other children living in the home and parents. So it's really it's an expertise.
Thank you. This is very helpful for us, and we're looking forward to talking to you a little bit more as we formulate a plan.
Great. Thank you.
Thank you. Next person on our list is online, Dr. Megan Wolf. Welcome.
Thank you. Senator Anwar and Representative McCarthy-Vahey and distinguished members of the Public Health Committee, on behalf of the more than 240 orthopedic surgeons of the Connecticut Orthopedic Society, thank you for the opportunity to share the Connecticut Orthopedic Society's testimony in opposition to HB 5196, an act expanding the podiatric scope of practice. My name is Megan Wolf. I am a dual-trained foot and ankle and sports medicine orthopedic surgeon, which means I completed a 5-year residency and 2 extra years of subspecialty training. I practice at Comprehensive Orthopedics in Wallingford, Meriden, Cheshire, and Southington, and I do take care of the Medicaid population here, and I currently live in Cheshire. We oppose the scope of practice expansion proposed in House Bill 5196 because the vast majority of podiatrists in Connecticut are not qualified per their education and training to do the 3 procedures proposed. There is no proposed mechanism to differentiate podiatrists that are adequately educated and trained to perform these 3 surgeries from those that are not. Furthermore, adding treatment of complications within the tibial diaphysis related to the use of external fixation pins goes beyond the Connecticut statutory definition of surgical treatment of the ankle by adding treatment of the tibial shaft. This is including entering it through the knee joint. Finally, there is currently no problem with respect to access to these 3 procedures in Connecticut, including patients with Medicaid or lack of adequate health insurance. For over 20 years, COS representatives have met and compromised with members of the podiatric community and representatives of the legislature with respect to repeated legislative requests by the podiatric community to expand their scope of practice to the ankle and further up the leg. Most recently, our society engaged in discussion with the podiatric community through the Department of Public Health Scope of Practice Work Group. This committee received the DPH Scope of Practice Review Committee report on podiatry on February 21st, 2024, after this bill was proposed in the committee. It is disheartening that the extensive meetings and discussions were not taken into consideration in the development of this bill's language. During the many recent meetings of the work group, COS representatives stressed the importance of extensive standardized residency training programs to ensure the safety of both adults and children seeking podiatric care. Connecticut statute requires podiatrists to have done a 2 or 3 year surgical residency in order to do ankle surgery. All MD or DO surgical subspecialties require at least 4 years of residency training. Orthopedic surgeons do significantly more surgical cases and with a higher level of responsibility in their 5-year residencies than the better trained podiatrists do in their now 3-year residencies. This is particularly the case for joint replacement, including the ankle, intra-articular fractures of major weight-bearing joints, including tibial pylon fractures, and osteomyelitis of long bones, such as the tibia, the 3 proposed scope expansions in this bill. The COS shared several studies published in the scientific literature comparing patients undergoing total ankle replacements and ankle fracture surgery by podiatrists versus orthopedic surgeons, indicating poorer clinical outcomes, increased complications, and higher costs with podiatric care. We respectfully request that this committee oppose the scope expansion requested by the podiatric profession in this bill. The likely risk of the proposed expansion with respect to the health and safety of adults and children, our patients, greatly outweigh any benefits to the podiatric profession. Thank you for your time.
Thank you, Dr. Wolf. You got a lot in there in that 3 minutes. Thank you for taking the time to be here with us today. Seeing no questions or comments, we thank you for being with us, and we're going to go next to number 38 on our list, Karen Garland, who I believe is here in person. Welcome, Karen.
Thank you. Senator Armour, Representative McCarthy-Vahey, and honorable members of the Public Health Committee. My name is Karen Garley, and I'm speaking as a member of the Hospice and Palliative Care Committee with the Connecticut Association for Healthcare at Home. I've been a registered nurse working in end-of-life care for over 30 years and in hospice and palliative care leadership for the last 18 years. I'm here today to express my strong support for the proposed bill SB 176 that aims to establish a pediatric hospice program in the state of Connecticut. As a hospice and palliative care leader and someone who deeply values compassionate care for children facing serious illnesses, I believe this program is essential for the well-being of our young patients and their families. Pediatric hospice and additionally palliative care provide specialized medical attention, pain management, emotional support, and spiritual care tailored to children with life-limiting illnesses. These services address not only physical needs, but also the unique emotional and developmental aspects of pediatric patients and to support their family unit. I'm currently the Senior Manager of Yale New Haven Healthcare at Home Hospice Services. And although I'm here today not speaking on behalf of Yale New Haven Health, I would like to share some of the challenges accessing end-of-life care for pediatric patients with a story about a particular family. Almost 2 years ago, I was contacted by Tracy Wodach, who just spoke recently, the president and CEO of the Connecticut Association for Healthcare at Home, to inquire if our agency could take on the care of an infant who was going home with her family for her final days. The providers caring for this infant were not able to find a hospice provider in their geographical area that had the capacity or expertise to provide the services that were needed. The ask was if we even couldn't provide the hospice services, could we at least pronounce this little girl so she didn't have to go back into the hospital? Luckily, our hospice staff was staffed with a team who had the experience with pediatric care, including end-of-life care, and were willing to support this family, this infant and her family. The team, including a nurse, social worker, spiritual care counselor, volunteer, and bereavement coordinator, in partnership with the hospital providers, rallied around this family, which also included a very young sibling, and sought to make every moment a special and meaningful one for all of them. They ensured the infant was comfortable and the family was supported throughout the process, and they were able to be where they chose to be, at home. Our hospice team had subsequently cared for several other pediatric patients, ensuring the patients were kept comfortable and helping them make memories with the time they had left together. We arranged for things such as a ride in a fire truck and a fireboat, a trip to a horse farm, and a behind-the-scenes tour of the Beardsley Zoo. Our team was there with these families to the very end and provided support and specialized care to keep children out of the hospital. The pediatric hospice and palliative care allows families to continue to hope for a cure while simultaneously receiving expert physical and psychological support. It empowers families to make informed decisions about their children's care, respecting their wishes and needs.
Excuse me, Ms. Garley, your time is up. Thank you.
I would just ask that you please consider the framework, working with the expertise, and so we can continue to provide this care that is much needed.
Ms. Garley, thank you so much for your testimony, and to you and all those who provide this really critical work. Talking about and facing death is something that is universal, but we don't all handle that very well. And the work that you do is so very important. And I know we have a question or a comment from Senator Marks.
Yeah, thank you, Chair. Thank you. I know that those are children, those are patients that you're never going to forget, ever,
Never.
ever,
I
ever.
remember children I cared for 30 years ago.
So do I.
25 years ago.
Yeah, isn't it? It's amazing. Yeah. And that the family will never forget you, and for all the people in that home. And, you know, when Senator Anwar asked, like, well, what's the difference? There is so much difference when you're caring for a child, even when you're caring for an infant, than when you're caring for a 3-year-old or a 5-year-old or an 8-year-old. The developmental stages and even their vital signs are different. You know, their normal vital signs that unless you've been a pediatric nurse or a pediatric caregiver, you just don't understand. And I think like one of the biggest things about this, doing the pediatric hospice program, is that when the child has passed, being able to have them pass in their own home, where then everybody can stay there as long as they need to and do what they need to do, instead of having to walk out of a hospital room. That you just can't compare the two of those. And even when the undertaker comes, that it's so completely different than when they come for an adult. So I know this is probably, some people might have tears in their eyes when I'm saying this, but I just know that you do work that will, losing a child is so hard, but because of what your company has done and the caregivers have done and what they've allowed that family to start that grieving process, there is no amount of money or nothing that can ever put a price tag on that. So I will work diligently to try to get the best bill passed that we can, and we might come to you to ask you. It's been a while since I've done this, but you are bringing back some memories. And I actually miss it a little, so maybe my retirement. So thank you for everything, and thank you for testifying. It's hard to be a nurse and to come and then do this and testify. So appreciate you very, very much.
I appreciate the committee's time. Thank you.
Thank you, Senator Marks. I thank you. Oh, seeing no, I would echo your words, and seeing no other questions or comments. Nope, you're great. Very important. These, as are so many of the issues that we face before us today. I believe next on our list is Dr. David Emmel. Am I correct about that? Let's see. Yes, Dr. Emmel is here with us online. Welcome, Dr. Emmel.
Good afternoon, Representative McCarthy-Vahey and distinguished members of the Public Health Committee. My name is David Emmel. I'm the legislative chairperson for the Connecticut State Medical Society. On behalf of our physicians in training, I would like to express our support for 3 bills before you today: Senate Bill 180, 182, and House Bill 5198. The State Medical Society extends its gratitude to the committee for recognizing the importance of addressing the burdensome prior authorization requirements prevalent in healthcare insurance. One aspect of the prior authorization process that creates frustration for doctors and the patients they care for is the peer-to-peer clinical review that all too often assigns a clinical peer from a different medical specialty than the requesting physician. For example, a treatment plan of a gastroenterologist being reviewed by someone like a gynecologist. Senate Bill 180 addresses this issue by refining the definition of clinical peer, stipulating that the clinical peer must belong to the same medical specialty as the treating physician. We view this as a pivotal step towards a much needed comprehensive overhaul of the entire prior authorization system. The State Medical Society also supports the creation of a rebuttable presumption in favor of the treating physician. as physicians are the ones best suited to know if a procedure or a medication is medically necessary. Senate Bill 182 aims to prohibit health insurers from mandating step therapy for prescription drugs used to treat mental, behavioral, chronic, disabling, and life-threatening conditions. Step therapy, which requires patients to try less expensive medications before accessing the prescribed one, often prolongs treatment and undermines the physician's judgment, leading to potentially harmful outcomes. The administrative burden of step therapy, including its potential for irreversible outcomes, contributes to psychiatrists' reluctance to participate in insurance networks. Eliminating step therapy requirements for mental health drugs and other conditions would empower physicians to deliver optimal care without insurer interference, ultimately benefiting patient outcomes. The State Medical Society strongly supports this bill as it facilitates improved patient care by removing insurers from the patient-physician relationship. The State Medical Society strongly supports the extension of Connecticut's telehealth law through 2027, and I would echo other speakers, even beyond would be wonderful. Since the COVID-19 pandemic, physicians have invested in telehealth infrastructure. This extension will safeguard these investments and enable physicians to continue providing comprehensive care efficiently through telehealth platforms. Moreover, telehealth has proved instrumental in overcoming barriers to healthcare access, particularly for underserved communities and those in remote areas. Extending the telehealth law will ensure continued access to essential healthcare services and promote equity in healthcare access statewide. Thank you for your time and consideration. I'd be happy to answer questions.
Dr. Emmel, thank you for your work and for being here to testify today. We have a question from Senator Gordon. Senator, please proceed.
Thank you, Madam Chair. Dr. Emmel, it's good to see you, and thank you once again for not only the patient care you provide, but the patient care advocacy that you're doing. And I know you've been doing it for many years. I know I've spoken a lot about this topic, and it's a topic near and dear to me, but I just wanted to ask you a question to clarify. What has been your experience and what have you been seeing over the years with regards to what I think is a worsening problem with regards to prior authorizations and the process of prior authorizations, not just affecting patients getting the care they need, but also patients getting it in a timely manner?
I'm sorry, I didn't get that last part, Senator Gordon.
My quick question to you is, what have you been seeing over the years with regards to what I think is a worsening problem, but I'd be interested in your perspective with regards to the prior authorization process, limiting patients getting access to standard of care approved treatments, but also it in a timely manner. I'm interested in what you're thinking.
I think one of the things that is often glossed over or underappreciated is the stress that physicians are under through this process. And, we sometimes speak of it as burnout, but I think a much more appropriate term is moral injury. Because when we're interacting with our patients, in the depths of a patient-physician relationship, trying to find the treatment plan that's going to be best for a patient, that will get them through the health horror that they're going through, when we're suddenly hampered and delayed and told that what we're doing isn't appropriate, and the barriers just keep getting thrown up, and it feels like it's harder and harder to break through, that creates a kind of a deep-seated frustration, and it's part of the explanation why so many physicians are now retiring early. We're seeing this particularly in fields like ophthalmology and dermatology and ENT. Physicians just losing that connection to patients that's so important when they just have to spend so much time on these bureaucratic processes, most of which feel like unnecessary barriers just to diminish expenditures on the part of the insurance industry.
Thank you, Senator Gordon. And thank you, Dr. Emmel, for your answers today. Seeing no other questions, we will move on to the next person on our list, who is June Kim, to be followed by Meredith Bailey. Ms. Kim, welcome.
Good afternoon. Hello, Honorable Co-Chair McCarthy, Co-Chair Anwar, and honorable members of the Public Health Committee. My name is Jongwoo Jun Kim. I'm a graduate student at Yale University pursuing degrees in public health and nursing. I work as a nurse in the emergency department in the United States and South Korea for over 6 years. Now I'm here to address the crisis of boarding in the emergency department in relation to supporting bill number 181. Emergency department boarding means situation when patients stay in the ER for a certain amount of time after admission, awaiting inpatient beds. The aftermath following ER boarding is fatal because you patients are loaded in the waiting room and then left unattended. This is the moment when the safe place turns into the neglected place. As a tragic example, in 2022, one young man died in the waiting room with no bed or no medical staff assigned to him. This story is not specific to one individual. Not only does this delay cost innocent lives helplessly, but people also give up asking for help in the middle of their most vulnerable moments. To prevent this from occurring, the first step is to face reality. Connecticut can achieve this by implementing ER boarding time measurement across the state. Measuring the boarding time is a fundamental step toward understanding and mitigating the boarding crisis in ER. This can be simply conducted with the existing electronic health records, not even requiring huge financial support or additional tasks. Connecticut can lead the safety culture in the emergency setting of the United States by pioneering this measurement system. Your attention to this matter can spearhead meaningful changes and advance the public health of Connecticut. Thank you for listening.
Thank you for testifying. And I would like to just highlight something that you said, that people give up asking for help. That's a really powerful statement. And I thank you for taking the time to share your experience. And we wish you luck in your studies. And we have a question from Senator Marks.
Hi, thank you so much for testifying, and nursing and public health. That's great, 2 degrees to get together. So we had an earlier speaker talk that it was just going to be more for the ER physicians to do by having to do this study. And when he was testifying, I was wondering, well, what about the nurses in the ER or the ED? Couldn't they be helping out with the study? And I love that you said that we probably could get most of the data right from the electronic health records. So is this something that you're studying while you're at Yale, or do you have anything more you can go into detail about actually getting the data?
At this moment, I'm not involved in any research related to it, but as I said, I work as an ER nurse for over 6 years before coming to Yale, and ED boarding situation is the one that I face every single day. And this is definitely dangerous for patients because the recommended ratio nurses versus patient is 1 versus 4, but this is no good anymore once you have more patients in the waiting room. And it's directly related to patient safety. I experience this every single day when I worked, and I have interest in further study with this.
Thank you. Thank you for one more question. And so I had asked that, do you think that by doing this study to actually doing something towards addressing boarding that would actually increase morale and let the healthcare workers in the DED know that the legislator in public health was listening to them and actually taking action now instead of waiting for the task force to give us their recommendations. And I actually did then receive an email from a physician thanking me and saying he felt it absolutely would help with some morale and make the workers feel that way. So I'm just asking you as a ER nurse, if you feel that it would make the nurses feel better knowing that we were listening to you and starting to do something immediately.
It's absolutely beneficial to know the data, the situation, because once we don't know the fact, we easily just ignore the situation. It is obviously very helpful. And as I said, there's no additional financial, like there's no required financial support or additional tasks. So definitely we're more than welcome to have that data.
Thank you so much for testifying. Appreciate it very much.
Thank you.
Another question from Senator Anwar.
Thank you, June. You did a great job. Thank you for the work that you're doing. And I think you highlight the fact that everybody working in the emergency room is impacted. The moral injury that we're talking about happens to nurses, anybody and everybody in the room that is taking care of the patients that they feel they cannot provide them the care in emergency situations. So thank you for highlighting that. I appreciate your testimony.
Thank you so much.
Thank you. Next, we have Meredith Bailey to be followed by Carrie Moss. Welcome, Meredith.
Thank you. Good afternoon, everyone. My name is Meredith. I'm a psychiatric APRN. I've lived in Connecticut for most of my life, and I'm here to speak in favor of Bill 5198. I received my master's in nursing from Yale, and I'm attending Quinnipiac for my doctorate. I worked at CCMC ED as a staff nurse, and then Yale inpatient psychiatry as an APRN. And since 2017, I've owned Serenity Wellness, a group mental health practice of 15 clinicians located in Brantford and Middletown. At this time, we serve over 1,000 insured patients with commercial and Medicaid plans in the state of Connecticut. And about 70% of our weekly appointments are telehealth. And this is at our clients' request, as we all offer in-person appointments. Our specialties include the LGBTQ+ community and postpartum and perinatal mental health. Since 2020, when telehealth pay parity came into being, my costs of running a business have not decreased. My EHR subscription, accountant fees, staff salaries, PTO commitments, rent, and 401k plans is another added expense for employers. I offer a group health insurance plan that premium increases yearly. In fact, Anthem Blue Cross Blue Shield requested an 18% increase in their premiums last year after posting more than $10 billion in profits. Anthem also decreased reimbursement for telehealth as of January 1st for all APRNs in the state. Anthem and Aetna plan to decrease reimbursement by $30 per 25-minute follow-up visit, or 26% per visit for psych APRNs if pay parity is not protected. Aetna sent out communication stating this in August 2023, and Anthem went ahead and cut it already. And I've had to fight them for the last 8 weeks involving the comptroller's office as well as the Connecticut Insurance Commission. Make no mistake, insurers want to pay providers less, and by removing pay parity for telehealth, they will have the opportunity and they will take it. Any reimbursement decrease at this time or in the future would severely impact our ability to operate as a small business, and we would be unable to offer telehealth as a sustainable option. Telehealth has changed the way people can access mental health care, and it needs to remain a financially viable option for small businesses. With telehealth, we have saved lives, prevented suicides, prevented postpartum psychoses, but we are also a business and we have ever increasing expenses. Please pass and make permanent pay parity and telehealth protections. Thank you.
Thank you so much for your work and your compelling testimony. Those numbers are significant, that 70% of your appointments are telehealth. People clearly are accessing healthcare in this way, and the issue of equity is certainly important, as you highlighted for us. Seeing no questions, I thank you for taking time and spending the time to wait to testify. And
Thank
next,
you.
welcome Carrie Moss, to be followed by Thomas Burr. Thank you.
Good afternoon, distinguished members of the Public Health Committee. I am here today to speak on behalf of Senate Bill 176. My name is Dr. Carrie Moss, and I'm from Connecticut Children's. I am both a board-certified pediatric hematologist-oncologist and a board-certified hospice and palliative care physician. I am the founder and current medical director of Connecticut Children's palliative care team, the Sunflower Kids. Additionally, I serve as the appointed pediatric representative on the legislative-mandated DPH-run statewide Palliative Care Advisory Council. I'm truly grateful that this bill is being raised on behalf of the patients and families we have the honor of serving. Prioritizing hospice program for children is long overdue and currently an unmet need throughout the state of Connecticut. Unlike adults with terminal illness, children do not receive the same access to hospice and related end-of-life services currently. In fact, there is not a single agency that provides services exclusively for children, and most adult agencies lack both the expertise and possibly more importantly, the comfort in doing so. The reality that children die in hospitals because we are unable to provide them with the appropriate home services is truly unconscionable. We can do better. We need to do better for these children and for their families. I have submitted testimony on this on behalf of this bill, but what I would like to do is share a little bit of patient information with you. Over the past 6 months, I've enjoyed the privilege of caring for a beautiful 12-year-old girl named Rhea with a diffuse intrinsic pontine glioma, a universally fatal brain tumor in children. From the moment we met this lovely young lady at Connecticut Children's, it was her priority to spend what time she had remaining outside of the hospital environment. Wise beyond her years, Rhea had places to go and people to see before the end of her life. And for 4 months, Rhea did just that. She enjoyed time with her family and friends, participating in school and church activities. In December, she went on her Make-A-Wish journey to Toronto to see the CNN Tower. Throughout this time, Rhea was lucky enough to have support of a hospice agency in her home. As her disease progressed over the past 6 weeks, she was able to receive medications and support services at home to prioritize her comfort. Her courageous mother noted that without the support of hospice, she would never have been able to keep her daughter home. As she stated, we cannot put into words how much it meant to be able to fulfill her final wish of her dying at home. We could not save her life, but we could honor her, and that means everything to us. Rhea died peacefully last week at home. I'm sharing the story of Johnny, and this is quoting his parents. With the help of Dr. Carrie Moss and her palliative care team at Connecticut Children's, we were able to bring our 9-year-old son, Johnny, home to be with his family during his final days. It's really hard to express the full value of this to our family. Dan and I were able to love Johnny in our home as his parents. We had skilled nurses who took care of Johnny with the utmost respect. We weren't stressing over administration of oxygen, pain meds, or IVs, or cleaning his soiled linens. He was able to be with his siblings. He was outside in the sunshine. He was cuddled peacefully in his own bed. He had visits with his extended family, neighbors, and friends. We were together. His life and death were honored as they should be. On behalf of Rhea, Johnny, and their brave families, and all the courageous and amazing children and families we serve every day, we are grateful to you for consideration of this position. We are just so excited to hear that this is an agenda item that people care about at this time. With your help, we can do better for them and by them. Every dying child in the state of Connecticut deserves this expertise and support of the hospice program. It is time we make this a reality for our children. Thank you for your time and your consideration.
Thank you so much, Dr. Moss. And I was grateful to have the opportunity, along with Senator Anwar, to meet you in person earlier today. And thank you for joining us again here online and sharing those very powerful stories. Here at the Public Health Committee, we talk a lot about maternal and infant health and helping our young, newest members enter the world. And it is equally important that we focus on helping those young people and their families who are leaving this world. So thank you so very much for the work you do and for taking the time to testify before us today. We are all committed to continuing work on this. Senator Anwar.
Thank you, Madam Chair. I just wanted to clarify a thought with you. If there was an existing entity that was providing this care and they had the expertise and the experience to do so, one model is to give them the opportunity to expand across the state, and another opportunity is to have all the existing ones develop capacity separately. So there are two pathways to be able to provide statewide coverage. What are your thoughts?
So my thoughts are any pathway is a welcome pathway. But aside from that, my thought is that, this requires expertise and in comfort within the home. And so the challenge of a statewide program is being able to cover all aspects of the state in the same period of time, right? And so a child that's dying in the home in the northwest corner may not have the same needs as a child dying in Fairfield, or may have the exact same needs at the same time. So I think either program could succeed in Connecticut. I think it will take a great deal of time to develop a program that can cover the entire state. And we do have interest and engagement from some of our existing programs, but it's the comfort piece, right? It's the getting the developmental comfort of coming in and working with patients and families. And it's never just, we talk about this in all of medicine, right? We are family-centered care, but the truth is in pediatrics, we never just have a pediatric patient. We have a family and we have siblings. And we know that being able to pass in your your home promotes and fosters sibling grief in a way that no hospital experience can. So we're not just talking about the children that are dying, although they are a priority. We're talking about the families they leave behind. And, you know, in the adult world, it's the life we've lived. And in the pediatric world, it's the life unlived. And these children just deserve better services at the end of their life. So in answer to your question, I would be welcoming to a further discussion of either pathway, as you suggest. We just need a pathway, right? We just need steps forward.
Thank you. This is very helpful. Thank you for your testimony.
My pleasure. Thank you.
Thank you. Representative Dauphiné, followed by Senator Gordon.
Thank you, Madam. I just wondered, you know, thinking outside of the box, do you think offering some kind of training, volunteer training to those that are already doing hospice to have like an additional certificate for treating pediatrics would be a good way to start? And I mean, my sense is many of them would probably sign up for that additional training. I know I would have, but I just wondered if you thought that would be a good start.
So I think it's an excellent start. I think we are working with certain agencies. LNEC does great training, and we can supplement that. I teach throughout the state at different hospices to help support and empower people. I think the reality is that the volume of kids doesn't always allow for that skill set to feel so up to date. And so there's always that comfort piece that comes with it that is harder to meet. And so that reflecting on that last question, people who do it all the time oftentimes are better suited to continue to do it. But we are willing to partner with any adult agency and spend time with them, helping them understand what we do. And so, and, you know, we support them in the home. Our commitment through our program at Connecticut Children's is we'll support you, but I can't be in every home every day. And so we need help on the other end of the phone in the home taking care of these patients.
Thank you, Representative Dauphiné. Senator Gordon.
Thank you, Madam Chair. Dr. Moss, thank you for your testimony. I had an opportunity to chat with you in person earlier today, and I appreciate that you took that opportunity. Certainly my experience with hospice is as an adult cancer doctor. I don't take care of kids. But one of the questions I have for you is, as one is trying to see what we can do here in Connecticut, are there other states that are already doing this or along a pathway that we can learn from? And that you might be able to cite. Maybe other states are not, but I'm interested in what other states might be doing that we can learn pros and cons as far as what we might be able to do better here in Connecticut moving this forward, especially trying to do hospice care at home, which is where, in my experience, vast majority of people and their families want to be. They definitely don't want to have to spend their last days in a hospital or in a nursing home if they can prevent that, if at all possible.
Right. And we see that with children. The universal place that children prefer to be is at home with their siblings and their families. So I agree with that fully. I think we can look no further as to our neighbors in Massachusetts for some of the work that they've done to promote both palliative care and hospice care for children. They have some excellent programs and funding that allow for that. I think if we also want to look at a different case study, we go to the Midwest where you have much larger catchment areas for the children's hospitals and for care. And so they have very developed programs for children with hospice just because of location, right? If you're in Denver covering Montana, then you need places in between that children can get care. And so there's some really well-developed hospice programs in the out west, and there certainly is some lovely things that we could learn from Massachusetts next door.
Thank you, Senator Gordon. Dr. Moss, thank you so very much. Have a wonderful evening.
My pleasure. Thank you so much.
Next, we have Thomas Burr to be followed by Ted Melnick. Welcome,
Yes,
Mr.
good afternoon, Representative McCarthy Vahey, Senator Anwar, and members of the Public Health Committee. My name is Thomas Burr, and I'm the Public Policy Manager for the Connecticut chapter of the National Alliance on Mental Illness, otherwise known as NAMI Connecticut. I am testifying today in support of the following four bills: HB 5198, SB 180, SB 182, and HB 5197. You should know that as part of the country's largest grassroots mental health organization, we know that getting access to treatment in a timely fashion is key to recovery from a mental health condition. These four bills can have a very positive impact on access to health care. You have my written testimony, so briefly, HB 5198, the telehealth bill, we applaud you for extending telehealth. We feel it should be made permanent. I can tell you that as someone who's done public policy work in this space for the past 15 years, I don't think anything has had a greater impact than telehealth. We heard providers who had like a 30% no-show rate for mental health appointments have that no-show rate drop down effectively to zero. It's just been huge. To me, it's a complete no-brainer, and we just need to make it permanent. Regarding SB 180, let me just quote the former Connecticut healthcare advocate, Ted Doolittle, who testified in a similar bill back in 2021, and I think he says it best. OHA strongly supports reversing the burden of proof for medical necessity denials, such that the insurer, in effect, would have to seek permission to deny claims instead of the current situation where the burden to appeal is upon the family that is seeking care for a sick loved one. In other words, the judgment of a family's treating physician who has been vetted sufficiently by the carrier to be granted in-network status should be presumed valid unless and until the carrier shows that the treating physician's medical recommendation is not reasonable. The default judgment should belong to the in-network treating physician or other provider who has examined the patient, not to the insurance company doctor or other reviewer in another state who has never examined or talked to the patient. Therefore, we support SB 180. Regarding SB 182, step therapy. This bill would prohibit certain health cares from requiring step therapy for prescription drugs used to treat a mental health or behavioral health condition or chronic disabling life-threatening condition. As you may already be aware, step therapy or fail first policies mean trying less expensive options before stepping up to drugs that cost more. It's a tactic often used by health insurance companies to limit costs, but it often results in denying people with mental health conditions the care that they need and is an intrusion by non-medical insurance entities into the sacrosanct doctor-patient relationship. Mental health medications affect people differently, even those with the same diagnosis. And really, when you get right down to it, delayed care can often lead to significant negative outcomes, unnecessary suffering, unplanned inpatient hospitalizations, homelessness, criminal justice involvement, and in extreme cases, even death by suicide. The cost to individuals, families, and communities when a person must fail on a medication before getting what they need is simply too high. Connecticut state policy should protect, not jeopardize, access to mental health medications. Therefore, we support 182. Finally, HB 5197.
Excuse me, Mr. Burr, but your time is up.
All right, so we support HB 5197, and in summary, I support HB 5198, SB 180, SB 182, and HB 5197. I did a quick survey of members, by the way, and 96.3% of them support these bills. And thank you for your time and attention.
Thank you. That helpful tidbit at the end, that's a pretty impressive statistic. So we thank you for your good work, and you're absolutely right in terms of access. And that is what we are seeking to address here. Is there a question? Senator Gordon.
Yes, thank you, Madam Chair. And Mr. Burr, thank you for your testimony. And I appreciate the work that your organization does. I remember way back, I won't say how many years ago, so I don't give my age, back in medical school being involved with the organization. But I'm just going to focus a question on just one bill on the telehealth. And I'm interested in hearing a little bit further about what has been the impact that you've seen with the types of patients who have either mental or behavioral health issues, being able to get them to engage on a continual basis with either the care that they need or actually being able to stay adherent to the medications that they have to take. Many of them have to take it lifelong.
Yes, it's just had an amazing impact. Like I said, nothing that I've seen in the past 15 years from a public policy standpoint has had a greater impact than telehealth. It really has helped people keep their appointments, maintain their relationship with their doctors or therapists, and it's just really been a godsend. And it would just be, I think, malpractice, for want of a better word, for the state of Connecticut to go back to the way things were.
Thank you, and thank you, Madam Chair. And I would love to see if we can actually make the extension permanent so we can continue to provide that benefit to anyone who wishes to access it when appropriate.
Thank you, Senator Gordon. Thank you, Mr. Burr. Seeing no other questions, we will go to Ted Melnick to be followed by Greg Schengold.
Hi, my name is Ted Melnick. I'm an emergency physician practicing in Connecticut for 14 years. I'm board certified in emergency medicine and clinical informatics. And I also perform health services research, a lot of which is on the burden of the practice environment. So I think that'll come up towards the end. in terms of some of the questions about how are we going to get this data for Connecticut SB 181. I'm testifying today to share my experiences. My testimony doesn't necessarily represent the official views of my employers or funders, but really I see this for the folks that are making a decision here as a moral obligation. And so I'd like to get to that. And again, with little burden and moral obligation and patient safety on the line, just want to channel one of my previous mentors to say this is really a no-brainer. It's the first step in solving what's really a major crisis in our state. So the people that we serve in our emergency department, those patients and their communities, I wanted to start with a story of a neighbor, a retired physician. He had worked in our hospital for decades and unfortunately fell down the stairs and broke his neck. We stabilized him in the emergency department. I wasn't on the care team. I heard about this afterwards from him outside of the hospital. And after he was stabilized and treated, he waited in an uncomfortable stretcher with a broken neck for over 24 hours. He was appalled by this, how he'd been treated. And when I had to explain to him that this is actually our new normal, and there wasn't really anything that I could do or anyone I could bring this to, it really shook me to the core, and that's why I'm glad I can be sharing this story today with you all, and so that you can recognize that even for someone who had worked in our hospital for decades, that this is normal, waiting over 24 hours in a stretcher with a broken neck. But it's not just uncomfortable and undignified, it's dangerous. A recent study of more than 1,500 older adults found that those who spent the night in the ER waiting for a hospital bed had a 39% higher risk of death. So emergency department boarding is a crisis, and it's existed since before the pandemic. It's just getting worse. And we don't really know how bad it is or where it is without the tools to measure it and understand it. And that's what CTSB 181 will allow us to do. I don't think that we need to wait for the full recommendations of Public Act 2397 for this first critical step. Really, CTSB 181 can enhance and accelerate the Public Act 2397's success by helping us to better understand the current situation and then assess impact of recommended solutions. So the data we need to understand emergency department boarding and the risks it's placing on the people of Connecticut is necessary to overcome this new normal, waiting in the hallway with a broken neck for a week, or sorry, for a day. We do have people waiting a long time, but rarely, not a week. In the absence of more specific data, actually, my research team partnered with an electronic health record vendor to report hospital occupancy and ED boarding time across 1,700 hospitals nationally. And this is where I wanted to loop back to how getting the data is really not that burdensome. There's no burden to the data trails that are created when a patient is seen and evaluated. There's timestamps. These can be aggregated. We were able to do that across 1,700 hospitals and really see that when hospital occupancy exceeded 85%, median ED boarding time increased nearly threefold. So essentially you have gridlock within the hospital and in other parts of our public infrastructure. Like when our roads are gridlocked, we seek to understand it and fix it. And that's what CTSB 181 will allow us to do. So this data is there. It's been aggregated by thousands of hospitals, but we need to start to look moment to moment within our own hospitals to understand.
Excuse me, Dr. Melnick, your time is up. Thank you.
Okay.
Thank you so much for your testimony. And also thank you for submitting written testimony. The question that I was going to ask you is actually included there, which is the source information for that 39% statistic, which is very significant, as are many of the things that you shared with us today. Thank you for your time and your advocacy, weighing in on this issue. Seeing no questions from members of the committee. Thank you also for showing us the sunlight. We see that reflected on your face, so it's nice to know there's still sun out there. Next up, thank you. Next, we have Dr. Greg Shangle to be followed by Steve Wansik-Karp. Welcome, please proceed.
Thank you. Good afternoon, Representative McCarthy-Vahey and Senator Anwar and the distinguished members of the Public Health Committee. My name is Greg Shangle. I'm a practicing emergency physician in Connecticut for the past 21 years. As the past president of both the Connecticut College of Emergency Physicians and the Connecticut State Medical Society, I'm testifying today in support of Senate Bill 181. ED overcrowding is a longstanding problem. This problem is not unique to post-COVID situations. In fact, the cover of U.S. News and World Report, September 10th, 2001, the day before 9/11, was highlighting the ED boarding crisis. I personally participated in Connecticut's 2006 legislative ED overcrowding task force. And unfortunately, like many other task force, solutions were never implemented. Last year, another task force was created, and I'm serving on that task force. SB 181 reflects the recommendations of the current boarding task force almost unanimously. Each hospital already collects much of these data metrics or similar ones. As the saying goes, we cannot manage what we cannot measure. Collecting the data is the first step so the healthcare system can work together actually to understand the entire scope of the problem. We can no longer attempt to solve this problem at the individual hospital level. Then we can collaboratively implement changes to truly address the boarding crisis. As another saying goes, idiocy is doing the same thing over and over and expecting different results. This long-standing crisis is worsening and is a public health emergency, and we require new steps. Every day, Connecticut's emergency department cares for 3,800 patients. The doctors, nurses, and staff cannot care for these patients as we were trained. Boarding creates impediments to providing ideal care. Knowing we cannot provide optimal care is a major contributor to burnout. As we bear witness to additional distress caused by boarding, is it any wonder the staff burnout continues to worsen? 2021 AMA survey estimated 63% of physicians reported burnout systems. And the latest survey from Medscape said 68% of emergency physicians experience burnout. This contributes to suicide. There's almost 3 medical school classes dying every year from physician suicide. And the suicide death rates are 250 to 400% higher among female physicians when compared to other professions. As burnout worsens, more physicians choose to retire early or completely leave the practice of medicine. Knowing Connecticut may try and address this boarding seriously at this time will be much appreciated. I cannot imagine how any emergency physician will interpret this data gathering as personally impugning our profession. And this isn't limited to physicians. The entire staff, the nurses, the techs are also experiencing this burnout and leaving the emergency department only to worsen the nursing crisis. There's not enough nurses to staff the inpatient beds as it is. One solution further has been raised in this session and discussed last week, which is about Medicaid underfunding. By appropriately—
Excuse me, Dr. Shangold, but your time is up. Thank you.
By appropriately funding Medicaid, we can maybe find some of the nurses to staff. So I urge you to pass 181 so we can start to find solutions. Thank you for allowing me to testify.
Thank you, Dr. Shangold. Thanks for being here, but also for remaining committed to this issue for so long. We have a few questions for you, actually. Senator Anwar, to be followed by Rep. Cavros-DeGraw, and then Rep. Parker, then Senator Gordon.
Thank you so much. Thank you, Dr. Shangold, for your testimony, but also your commitment to the patients in the state of Connecticut. How should we respond when people say to us that let's wait for the entire report, don't do anything right now, let's wait for another year or so when the report is available, and then we can make some decisions?
Well, being on that committee, one, our committee wants this to go through now. We want the data so we can start to work together. Two, someone brought that up during the committee. I've been waiting for 21 years. As I said, in 2006, we had a similar committee where we talked about implementations. ACEP has published in that time, both in 2008 and more recently, a white paper on how to fix this and address it. So you need the data to understand it first, and then we can talk about the solutions. But we need the data first so we can sort of target the solutions. So to wait just doesn't make any sense. And hospitals already have this data. I've seen it in my 20 years as a medical director and as the chief of staff of the hospital. We have this boarding data. We just want to put it so the state can see it as the entire scope and not from the individual hospital level.
And the part of throughput within the hospital, how we are not able to mobilize patients or discharge them in a timely fashion, what are the 2 or 3 other things that can be achieved, if you could speak to them too.
Well, if you look at ACEP's white paper, definitely discharge by noon has been a solution that has been implemented. A balanced OR schedule. Most OR times are bundled together on a few days of the week. So if people were operating 7 days a week, that would help. And certainly getting enough nurses to staff the beds. There's more licensed beds than actually are staffed. So there is a problem where the beds are available, but they're just not staffed. And the ED boarding is also with mental health patients. I don't believe we've addressed parity with the mental health. We have to ask an insurance company if a patient's sick enough to be admitted for mental health. We have to ask the insurance company if that's okay, where we don't have to do that with any other entities such as chest pain or appendicitis, but now with mental health. And then they don't work nights and weekends. So people stay 3 days on the weekends waiting for the insurance to approve a mental health admission. And lastly is the prior authorization also for nursing homes. Now, as more sick patients are complex, we divert admissions in the emergency department to go directly to a nursing home. But again, they often spend 2 or 3 days awaiting the insurance company to okay that. So all of those things could be helped to try to alleviate this burden.
Can I clarify this? Did you just say that if a person comes on a Friday evening or Friday afternoon and the insurance companies are not available for their admissions to be approved, those patients have to wait in the emergency room for 3 days for that approval to happen?
So I'm dressed like this. I just came back from my shift. I happen to work Friday night, Saturday night, and then day shift today. And there was a patient that couldn't go home on Friday night. And today I signed the paperwork that the insurance company wanted. And they spent the entire weekend waiting for that. And they're still there when I left today. So that patient was, again, been there since Friday night. That's routine for us to have to wait for a weekend for many of these patients.
So the moral injury that all the healthcare workers in the emergency room are facing, the emergency department workers, the insurance industry's practices are a significant part of that.
I believe so. I mean, certainly the prior authorization and limiting who can go to nursing homes or to be admitted for mental health illness that's we've determined is serious enough that needs to be admitted.
Thank you so much. This is very helpful too. Thank you.
Thank you, Senator.
Thank you. Thank you, Senator Anwar. Representative Cavros Tegral to be followed by Rep. Parker.
Thank you so much. And thank you, Doctor, for being here today. Two things stood out to me. The first was when you mentioned that the article that you referenced at the top of your testimony was written or published the day before 9/11. I had a 9-month-old at that moment, and she's now 23. So I would ask, what from your perspective is taking so long for us to get a handle on this? And then the second piece is when you illuminated for us the number of doctors who are taking their own lives, which is just, horrendous. Why do you think that it is so much more significant for women physicians than men physicians?
So why has anything been done? I think it's hard, right? So everyone is busy and they've tried to put Band-Aid solutions, and that clearly hasn't worked. So I don't think it's a lack of people's intent to trying. I think there are certain incentives that are financial for hospitals to operate at 110%. There's a lot of burdens that go on. The Medicaid underfunding is certainly a burden. And people have a harder and harder access to unscheduled care. And so all of that care comes to the emergency department. I believe high deductible health plans have contributed to this because people cannot get routine care. And now they present with sicker and sicker illnesses, leading to more people coming in. So it certainly is multifactorial why this has gotten worse over those now 23 years since that U.S. News and World Report. As far as the gender gap, I don't know why it's worse for female physicians. It's possible because they have more, if they have more responsibilities at home than male physicians, that the stress is even more, but it just is a data, but I'd be guessing at what's the cause of that. I mean, I think it's all physicians, regardless of the gender, that are experiencing this stress. And it's certainly, as the nurse from Yale mentioned, it's not isolated to the physicians. The nurses are burdened by these patients spending extra time, and we're the face having to explain it to them, knowing that this isn't the type of care we want to provide, that we want to provide better care, but we're just hamstrung by the entire healthcare system.
I would say that, and I would imagine some of my colleagues would agree, that when we go to the doctor and they find out what we do for a living, we are often given quite a lengthy explanation of some of what you shared today, and I think that we will continue to do so. I certainly am glad that we're hearing this today, but I do think we need to get to the bottom of why those numbers are so different for women physicians, and hopefully we can figure out a way to do that. Thank you so much, Madam Chair.
Thank you. Representative Parker, to be followed by Senator Gordon and then Representative Cook.
Thank you, Madam Chair. Thank you, Doctor, for being here. I want to get a little bit into the working group. So just first to confirm, you are a member of the working group.
Correct. Well, I was a member in the 2006 task force, and I'm a current member on the current task force.
Great. And echoing the thanks for the many years of commitment to it. So in the policy we passed last year, that working group was set up to provide a report on January 1st of 2024 and annually thereafter until January 1st of 2025. So 2 reports. You got pretty close with the deadline for the first report. I think it came in a couple of weeks late, but that's great. I'm wondering, it feels like there's a sense that we've heard a lot about this idea of waiting for the final report for information to come out. When actually was it said that the second report needs to be the one where the recommendations come out that get acted on? Is that anywhere in statute or your understanding of how the working group was set up? Or could it be that this first report came out telling us what we should do or suggesting what we might do, and then we should do it? Does my question make sense?
I think so. Yeah. So I think the chairs have been doing a great job. I think our subgroups and our meetings have had very dynamic discussions, bringing a lot of experts together. And the whole premise we were working on was to submit this first report in time so that this legislative session might provide some recommendations so we can have tools that we can then sharpen our discussions on that final report. So that's what we've been working for all along, was to get this report out. And sorry about the missed dates, but as I said, I know the chairs are definitely committed to getting as much information as possible. And as a committee, we wanted this bill to be placed, and we want this information so we can see the entire scope. Because many times, as I said, each individual hospital already has this data, but we cannot see the entire scope of the entire problem.
Yeah, thank you for that. And for clarifying then that your committee saw this chance as this first report as a way to get in time to get some legislation done this year that will help you for the second report, which doesn't maybe need to be framed as the final and enacting report. And I want to be clear, I have, it's not saying that it's a problem that you were a few weeks after January 1st. I think it's incredible that what you did in that timeline, and the co-chairs are doing excellent work. And to that point, as stated in the policy, the co-chairs actually have a representative from an association that supports hospitals in the state, wherever the language is not in front of me, and also emergency physicians. So it seems like there's pretty good representation on that committee. My last question is, I know that the subgroup made a unanimous recommendation that led to the legislation for today. Can you speak to how the full committee ended up voting on that recommendation that was made unanimously by the subgroup?
I don't have the minutes in front of me, so what I'm doing is from memory, but we actually had a vote on the recommendations twice. And the first time, I believe it was everyone voted for it except for one member. And then when we repeated the vote, it still was an overwhelming majority to get a person to have metrics reported publicly through DPH. And I believe that's paraphrasing, but that's what the recommendation was, that we had mandated publicly reported metrics. And we didn't exactly have the metrics at that time, but I think this bill does reflect metrics that would help us understand the problem.
All right. Thank you so much for that. That's really helpful to hear about. Appreciate your work and your time today. Thank you, Madam
Thank you.
Thank you, Representative Parker. Senator Gordon, to be followed by Representative Cook.
Thank you. Dr. Schengold, thank you very much for your testimony, and thank you very much for the work I know you've done in leadership with your colleagues who do emergency medicine, and also for the work you did when you were president of the Connecticut State Medical Society. That's a tough job. I know that very well personally. I just want to follow up on a question that was already raised and that you answered, but I think it's a very important point that can get overlooked, is as far as the red tape and the delays that we get from insurance companies in trying to approve care that we know needs to be done, which is not a minor issue at all. And my question to you is, not just on weekends, but we face this even during the regular work days, waiting and waiting to figure out what we call dispositions for patients who by default we have to admit, but if we can get them to a nursing home or get their home care set up, then we're actually able to, for example, get them out of an emergency room quicker than otherwise. But what has been your experience in general with that, and what you've been hearing from your colleagues over the years, separate from whatever may have happened during the pandemic, as far as more and more of these delays and the length of the delays? Because we're talking sometimes days, just not a number of hours.
Yeah, thank you, Senator. It certainly has worsened in my 21 years. As you said, we used to admit these patients so that they would be in a hospital bed, but now that the hospitals are completely full, many of these patients just remain in the emergency department. It's not safe for them to go home. Certainly, our aging population, where people live longer, is likely contribute to it, and they live with more complex issues. But there's not a shift that goes by where I don't see an elderly patient who fell at home, who has an unsteady gait, and going home to that situation is completely unsafe. And fortunately, maybe they don't have a broken hip, but I know if they go home, they can lead to a broken hip or worse situations. I mean, I've seen plenty of elderly people who've spent 24 hours until someone checks them on the ground at home. So when we see patients like that, we want to have a safe disposition. And that often means that they need to go to acute rehab. And those patients do not often leave within 24 hours. It's often 2-3 days, and then it gets worse. And the other place where we've seen pre-authorization issues is doctors need certain tests. They know they need the tests, and they're having trouble with getting it timely. And so many times these patients present to the emergency department in an attempt to get the test. And that is a further cohort of patients that we're seeing in the emergency department, where we know they may need an MRI because they have severe neurologic symptoms, or they need a CAT scan for their abdominal pain, and they can't get the pre-authorization, so they come to the emergency department to bypass that syndrome. So all of these are separate issues on the pre-authorization. And as I mentioned before, the mental health is a severe one, where it's a disease entity that doesn't have parity with the rest of healthcare.
Thank you, Senator Gordon. Representative Cook, to be followed by Representative Zupkis.
Thank you, Madam Chairman. And Doctor, I'm sorry to see that you're on a hot spot, but you seem to be a wealth of knowledge. So I want to thank you and thank all the medical professionals out there for taking care of us in such good manners. I want to touch base on, as we're talking about this jam up in the system, the one thing that is being missed, I think, in all the conversation is the required observatory or observation status, if you will, to where we're clogging up the emergency rooms because the insurance companies won't approve, but yet you have this observation which could last 24 to 48, sometimes 72 hours for a patient before the insurance company truly ever approves. So as we're talking about prior authorization, they're also saying, hey, look, we just don't know where they fall yet. So we're going to keep you in this observation status to figure out like what may or may not be happening. Which I find that really hinders the transfer, the Medicaid, Medicare population, because they have to do, so many days of inpatient. And if they're not inpatient, then they don't get their benefits to kick in. Are you all seeing the same problem across the board with that as well?
Yeah, I think you're talking about the 2-night stay for Medicare so that the nursing home stays can be approved. And many times people don't meet some third party. A lot of times they use the word interqual, that they don't meet admission criteria, but we know going home is not safe. So we can't put them in the hospital. So we keep them in the emergency department. And sometimes there's a medical, someone might have a urinary tract infection. We treat them with antibiotics and IV fluids. And if they all of a sudden perk up and get better, maybe an admission is averted. But those longer stays occupy the rooms. The most EDs have the limiting function is the number of rooms. We've all become accustomed to treating patients in beds and unfortunately now in waiting rooms. And so every time there's a room that's occupied, there's a new patient coming in that we have to treat somewhere else, or we have to take these patients in an undignified manner and put them in the hallways. So all of those are contributed, but that did get a little bit better because that rule was suspended during COVID, where you didn't need the 2-day stay to require that. And we did see some slight improvement with that, that they didn't need a 2-day stay. But you're right that when a person's in observation status, it doesn't count as an admission. And so Medicare will not pay for the skilled nursing facility without a 2-day hospital admission.
And then with that observation status, then we turn around and still battle with the insurance companies as the roadblock from the professionals versus what the insurance companies feel is appropriate, correct?
It's my understanding is if they're in observation status, that doesn't count as a day of admission. So if they spend 24 hours, that's a day that's not there. I don't know if they can backdate it or not. I don't get into those weeds, so I apologize.
No. I appreciate it. Thank you, Madam Chair.
Thank you, Representative Cook. And Representative Zupkis, I believe you're our last member who has a question. Thank you so much.
Be quick. Thank you.
Thank you. No,
be quick.
thank you.
I just want to quickly ask about the task force. I believe it was formed in 2006. Is that correct?
So there's 2 task forces here that I've mentioned. When Peggy Sayers was a representative, she had a task force about this problem in 2006. Dr. Carius, myself, and Dr. Brewer, all emergency physicians, were on that task force, and we met as any other task force, and there was not really any resolution to the problem. One of the things that came out of it was trying to cut into the prudent layperson and say, well, if we just didn't have people with Medicaid come to the emergency department, we wouldn't have boarding. And it was the furthest thing from the truth. We embraced the prudent layperson, and the new patients coming in is not the problem. The problem is boarding. Those patients that need to be admitted that cannot go home, that stay in the emergency department, occupying a majority of the beds.
Right.
Because this problem got worse, a new task force last year, a brand new one, was created.
Okay. And I'm looking at it, I believe the correct one, there's like 20 people on it. Are those the right people to be on it?
Many of us on it are frontline emergency physicians dealing with it, but there's also people from the mental health world on it. There are people, DPH representatives are on that committee. Hospital administration is on that committee.
Any hospital administration? I'm just like, I think
one of the co-chairs is a Yale hospital administrator.
Perfect. Okay. but because as I'm listening, and I know this bill is about the data and for us to pass a law to get the data released. Is that the only hurdle? So if this law passes and y'all get the data and you can study it and know, understand all of these things, like I guess is, and then we can move forward and this will be taken care of. I guess my point is I just don't want to sit here for 10 more. Well, I probably won't be here in 10 years, but I don't want this to be in this committee for 10 more years and we're still talking the same thing.
Or 18 more, or 18 more years, or 23 years, if you look at the cover of U.S. News and World
Hopefully it'll
Report.
be solved next year, but
I think the data will, you know, when you implement changes, you want to know that that implementation is addressing a problem. So if you establish a baseline, understand the problem, see where where your efforts can provide the biggest value, and then have recommendations. And then I think next year's report will, if needed, will make recommendations. You know, many of these things are at the hospital level that can be done, and sometimes seeing the global thing will help create the right incentives so that we can solve the problem. But it's everything working together. It's the doctors, the hospital systems, the insurance companies, and the state policymakers, I think, working together to address the problem.
Great. Well, thank you, because if people are sitting there over the weekend just because they can't get an insurance form signed or something, that's a problem. So hopefully that's at the top of y'all's list. Thank you.
It's definitely a topic being discussed at the committee.
Thank you.
Thank you, Rep. Zupkis and Dr. Shangold. What a robust conversation here. So needed, and you're highlighting, all of you in this conversation, the various roles that different committees and different stakeholders play. Here in public health, we have purview over some of those, and we know our colleagues in insurance, others, but the gift of having the various stakeholders at the table together is what this group is doing, and I appreciate very much your work and your time. Thank you. Before we go on to our next, I was going to say witness. I know we're not in court, but I wanted to just note that we are on our 46th person testifying, and we have 74 people signed up today. So I just remind members of that as we are asking questions. We want to make sure we get to hear from as many folks as possible. And with that, Steve, I'm going to turn it over to you. And we are then followed by Dr. Kenneth Robinson, I believe is here in the room, or was, yes. So please proceed. Welcome.
Good afternoon. My name is Stephen Weisser-Karp. I'm Executive Director, National Association of Social Workers, Connecticut chapter. We're here today in relation to two bills. One is the telehealth bill. We have submitted detailed written testimony. So let me just suffice by saying NASW supports the bill. We believe an extension of the law is good. We believe permanency is better. In regards to an act concerning social workers, again, I have submitted to you written testimony that goes over the benefits for licensees, the benefits for licensing authorities, and the benefits for states. But I want to very briefly tell you about a little context to how we got to this bill. Department of Defense funded an effort to get this compact throughout the country. They gave money to the Council of State Governments. The council in turn reached out to all the major organizations that represent social work. They created a technical assistance group of about 30 people, 30 statewide stakeholders nationwide, including myself. We went through the provisions of the bill, made recommendations. The bill was then went to another committee that did the actual drafting of legislation. Once that was all done, the bill then was, or the proposed compact went out for public comment. I can tell you that CSG says they have never had so many comments from any profession as they have by social workers. So I say this just mean to tell you that this bill has gone through a lengthy 2.5-year process roughly to get to the point where you now see this language. This bill has been vetted and vetted and vetted and is now being introduced across the nation. It's most important to know that there needs to be 7 states to adopt it in order for the work to begin on the compact, which in itself will take a couple of years. 2 states have already adopted it. We fully expect by the end of 24, there will be at least 7, probably more states. One of the advantages of passing it in 2024 is that Connecticut will have a seat at the table. The bill would then basically create a commission, and as states join the compact, they would get a representative on that commission that will develop the rules and regulations that will make this possible. It's very important, I believe, that Connecticut has that representation. 2 years ago, the psychologist psych pact was passed by this legislature. Last year, the professional counselors contract was passed by this legislature. And we're asking you now in 2024 to come forward and bring this bill forward and to pass it. This bill clearly will assist in workforce issues. It will make it possible for social workers to practice in multi-states at a time when there's needs throughout the country. With telehealth growing, we know that there is an importance to being able to practice in various states. Right now, to do that, you have to apply to every single state. You have to pay the fees for every single state. It is an onerous and expensive process. This will allow social workers, clinical social workers, to at least practice in compact states. It will apply to licensed master social workers and licensed clinical social workers. You will see that the language includes baccalaureate social workers. That is only for states that have a baccalaureate license. I do need to emphasize that.
Excuse me, Mr. Carp, your time is up. Thank you.
Just to emphasize that the language cannot be changed. So what you're looking at needs to be the language that ultimately passes. And I thank you for your time.
Thank you so much. That's actually an important point that you shared at the end. And I would like to thank you for the time and work that you have invested on this on a national level on behalf of the social workers of Connecticut, as well as the entire nation. We have a question from Representative Dauphiné.
Thank you, Madam Chair. Thank you for your testimony today. A couple questions. Do you know if the bill today will allow multi-state social worker license holders to use the Haven services?
Yeah, that's a good question. That's been brought to my attention actually just today. The issue with the Haven services is that if you currently are out of state and you apply for a Connecticut license, the $5 of that fee goes to Haven. Now, under the compact, you will sign through your own home state. So wherever your resident state, you'll get licensed through the compact. So you will not need to get a Connecticut license. Now, how many social workers are out of state and licensed? We're actually taking a look at that. I just contacted DPH today. They gave me a link to identify that number. We don't think it's a significant number, quite frankly, but there would be those social workers who are currently licensed out of state. If they join the compact, assuming Connecticut passes it, if they join the compact, there would probably be a small loss in revenue for Haven. Again, we don't think it's a big number, and I'm going to be looking at that number and be glad to get back to you as to what that looks like. It's not going to be anything like, for instance, nurses. We are talking about multiple thousands of nurses. You know, we're probably looking at a pretty small number of social workers who are currently licensed in Connecticut but don't reside in Connecticut.
Thank you for that answer. Do you know if the social workers who will be working in Connecticut under a multi-state license with this bill are going to be required to pay the same license fees to Connecticut and renewal fees to Connecticut?
That's a good question. Yes, if you're in Connecticut, you have to go to your home state to get on the compact. What that means is you have to maintain your Connecticut license, and then you would get a compact license. So it's actually 2 different licenses. You have to maintain and be in good standing on your Connecticut license in order to be part of the compact.
Thank you for that answer. And one more, if I may. Do you know if a social worker in Connecticut under the new compact privilege will be required to pay a new fee, like a compact privilege fee or some other fee? I ask because Haven receives $5 from each renewal fee each year in Connecticut through the Connecticut license renewal. And if there's no new fee, then there may potentially be a funding shortfall. Can you
So
speak?
that's actually more probably a DPH question. I mean, there's nothing that I've seen in the compact that would disallow DPH from continuing the $5 fee. But I'm not an expert on that question, so I think that would really be something that you'd have to bring up with the Department of Public Health.
Thank you, sir. Thank you for your time.
Thank you. Thank you for your thorough testimony, and we know that we will be continuing to work on this. I just will note, besides last year doing the licensed professional counselors, we also did the physical therapy compact, and we have had others approach us, other committees, I believe both Commerce and who's the other committee who's doing, forgive me for thinking aloud, a couple other committees, Veterans, thank you. Here, Senator Marks is right here. Are looking at licensure and how we're helping to address the workforce. The compact drafting is extremely complex. So this is why, as a committee, we don't take on, 5 or 6 of these because it's a lot from our nonpartisan attorney. So I just wanted to share that for the information for members and help folks to know that we were going to continue having some of these conversations, and we'll be seeing another compact here later this session, the nursing compact. Senator Gordon.
Yes, thank you. I'll be real quick, and I just want to follow up on what my colleague, Representative Dauphiné asked, because the Haven issue is an important issue, and it always struggles for funding. But one of the questions I have for a follow-up, if I may, is if someone participates in the compact and they need Haven services, and they certainly could benefit from Haven services, what is the confidentiality provisions? It's one, if you're licensed and you're here in Connecticut, and Haven does maintain very good and strict confidentiality for important reasons, given the services that it provides. But what do we know about the confidentiality? Is it the same if someone is out of state, but is partaking in the compact and thus is doing things here in Connecticut and participates in Haven for whatever reason and receives the services?
That's a good question. I honestly can't answer because every state does have different rules around confidentiality. I'm not even sure if an out-of-state social worker in the compact could participate in Haven. So I don't have an answer to that. And I don't have an answer beyond saying that each state has its own rules, and the state that the social worker is practicing in, they have to meet those rules, but they also have to meet the practice standards of the state, both the state they reside in and the state that they may be practicing in. That could be a different state.
Thank you. And I think any of the compacts we look at, we just want to make certain we're aware of any of the confidentiality rules, that none of them are weakened or gotten rid of just because somebody participates in a compact.
Thank you, Senator. And thank you, Mr. Wansit-Karp, for being here with us and for all your years of advocacy. Have a great night. Next on our list, we have Dr. Kenneth Robinson, to be followed by Kat Parker. Could you do me a favor? I'm sorry to interrupt. If you could press the button on the desk right in front of you. Thank you.
Haven't
So if you
testified in
could
a couple
start
of years,
over,
so.
that'd be great.
Good evening, distinguished members of the Public Health Committee. My name is Dr. Kenneth Robinson. I'm an emergency physician at Hartford Hospital and have been at Hartford for 29 years. Presently, I'm the Vice President for Academic Affairs at Hartford Healthcare, but up until August of this summer, I was chair of the Department of Emergency Medicine at Hartford. Thank you for the opportunity to oppose SB 181. I know that sounds unusual coming from an emergency physician. You've heard plenty of testimony today that we all know that overcrowding is a serious problem. We don't need to study that specific fact anymore. What we need to study is what are the factors of that. And just remember that ED crowding is a lagging indicator. There's factors that cause it. So we need to understand what those are. So consider the simple operations management model of input, throughput, and output. And consider the throughput is ED operations or even broader to hospital operations. And we'll just leave it at that right now. And that's where the crowding would be. Input, There's many things, and things that increase input would increase crowding. Things that decrease output would also increase crowding. So the things that might increase input are lack of primary care. A patient gets sick, they call their primary care physician. There's not enough capacity in their office. They send them to the emergency department. They may not have a true medical emergency, but they're sick, they need to be seen, but there's not enough capacity in primary care. In the same way, we've heard plenty of stories today, just the short time I've been sitting here, regarding similar lack of capacity in behavioral health services and addiction services. We see plenty of people in the emergency department that don't have a true crisis, but they don't have anywhere else to go, so they end up there. These are inputs that are increasing the crowding. Also, Dr. Shangold, I believe, mentioned home health services and elder services. Same thing. A lot of those patients are brought by their family members because they can't care for them at home, but they don't really have true medical emergencies. If there was capacity in those systems, then that could minimize some of the crowding. Now, on the output side, now these things, if they slow down output, so things that like capacity in EMS. When we're in the hospital, we call EMS to take a patient home or to rehab or to a nursing home. If there's not enough capacity in the system, we often wait hours, sometimes a really long time, for an ambulance to show up to take the patient out. So that creates crowding. In the same way, the lack of capacity in rehab system and nursing homes, same thing. Patients are waiting a long time for beds. You've heard some description of that already. And everyone's favorite topic today seems to be authorization. Greg had a greater, Dr. Shangold had an even worse story than I have. We've commonly had people waiting over a day for authorization. If you consider an average length of stay of an emergency department bed, a patient is 8 hours. That means a person that waits 24 hours is taking up 3 beds for 3 patients in the waiting room. That happens a couple of times a day. You can see how crowding really escalates. So,
excuse me, Dr. Robinson, your time is up. Thank you.
I'd say that tracking crowding is redundant. We already know that's a problem. We need to focus on understanding the metrics that cause crowding and then direct our work at those issues.
Thank you, Dr. Robinson. I know we have a few questions, starting with my good co-chair, Senator Anwar.
Thank you, Dr. Robinson. Thank you for your testimony and waiting with us this afternoon and evening. If you can't measure, you can't fix. We say this all the time in so many things, but it's surprising for me to hear you say that we don't want to measure. How are you going to say that we tried to fix? Because the solutions to arguably everything wrong with the healthcare system results in the emergency room crowding. And for us to say that we're going to fix the rest of the entire healthcare system and the insurance industry's abuse and whatever is happening, only then we will be able to say, well, let's now see what happened in the emergency room. So I'm trying to understand, why don't we start to measure today, and then we try to chip away on the very difficult issues that we are dealing with on the outside, not from understanding, but delivering, because there are so many powers that are at play. So I would have expected you to say that we want to measure it so we can actually keep track of it, and we will see how it's going to get better every few years. But I didn't hear that.
We know it's an issue. We don't need to measure it. We have so many other factors that are affecting this that we don't have data on, that we don't truly understand. We know crowding is an issue. We know it adversely affects the health of the citizens of Connecticut, but we don't know the true impact of lack of primary care capacity or EMS capacity or anything else, authorizations. Getting a number on crowding isn't going to help us. Getting a number on any of those other input or output metrics is going to help us, because that's where the work is. The work isn't on crowding. It's on either the throughput factors or the output. So I guess I'm a little bit impatient. I don't want to wait a year to start the work on this. I mean, like, we know this has been going on at least since 2001, if you can believe some of the testimony, and I'm not refuting that. We've known that crowding is an issue for decades. We don't need another year to get numbers on it. We need to figure out what the true issues are, get numbers on those, understand those metrics, and work towards those.
if you'll notice a number of bills throughout this session, we are going to look at some of those aspects, and perhaps there'll be some in the insurance committee, but a lot of those will be in this committee where we will be looking at many challenges that we are facing in the state for outpatient and inpatient care and the emergency care. But that's a journey, that's a 10-year, 20-year journey. So you're saying that we take that journey and then start to measure it after that. So I'm not convinced, but I appreciate your testimony.
Thank you, Senator Anwar. Representative Parker, to be followed by Senator Gordon.
Thanks very much, Madam Chair. Thanks, Dr. Robertson, for being here and for your time. I know it's been a long day and lots of voices on this issue as it's gone along. And I appreciate you acknowledging also that you previous work as the chair of the ED, so you really do have that perspective. I have a few questions about your testimony, written testimony. What I understood as 3 main points, and I want to maybe give you a chance to clarify those. The first one you had referenced was that people may choose in an emergency situation to go to a different hospital based on metrics they saw online. It seems to me that if someone's in that situation, they're probably not searching the DPH website to find which hospitals have lower times or whatever, but I wonder if that's what you were referring to, and if that's, it doesn't strike me as the most compelling reason, but I'd love to hear you clarify that if so. And I have sort of similar things with the other two, so I'll just go ahead and share them. The second was that it might lead to a lack of public trust in emergency departments. It seems to me that what we're talking about and the well-known facts of people being in EDs for over 24 hours when they work in the place and everything else that goes along with it is eroding public trust. So that also doesn't seem that compelling to me. And then the final one is that it's burdensome to the EDs, the collection of this data. And we've heard testimony earlier. My understanding is that the burden is potentially on our friends at CHA and maybe even DPH, who we could hopefully fund to do this work, and not on the providers in the EDs that are doing heroic, important, valuable work every day. So am I understanding your 3 points of issue specifically, and would you like to clarify any of those further?
Sure, I'd be happy to. The first one I think was if someone looked at the DPH website or wherever this will be publicly reported, that could affect where they seek care in an emergency department. It may be, they may have an injury or an illness and they may check after that and think, I'm having chest pain. Where should I go? Where am I going to be seen the fastest? Well, they may look at that, sometime when the metrics come out and just have that in the back of their head. My worry is that this will affect where patients seek care because they don't understand what's happening in the emergency department. They may think, I have a really serious condition and I want to be seen right away, but at Hartford Hospital, the wait time or the boarding time is this. That sounds horrible. I'm going to go to a place that has a lower number. What the public may not understand about ED operations is if you present to the emergency department with a serious issue, heart attack, acute stroke, significant trauma, you go straight through to our resuscitation room. So I wouldn't want someone to use these numbers to decide where they're going, only to go to a place that may not have the state-of-the-art equipment to care for them in a timely manner, only to have maybe a less appropriate treatment and then be transferred to one of the centers that can manage that. So that's my background on that.
Sure, I appreciate that. And the work to then educate the public around what these metrics actually mean and what to do with them or not is maybe an important piece of that. So then my just final question to you is, if we were to move forward, the committee chooses to move forward with this proposed legislation, is there anything from your perspective in your position at a really critical institution in our statewide health network that we could do to make this work as best as possible so it's not having some of these negative impacts at Hartford? And that could be a thing we talk about more later. So
yeah, I think that the publicly reporting causes some problems with this. If you need to know the data, I mean, you can get that very quickly. I can pull my phone out and tell you in 3 seconds pretty much how many people are boarding in Hartford Hospital Emergency Department right now. And I can tell you the times that they've been waiting.
That's incredible to hear. I think we've been getting a sense that it might be that easy, and you're actually saying it would.
I mean, I don't know the exact metric you're looking for, but it's in everyone's EMR. My worry is the way the public reporting will be used. one of the things that we just talked about. Now, the other in trust is I imagined this written in the paper. And if you look at a way a newspaper article is written, there's a paragraph and a long column usually. And the first paragraph will say something like ED overcrowding, a significant problem, da-da-da. I feel like few people read past the first couple of lines and then they'll think that ED crowding is still an issue and, things aren't being done about it and just have a negative connotation of emergency departments and hospitals in general. So that's how I thought that it would adversely affect the trust. But I understand that you need the data. I just think that there's some potential unintended consequences to publicly reporting it. And we need to move a little faster.
I really appreciate you sharing that. So I think what we're hearing is the sense that this data might not actually be that hard to get, but how and where it's reported and how it's utilized the most effective way is going to be the key issue for you. Let me just make clear that the questions that I'm asking do not suggest anything other than, like I said, a respect and admiration for the work that your hospital does and everyone else that's been represented today. And I hope that anyone that's listening, if anyone is listening out in the public about this, is not taking our questions to suggest that we think there's not great care going on in EDs, given the immense challenges that you folks face. And hopefully we can help try to solve some of those too. Thanks for your time, Doctor. I really appreciate it.
Thanks. I didn't take your questions that way.
Thank you, Representative Parker. We're here to make changes and there's always room for improvement. And that's what we collectively are doing together, those of us on this side and those who are testifying. Senator Gordon.
Thank you, Madam Chair, and thank you for testifying. As I've talked about earlier during this public hearing, I'm well aware of what goes on, given the other hat I wear, which is a doctor. I did read your testimony. I read through all the testimony, and I have to say I respectfully disagree with saying we should not move this bill forward. I support it. And certainly I think a lot of emergency room physicians do. I don't think there's anything wrong with us getting more data, separate from how that gets presented publicly. And I've had some issues in the past with the way that CMS on the federal level presents certain statistics on hospitals. But for us to be getting more data, I think is helpful, while at the same time working on some of these big issues, which I know last session there were things being done on it. This session there were things trying to be done on it. And I understand the impatience, but I don't think there's anything wrong with us trying to better get data. And as my colleague, Senator Anwar mentioned, if we're going to try to understand certain outcomes, that is very helpful for us to see certain metrics. And in fact, I just want to quickly cite the excellent testimony submitted by Dr. Mike Carius, who I know you know, and he's a good friend of mine, emergency room physician for over 40 years. And he does actually strongly urge us to pass this bill, recognizing that getting certain statistics and getting certain metrics and understanding, he says, would be quote unquote meaningful. And I do agree with him. So there's nothing stopping us while we're trying to get more metrics and understand more, to have certain outcomes data based upon what legislation ultimately gets passed and what rules ultimately get made to work on these other issues. So I think that one can take away from everything we're hearing, yourself included, and do various things in a parallel concurrent track. And I would encourage us and my colleagues throughout the legislature to be working in that regard on what we can do in a meaningful way. Thank you.
Thank you, Senator Gordon. And I thank you for your time and testimony. It's certainly, we all have different perspectives. And when you're an emergency department physician working on the front lines and having to answer directly day in and day out to patients who are struggling and in their most vulnerable moments, and you don't feel that you have the power to do for them what you'd like to do, it's difficult. And wearing an administrative hat, as you now do in a different way, you see a different perspective. And I understand that. I think the thing we all share is that we know we need to do more. And I think what we are doing here in this committee and in other committees is to try and address some of those very issues that you're talking about. I do think that we will continue these conversations with the working group and with all of you who wear those hats out in the realm of caring for our patients. And we're very grateful for the work that you do. Thank you.
Thank you.
Next up, we have Kat Parker, to be followed by Ben Shaken, then Jim Williams. Is Kat here with us? Okay, I guess it's getting late. So Ben, we have you here in the room, and then Jim Williams on Zoom. Welcome, Mr. Shaken.
Good evening, Madam Chair, members of the committee. I'm Ben Shaken. I'm the Director of Government Relations at the Connecticut Community Nonprofit Alliance. I am joined by my colleague, Monica Nugent. We're going to touch on two bills today. I will take the first one. She'll take the second one. The first one is the Telehealth Bill, House Bill 5198. We are here in support of this bill. Let me just back up. We're the statewide association of community nonprofits. In case you're not familiar, it's been a little while since we've been here in front of the Public Health Committee, and it's good to be back. Community nonprofits serve 500,000 people across the state, and our membership includes the community-based network of clinics, behavioral health clinics that serve adults and children and families with mental health and addiction needs. So telehealth is, as you've heard from folks before us, one of the sort of silver linings, if you will, that's come out of the pandemic as it relates to behavioral health services. Taking you back to this time in 2020, Connecticut was actually one of the last states to adopt telehealth services across its state system, and we implemented it really quickly through executive order and through some other changes, and it has worked really well. We submitted written testimony with a number of statistics, but I will just say in brief that echo what Mr. Burr said earlier, that our providers are seeing a significant increase in adherence to treatment plans, in access to care, especially for families that are juggling multiple priorities. And it's become, now that we've come out of this pandemic, and in-person services are still offered or are offered again in significant ways, just sort of a tool in the toolbox. It's something that our providers are able to use to keep folks engaged in treatment, perhaps in between visits or when it's medically correct for the patient. The bill just changes the date, which we support. We agree with everyone who said permanency would be great. The important parts of this bill that passed a few years ago that are being extended, number one, it pays for telehealth at the same rate as in-person visits, and it allows services to be delivered from any setting. Payment should be based on the treatment that's provided, not on where it's being provided. It also allows for, in certain appropriate circumstances, telephonic or audio-only telehealth visits where you don't have to be on camera, which is important in particular for the clients that our members serve, many of whom don't have the same kind of access to technology that you or I may have. And then finally, it also allows providers to use any HIPAA-compliant platform rather than the state sort of prescribing all telehealth services will be on this platform or that platform. And it lets providers meet their clients where they are. So we encourage the committee to support this bill. We'd look forward to working on this proposal or others in the future that go towards some kind of permanent solution that will work for providers in the state. And I will turn things over to Monica.
Hi, good evening, everyone. So as Ben mentioned, I am a public policy and advocacy associate at the Alliance, and the second bill we're here to support is Senate Bill 182. You have our written testimony in regards to this bill, so I will summarize very briefly that since the COVID-19 pandemic, 38% more people are in some form of mental health care, and medications for various mental health conditions are part of this care. We encourage passage of this bill because the patient-provider relationship is important. The patient.
Excuse me, but the time for testifying is up. Thank you.
We just urge your support.
Thank you. Thank you. And thank you for submitting written testimony as well. I have a question just about that statistic that you just shared. 38% of people of Connecticut are in some form of mental health care. And if you can share your data source, I'd love to look.
Nationwide,
Okay.
there's been an increase in 38% of people, and that's from the Pew Charitable Trust that they did a study on the mental health crisis in the US.
Thank you very much. And the Pew Charitable Trust is certainly a very reputable source for us. Mr. Shaken, I'll say it's nice to see you here in public health after all the years we spent together in planning and development. And we appreciate you both being here and spending time staying here in person with us. It's nice to have the option, virtual and in person, right?
Thank you, Madam Chair. We'll be here upstairs all night in appropriations if you need us.
Okay. Thank you so very much. Next on our list, we have Jim Williams, who is joining us via Zoom. Welcome, Mr. Williams.
Yes, thank you very much. My name is Jim Williams. I'm the Government Relations Director for the American Heart Association. I'd like to thank the leadership and members of the committee for providing me with the opportunity to provide comments on House Bill 5201, for which we are in strong support. Tobacco use is still the nation's #1 cause of preventable death and disease in Connecticut. Yet the governor's proposed budget sweeps the $12 million in annual tobacco control for fiscal year 25, intended for education, prevention, and cessation, back into the general fund. This funding is critical to help in preventing new tobacco users from going down the road of addiction and tobacco-related disease, and to help current users who want to quit. The last time this funding was swept was in 2016, and it was not reinstated until 2022. Unfortunately, this has happened many times in the past. This bill proposes that Connecticut invest the minimum CDC recommended annual amount of $22.7 million. Full funding per CDC would be $32 million. Tobacco control in Connecticut should be viewed as self-funding, as Connecticut takes in approximately $367 million every year in tobacco product sales revenue and annual disbursements from the master settlement. One thing you may have heard from OPM is that there is a $24 million backlog in tobacco control funds. This is not entirely true. It did take quite some time to reconstitute the Tobacco Health Trust Fund Board, which awaited appointments for numerous leaders. The board's job is to ultimately suggest to the appropriate committees of the legislature, the Public Health and Appropriations Committees, how they would like to invest the funds. To be clear, the initial $12 million approved by the legislature in 2022 has gone through the board process, and their recommendations on how to spend it are currently before those committees. The second $12 million approved by the legislature in 2023 becomes available in April of this year. The process has taken some time to get up and running, but it is doing so now. Any successful program relies heavily on continuity of funding, which is why we cannot simply allow these funds to be swept again back into the general fund. The reality is that if they are simply swept, as the governor states, it will be extremely difficult to approve funding in the future. We hope that you not only will support this bill, but will also consider signing on to it as a co-sponsor. Thank you very much for your time and thoughtful considerations.
Mr. Williams, thank you for your time and tireless advocacy. You said the CDC full funding was that 30 million?
CDC full funding for Connecticut is $32 million, and the minimum is $22.7 million. The last 2 years, due to a lot of work by advocates and legislators, was that we were able to get $12 million in 2022 and 2023. But before that, there was $0 from 2015 up until 2021.
Thank you. And thank you for clarifying. I just wanted to clarify that for folks, that the CDC full funding recommendation for Connecticut is that amount that we as a committee last year passed a bill recommending the CDC minimum recommendation of 22.7, and what was funded was 12 million. And now this year, the idea is to take that money back to zero. So just underscoring that for anyone who might still be listening and those of us in the room. So Mr. Williams, we look forward to continuing to work together with you. Senator Amor and I have been steadfast in our belief and support that these funds are so needed. So we're thankful for you.
Thank you for your time.
And next up, we have Brian Heindel. Forgive me if I mispronounced your last name. It's been a while. Followed by Ruth Kenobi. Welcome, Brian. It's nice to see you.
Thank you. Good to see you again. Yeah, my name is Brian Heindel. I apologize for the background noise. I'm in a conference room. My name is Brian Heindel. I'm with Henkel Corporation, and I'm here to testify in strong support for SB 178, the textured hair legislation. First off, I'd like to really thank our state senator, Senator Miller, for her leadership and commitment to this issue and raising it today before the committee. So we're really appreciative of her efforts to get us to where we are today. This bill would require that all cosmetology schools in Connecticut provide textured hair education. Right now, cosmetology schools do not teach cosmetologists how to treat and cut textured hair. And we really feel like this is the next extension of the Crown Act, which prohibited discrimination in the workplace based on your hair type. And we feel like this is the next step in this, where it's discrimination when you walk into a barbershop or a salon and you're turned away because you have textured hair and they don't know how to cut it. This would not add any hours to the textured hair curriculums. We believe we've talked to some curriculums and to schools, and we believe that this could be incorporated into already existing curriculums that are out there. So far, Louisiana and New York have passed initiatives to include this in their curriculums, and we are very excited that Connecticut is interested in taking that next step. So I will stop there and see if you have any questions.
Mr. Heindel, thank you so much for being here and for waiting until this point in time in the day. This is the first that we have talked about this bill. I want to thank Senator Billy Miller for her advocacy, and also to express our condolences to her at this time. I don't know if there are questions from members of the committee, but we do. Representative Mara.
Thank you, Madam Chair. So I read through some of the testimony on this, and it looks like there was a note that 75% of hairdressers or barbers actually want this. So is there some sort of holdback? Is there maybe curriculum not available? Just curious if you have some insight into that.
Yeah, it's to me, it's one of those issues where you hear it and you're like, wait a minute, what do you mean they don't cut or treat textured hair? And so the Professional Beauty Association, who's going to testify later today, did a survey of stylists, and that's how they got that figure, is that they do want to learn how to do this. But if you've already had if you already have your license, you're not likely to go back and get more education on this, just because, then you probably would have to, take more time to do it. So this would apply to people today. If this bill passes, it would provide, from this point forward, it would include that education. But we do feel like this is, it's another form of discrimination, and we're really, and Henkel's, we're a global consumer goods business. We have 1,000 employees in Connecticut. One of our all of our professional brands, which are that make products that are sold to salons, are really supportive of this. And so it's really, our customers are telling us that they're seeing this people being turned away, and so that's why we're very interested in this.
If I can have a follow-up question then. So how many salons are we talking about that this would affect? And again, I did mention something like, is there curriculum already that or people that are available to teach this that can go?
It is available, and there is a member of the Textured Hair Coalition, which is what our coalition is called, is already providing free training and free support to cosmetology schools to do this. So, for example, if you're working on a mannequin with straight hair, you have a mannequin right next to you that has textured hair, and so you're doing both at the same time. So that's how they would incorporate this in. But there is there is education out there that we could provide to the schools. How many salons? I'm not sure. There's multiple in every community, but we're really looking at this being a nationwide effort, and we feel like this is the right thing to do. And like I said, New York and Louisiana have already done this, and Connecticut is at the forefront of this, along with New Jersey has legislation this year, as does Minnesota, and we expect others. But it's really exciting that Connecticut is one of the first states to really to take this up.
Okay, thank you. And thank you for coming in and giving testimony.
Sure, thank you.
Thank you, Representative Mara. And in addition to Rep. Billy Miller, thanks to our BPRC, our Black and Puerto Rican Caucus, for bringing this forward and to our attention. Seeing no further questions, we will go next to Ruth Kenovi, followed by Kevin Sprague, Dr. Sprague. Ruth, welcome. Thank you.
Thank you. Good evening, distinguished chairpersons and members of the Public Health Committee. My name is Ruth Kenovi, and I'm the Advocacy Director for the American Lung Association in Connecticut. I really want to thank you for raising House Bill 5201 and for the opportunity to speak with you tonight in support of it. I'm so encouraged by the actions of this committee, as it is clear that you recognize the very real and the very present burden tobacco products have on our communities. We strongly urge the committee to pass this legislation and to dedicate at least the CDC minimum towards the state tobacco control program for this year and all future budgets until tobacco use is a public health problem of the past. You all know this, but tobacco use remains a major public health crisis in Connecticut. It costs Connecticut more than $2 billion in annual healthcare costs. And too many kids remain hooked on these products. And every day, as the public health community kind of continues to make progress on existing products, the industry develops a new medium for addiction. So Connecticut cannot afford to continue its history of woefully underfunding our state tobacco control programs. Connecticut budgeted 0 state funds towards state tobacco prevention and cessation programs from fiscal year 2016 to fiscal year 2022. The leading cause of preventable disease, death, and addiction in our state deserves more, and our kids, our families, and neighbors deserve more. As we've mentioned, you've heard from my friends and colleagues, the CDC recommends Connecticut spend between $22.7 million and $32 million every year on its tobacco control program. I was very encouraged by the reinstatement of the Tobacco and Health Trust Fund for fiscal year 2023 and the really powerful message that you all sent in continuing the investment last year. These were very important steps for Connecticut. However, when we started this conversation, advocates expressed the need to prevent history from repeating itself. From 2003 to 2018, we saw the Tobacco and Health Trust Fund swept upwards of 80 times, and the transfer to the fund stopped or diminished anytime there were gaps needed filling in the budget. Since reinstated, the governor's budgets proposed to either cut in half or suspend the Tobacco and Health Trust Fund investment. This is a self-funded program. You've heard these numbers, but every year the state receives approximately $120 million from the master settlement agreement with the tobacco industry, and another $300+ million in tobacco-related revenue. This should be an easy, common sense policy. We invest in preventing young kids from getting hooked on these deadly products and help those who are addicted to quit with the money available from a settlement with the industry to do just that. So I really want to thank you for your championship of these issues and bringing the issue up in public health. We don't want to see the momentum of the Tobacco and Health Trust Fund board slow down, especially now that the board is just about to get funding off the ground. You and the Appropriations Committee have recently received the board's first plan to spend the first round of funds available to the Tobacco and Health Trust Fund board. The next round of funds will be available in April. So I'm excited to see the good work that this program is going to get going and out into the communities. Thank you for your commitment to funding programs to help prevent tobacco addiction and help those who are addicted to quit. I really appreciate you all. So thank you for your time and your persistence and thoughtful questions today. So thanks.
Ruth, thank you for staying with us. As Ruth knows, I call her part of the big three. We've had all of you here today, heart, lung, and cancer. Our advocates who continue to remind us how important this issue is, that we address the role of nicotine, which I think one of your colleagues said is sometimes harder to kick than heroin for some people. So thank you for your advocacy today. Just from a funding standpoint, I was having a sidebar conversation while you were testifying. I'm going to confess to you. Can you just remind all of us just which committee, finance or appropriations, we usually see the conversation with the trust fund happening in?
Yeah, and so this is one of those really frustrating things with the budget where the transfer from the master settlement, the tobacco settlement fund goes to the Tobacco and Health Trust Fund, and that happens in language within the Finance Committee. I spoke in front of the Appropriations Committee because it's always a good opportunity to talk about the need for funding, but really it's like back language budget or back budget language that really happens within the purview of the Finance Committee.
Often within an implementer.
Yes.
So thank you for clarifying that for us so that if members of the committee want to speak to our colleagues on other committees, they know where to go and who to have those conversations with. Representative D'Amico.
Thank you, Madam Chair. Just a real quick question for Ruth. Ruth, I heard your figure that you gave the $27 million recommendation from the CDC, and I also saw it in Jim Williams' written testimony. Where does that number come from?
The CDC has done a very careful evaluation of kind of what things look like with tobacco use in all states. So every state has a number. It's very different based on population, tobacco use, expenses for these types of things. So it's very like a thoughtful piece, and I can follow up with you with kind of some more of that methodology. But CDC doesn't just kind of throw it out there. There's a very specific way that they look at what the cost is and what's happening and what's coming into the state in terms of the tobacco industry spending. There's a lot of that here in the state. So there's a lot that needs to be done to push back.
Great. Thank you. I appreciate it.
Yeah.
Thank you. Thank you, Madam Chair.
Thank you, Rep. D'Amico. Seeing no further questions, thank you so much again for your advocacy and spending time with us today. We actually are going to go to number 56, Gia Cook, to then be followed by Dr. Sprague. Welcome.
Thank you. Good afternoon, everyone. My name is Gia Cook, and I am a resident of New Haven. I'm here to communicate my strong support for SB 178, which is an act requiring the education and training of barbers, hairdressers, and cosmeticians to include working with textured hair. As of right now, the governor of New York has signed a similar bill into law. The state of Louisiana's Board of Cosmetology issued a resolution that will mandate all licensing exams to include a section on cutting textured hair, and New Jersey is expected to pass a similar bill. These states recognize that everyone deserves access to quality hair care services, regardless of their hair type, and I believe that it's time for Connecticut to do the same. This crucial legislation addresses a significant gap in the current cosmetology curriculum and will ensure that all beauty professionals are adequately equipped to serve clients with a variety of hair textures. Unfortunately, many people with textured hair often face challenges in finding skilled professionals who understand the unique characteristics and styling needs associated with their hair. Two national hair bias reports in 2020 revealed that 86% of Black women said that they had challenges finding consistent quality hair care at salons. And when they do find these stylists, they often have much higher costs associated with these services because of the negative connotations with textured hair and the special skills that are needed to manage or tame it. The demarcation of these skills needed for textured hair is due to the fact that its representation has historically been excluded from the general curriculum, which forces students to seek additional training if they want to work with textured hair, which then requires extra resources, so funding, time, access. And all of these factors have contributed to a culture in cosmetology where curly and kinky hair have truly become an afterthought. And this issue is very important to me personally because I've experienced and witnessed the effects firsthand. Bias against curly and coily hair textures is one of the most well-documented and pervasive forms of race-based discrimination in the US. It seeps into all aspects of life, so at school, even at work, where Black women are 80% more likely to change their hair from its natural state to fit in at the office, in sports, and even just in general daily life. It's been reported that 86% of Black teenagers started experiencing discrimination based on their hair by the age of 12. Their innocence and confidence is marred by something as personal and intrinsic as their hair. No one should be made to feel like their hair that naturally grows out of their head is bad or unruly. And this bill is a huge first step to ensuring that these sentiments are eradicated by educating and empowering cosmeticians to provide their services to all ranges of people, and by enabling people with textured hair to enter virtually any salon and trust that they'll be taken care of. So overall, textured hair, specifically curly, coily, and kinky textures, represent a wide range of cultural and ethnic backgrounds. And SB 178 is a huge, huge step towards fostering inclusivity and promoting diversity within not just the beauty industry, but also our broader society. It won't only benefit consumers, but also contribute to the professional growth and success of beauty practitioners. And it's going to foster a more comprehensive community in Connecticut, ultimately enhancing the quality of services for all of its residents. So thank you so much for your attention to this matter, and I truly do appreciate your dedication to the well-being of our community.
Thank you so much for coming and giving voice to this issue and helping us understand it from multiple different perspectives. I really am inspired by your testimony today.
Thank you so much.
A question from Representative Clara DeStitria.
Thank you, Madam Chair. Thank you for being here today with your very informative testimony. My question to you right now, currently in the state of Connecticut, if you're a cosmetologist and you're not getting trained on textured hair, where would a cosmetologist presently go to learn how to work on textured hair?
I'm not sure specifically in Connecticut, but I know there are a lot of different coalitions online, like the Texture Education Collective. They have a whole list of resources on their website, and they have people that are like practitioners that want to help and educate people as much as they can on these types of hair types in different like ways that you can work with it.
Thank you very much. Thank you, Madam Chair.
Of course, thank you.
Representative Wieslander.
Thank you, Madam Chair. Thank you so much for being here today and for your testimony. I wanted just to comment on one thing. Recently, one of my daughters has very different hair than I do, and we found a curly hair specialist who was able to give her first curly hair cut, and her face and her whole body was just so joyful when she left the salon, because she was able to be educated on how to take care of her own hair in a way that we had never even thought about. So when you mentioned just being, giving the different level of acceptance for people of all different kinds of hair types, I just wanted to thank you for noting that, and that I'm just thrilled that we can look forward to having more options for everyone. Thank you.
No, thank you so much.
Thank you. And I thank you, Representative Wieslander, for those comments, and also Ms. Cook for just you talking to us about race and the role of racism. Hair is something that we don't talk a lot about in this committee, but is really something that impacts all of us in our day-to-day lives when we talk about, bad hair days. And while we joke, it does have an impact on people's mental health, well-being, and so many pieces of that. So I appreciate you also naming that specifically for us. Thank you for your time with us today. And we now have Dr. Sprague. Thank you for waiting. And Dr. Sprague will be followed by Tony Ann Marcion, who I believe is here in the room with us. Is that correct? Great. Dr. Sprague, welcome.
Yes, thank you for having me. My name is Dr. Kevin Sprague, and I am the president of the Connecticut College of Emergency Physicians. And today I'm speaking on behalf of over 500 emergency physicians in the state of Connecticut in support of Senate Bill 181. Our college has heard loud and clear from our members that our emergency departments and our patients are suffering. And I've listened to a lot of the testimony today. And I don't want to, would be reiterating a lot of what's already been said. The way I think about this is, if our emergency departments are a highway, the problem isn't so much newer cars coming on the highway, it's when we have entire lanes shut down. And that's what boarding does to our emergency departments. It basically takes a 4-lane highway and turns it into a 2-lane highway. Or sometimes the highway is completely full and we're trying to route all the traffic onto the shoulder. And so what is boarding? It's after our emergency physicians have assessed and stabilized our patients and identified that they have ongoing healthcare needs. The patients should then go to the next care area to receive that care, but increasingly they don't. And what I want to touch upon is that in some cases, patients are harmed by continuing to stay in the emergency department. They do not receive the same level of care by staying in the emergency department as they would if they went elsewhere. And increasingly studies are showing this, increasingly studies are showing that patients that stay a single night in the emergency department have increasingly long stays, increasingly adverse events, and increase in hospital mortality. And so while these patients don't move anywhere else, more patients enter the emergency department, and we are now trying to care for them in the waiting room, in hallways, in chairs, and in the 10 years that I've been in Connecticut, this situation has only grown worse. More and more patients in the hallway, more in the waiting room. And so we Connecticut emergency physicians, we need your help. Our emergency departments cannot function with boarded patients, and we ask that you pass Senate Bill 181 so we can begin to address this worsening problem. Thank you.
Thank you so much for being here with us today and for doing the juggle. As we see in your background, you are working to care for the people of Connecticut as you are here working to care for them in a different way. I do not see any questions. You're right. And as you've heard, we've had extensive conversation today and we will be continuing it. Thank you so much. Oh, there is one question. Representative Reddington Hughes.
Thank you, Madam Chair. I'm just curious that as this goes forward, will the working group identify some key metrics to be measured to kind of streamline the process? Because that seems to be something that's coming up time and time again.
So I'm not a member of the working group. I'm sure that they will have additional recommendations, additional metrics. But I do speak on behalf of emergency physicians that this is what we're seeing, that patients that need continued care outside of the emergency department are not getting that care and not getting to those locations. And that is causing additional problems.
Thank you.
Thank you for that answer, Dr. Sprague. And I will note from earlier testimony with Dr. Moore, who co-chairs that group, they talked about one measurement, which was the percentage of folks who are admitted and board for over 4 hours, but there will be further conversation with the group about that. Thank you for being here with us today. Next, we have Tony Ann Marcione to be followed online by Adam Kay, Dr. Kay. Welcome. Thank you for being here with us today.
Thank you, Madam Chair, Senator Anwar, and distinguished members of the Public Health Committee. My name is Tony Ann Marcione. I'm the president and CEO of Regional Hospice in Danbury, Connecticut. I have 30 years of experience in healthcare operations and leadership, including hospice care. Since 1983, Regional Hospice, a nonprofit agency, has been providing physical, emotional, and spiritual support to families facing the unimaginable sadness of caring for a child diagnosed with a terminal condition. We consistently rank in the top 1% in post-care surveys, and our quality measurements developed by the Centers for Medicare and Medicaid exceed state and national results. We are one of the few providers of pediatric hospice care in our state. We currently have the ability to not only provide pediatric hospice care in our communities, but also freestanding inpatient care for respite and pain management crisis. However, the demand for these crucial services far exceeds our current financial capacity, and we are forced to turn children away. Every day, families across Connecticut deal with the heartbreaking situation of caring for a terminally ill child without the specialized support and resources that hospice care can provide. The complex nature of pediatric illnesses requires specialized medical expertise and resources. Pediatric hospice nurses are in high demand and come at a premium cost. Without adequate funding, we are unable to expand our services to meet the growing need in our own communities. Regional Hospice applauds Senator Anwar's bill. We support Tracy, Dr. Moss, and Karen's testimony today. And as you may know, Senator Kushner has introduced a bill in the Appropriations Committee to support the critical funding needed for the expansion of current pediatric services at Regional Hospice. I urge you to support her bill and to stand with Regional Hospice in our mission to provide compassionate care in a sacred, mindful, and loving way to all who need it, and especially the littlest ones. Thank you very much.
Thank you so much for your important work. I'm going to turn it over. Senator Anwar has a question.
Thank you so much for your testimony, and thank you for the work that you're doing. You guys are the only official hospice providers to children in Connecticut.
No, we're one of the few.
Okay. So when we were talking to DPH, they referred you as the only one, but looks like the others may not be as well recognized from the sound of it. The question that I was asking earlier was that there are two potential models. So we're trying to make sure there's enough access, but we also recognize that this is a specialized area not every hospice may be fully equipped to be able to manage hospice for children.
Mhm.
And there are multiple paths going forward. One path is to create a committee and figure it out, which is going to delay us and then may not help some of our children in the state. And another path is to provide expansion to somebody who's already been doing this for a long enough time to be able to see how they can make sure that the top level quality of care can be provided across the state from the existing program. And third option is to be able to provide capacity for the existing hospice organization, so there's more localized support in some ways. Can you expand on the second option of expansion across the state for one existing entity and how that would look like, and what is the capacity that you guys have?
I would have to say right now, we would go anywhere in the state, and we do. I'm not sure that we could cover the full state. I would say that I think that it could be done with a few of the hospices in the state, but I don't know that we could actually take on the entire state at this point.
And I've looked at the bill from the appropriation side. It's somewhat linked to what we are talking about right now.
Mhm.
Could you tell us a little bit about what the ask and why the ask is in that bill?
We're asking for help in funding to bring in more pediatric nurses. We have been trying to recruit on our own, but we are struggling it's very difficult to recruit pediatric nurses. So we've had the need to bring in recruiters. In order for us to even bring in a pediatric nurse from another state, they're immediately looking for relocation funding. Their salaries are much higher than our adult hospice nurses. We also don't have the productivity that some of our nurses that treat adult cases can see up to 18 patients, case manage 18 patients. Our pediatric nurses see 8 to 10. So we need more pediatric nurses to even see a less census that we do with our adults. Our pediatric nurses also obtain cars because we try and go anywhere in the state. So we're buying cars, and we actually have a fleet of cars right now, even for our regular nurses. We also need a nighttime nurse to cover pediatrics. Our nighttime nurses, they're very comfortable with adults, but they're not comfortable with pediatrics. So we need specific pediatric coverage over into the night and on the weekend. So it tends to get very costly while we're trying to build the program, without the money coming in to try and help that, we have a very large gap to fill.
At any point, how many patients are under your care for pediatric hospice?
Right now, we have 8 pediatric patients. We only have 1 pediatric nurse.
So this is somewhat of a crisis because, and what's the farthest from your home location that you are traveling to?
Hartford.
That's a good 50-minute, 50-minute drive,
Mhm.
right? So this is somewhat of an urgent issue in some respects from the state's perspective and the coverage perspective for our children.
Absolutely. And with what we do with our pediatric cases is we provide a lot of free care also. Some families have no insurance at all, but we also provide, in many cases, we provided burial for the children because the parents cannot cover the cost for burial. So besides free care, we're also providing a lot more, and we also give 14 months of bereavement to the families after the child passes.
And somebody made a very accurate comment that from a palliative perspective, there's one part, but when somebody is requiring that care for children, it's very difficult in adults, but you're taking care of the patient, but the entire family. But it's much, much more significant when, God forbid, a child is going through that challenge. So the
Absolutely.
grieving is at a different scale altogether.
Correct.
So one nurse can't do this, cannot do
No.
this.
No. And we have trained our other hospice nurses to do this. The burnout is much more quicker than someone who is prepared and has the passion to take care of children. They can maintain it for sometimes 3 to 6 months, and they're quickly burnt out at that point.
Yeah, that's very understandable.
Yeah.
Can I ask you, how's the reimbursement in the insurance industry for this?
The reimbursement is probably kind of the same as what we see across the board. The reimbursement does not always cover the cost of care, but we don't limit, especially in pediatrics, what you're being reimbursed for. You would ultimately look at as 2 nurse visits a week, 3 aide visits a week, and a social worker visit maybe once a month. We see our children sometimes 3 or 4 times a week if need be. So the reimbursement does not match the cost of care in most cases.
And final question, do you know any models in other states where they are doing a far better job than we are?
The only model I know of is the one that Dr. Moss talked about. And, it's in conversations with her that she has spoken to me about how they're doing it in Massachusetts. But other than that, I am unaware of any other model.
Thank you so much. Thank you, Madam Chair.
Thank you, Mr. Chair. Representative Welander to be followed by Senator Marks.
Thank you, Madam Chair. I just had a quick question about the comment that Tracy had made earlier, in that she was encouraging us to not just look at the hospice, but also the palliative care.
Mhm.
And wanted to know, would you support that addition? And if so, why?
Yes, I do support that. And the reason being is with hospice care, the physician who is referring the child for hospice has to be in agreement and sign a certification that they think the patient will die in 6 months or less. A lot of our physicians struggle with that. And even though you can be recertified after 6 months, they're much more likely to put them on palliative care and then transfer onto hospice at a later point.
So my understanding, that would be a smoother pathway for the families to
Correct.
negotiate, if
Correct.
that was also part of it.
Mhm.
Thank you so much for your answer. I appreciate it and your time.
Thank you, Representative. Senator Marks.
Thank you so much for being here, staying to testify. So are the pediatric hospice nurses, are they BSN nurses or are they APRNs?
They're BSN, but we do have an APRN who is a family practice APRN.
Okay. Do you have nurses that will do both adults and pediatrics? Because I think sometimes it's just you grow to actually love death and dying and to really, I love people's labor stories, and that I also, death and dying stories can be beautiful stories as much as labor stories can be. So especially if they're at home doing it the way they want to. So do you have some nurses that will do both pediatrics and adults? I think sometimes that helps with burnout.
We try that. We have tried that many different times. As I said, they can do it for a while. We did have one a couple of years ago who actually, it turned out she liked it better than adults. What I find 9 times out of 10, they can try it, but they can't sustain it. It takes a very special person and a very special nurse and aide and social worker to care for hospice patients in general, but children on hospice is just a very different animal.
Yeah, and especially the nights. I mean, I did nights hospice work, and you can have the quietest nights and then you can get 3 calls at the same time, or someone's
Right.
cat pump is, you probably don't use cat pumps anymore, but isn't working. And how do you do that at nights with such a huge area?
We've had to hire 3 nurses who rotate nights. So we have 1 nurse on, 1 nurse backs her up, and then 1 nurse is off. So they rotate the 3. We want to add pediatrics to that because our night nurses are excellent and they can provide the pediatric care. We sometimes find when a nurse needs to go out to a home, it's the late day on Friday, nighttime or a weekend, they're there for hours, if not overnight.
Yeah. Thank you so much for all you do and for being here.
Thank you.
Again, ditto to Senator Marks. Senator Gordon.
Thank you, Madam Chair. I'll be very brief. Thank you for the work that you do. I know hospice care very, very well in my other job as a doctor. I know given the location where you are, you had mentioned, I believe, and I just want to make sure I was clear on this, you had mentioned one of the farthest places you're currently going to is Hartford?
We go up to Hartford, and I think we have a child in Wallingford.
So one of the things that I just want to make certain that we're reminding of when we're talking about wanting to do palliative care and hospice care for kids is seeing what we can do all around the state. I represent a lot of rural towns, and Northeast Connecticut. And even though there are actually some hospice programs right over the border in Massachusetts, that's not always easy to do. So I'm not saying anything bad about your program, but we just want to make certain that we're trying to cover in as fair of a way every part of the state, because unfortunately there are kids everywhere who will and do need palliative and hospice care services, and their families as well, for the work that you do. So
Absolutely.
I just wanted to highlight that, and thank you again for what you do.
Okay, thank you.
Thank you. Thank you for being here with us today. Next up, we have Dr. Adam Kay, to be followed by Doc Fox. Welcome.
Thank you. Thank you. Good evening. At this point, Senator Anwar, Representative McCarthy, Vahey, and the entire committee. Thanks for giving me the chance to talk. My name's Adam Kay. I'm a radiologist in the Bridgeport area. I am currently the chair of radiology at St. Vincent's Medical Center and a partner and owner at Advanced Radiology Consultants. I'm representing the Radiology Society of Connecticut today regarding House Bill 5199, the act establishing a task force to study the shortage of athletic trainers in the state. We have no issues with this bill. I'm sure the athletic training profession is experiencing a shortage of qualified professionals, just like we all are across the state, to fill current demand for their services. But I'm here today, and we're here today because a similar task force was enacted last session to review the workforce needs of radiologists, radiology technologists, nuclear medicine technologists, and respiratory care practitioners. And despite that being enacted into law, nothing has happened to our knowledge with this task force, and no meetings have been scheduled yet. The workforce shortage, the task force on this workforce shortage was created, Section 44 of Public Act 2397. We suggest that before another task force is created by this committee on workforce shortage, the task force on workforce shortage that was created last year be convened and its report deadline extended. We really look forward to the creation of that task force because many of our practices, mine both in the hospital and outside the hospital, have had to reduce patient activity due to shortage of radiology technologists. They're critical to our practice, as I'm sure everybody here knows. They set up and execute the patient's imaging tests, and the lack of adequate technologist staffing is triggering delays, including things like us having to close a mammo office so that women are unable to get their their yearly mammograms on time. Having to close CAT scanners for the day, things like that. So we respect your work, and we respect everything that the committee does. We simply ask that we make last year's task force a priority as you're considering this new bill on a new task force, and make sure we take care of the task forces and the issues that we've probably addressed many times before. So I thank you for your consideration. Thank you for your requests, and I'm happy to answer any questions about that.
Thank you. It's nice to see you, and I do hope to see you closer to home sometime in the weeks and months. So it's my understanding that you are in support of the bill, but you are looking for action on last year's. And I'm going to note that had you been watching on Friday, our committee hearing, we talked about various task forces and conversations of the committee. The task force that you are referencing actually faces what many other of our task force faces. We have to get people appointed. And in fact, we have made progress on that one. And I think Senator Elmore and I can circle back with our administrators to see if we can't get the final folks appointed and come together. So thank you. And Senator Anwar has a question.
Or just a comment. I think your point is valid. The challenge we at times have is we have appointing authorities, and they have to be the ones to appoint the individuals. So there are 2-3 levels and layers that we have to overcome. One is finding the right person in that task force, and then making sure that appointing authority would place them. So that's part of the delay. We are filling those positions. For the Public Health Committee members who are supposed to fill them, we did them right away. We were probably the first ones to do it. But then beyond that, we are just working on some of the other parts of the picture. We are getting closer to that, and then hopefully we'll move in this direction. We're writing bills a little differently this time, and At least I'm hoping we can write them in such a manner that the work will continue and we don't have to wait for the entire task force to be formulated. Otherwise, we'll be in some of the task force waiting forever. So your point is well taken, and thank you for that.
Yes, and I applaud your initiative for coming on the other bill. Good for you. It's important. We know this is an issue we face here in the Public Health Committee. Our workforce issues are a continuing conversation for all of us. So thank you so much, and I do look forward to seeing you soon. Appreciate you being here with us today. Next,
for the
we
time.
have Doc Fox, who is online, and Gabriel Gambardella, who is here in the room with us. Welcome, Mr. Fox.
Thank you, Representative McCarthy Behe, Senator Anwar, and the distinguished members of the Public Health Committee. Thank you for the opportunity to provide testimony. My name is Doc Fox, and I'm an emergency department nurse in a hospital in our state. I am also a co-chair of the Solutions subgroup in the ED Working Group. I'm an active member in the Emergency Nurses Association and the Connecticut Nurses Association, but today I'm testifying on behalf of myself. I stand in support of Senate Bill 181, an act concerning emergency department crowding. Being a member of the ED Working Group, I believe this data sharing is essential for the public health issue to be fully understood and accounted for. Each hospital is already tracking this data. Sharing it publicly on the Department of Public Health website will allow this data to be easily available and paint a better picture of this issue that is at state and nationwide. Being a bedside nurse and a triage nurse, I see the impact that ED boarding has on my patients. Boarded patients often stay in crowded, loud emergency departments for hours and days on end, receiving different care than they would on an inpatient floor due to incoming emergencies. It is essential that we gather this data to make informed choices on what needs to be done to mitigate this issue and see the impact that our choices have through real data. I support Senate Bill 181 and ask the committee to support and pass this legislation to allow us to better understand ED boarding and improve the safety of healthcare workers and the patients in our state.
Thank you, Mr. Fox. Thank you for your work caring for the patients of our state and for serving as a member of the committee. Seeing no questions, thank you for spending your evening with us. We appreciate it. Next up, we have Gabriel Gambardella, to be followed by Myra Reddy.
Good evening, everyone of the Public Health Committee. Thank you for letting me be here and speaking tonight. My name is Gabe Gambardella. I'm a podiatrist in a private practice in the Bloomfield area. I am the section chief at St. Francis Hospital in Hartford and the legislative chair of the Connecticut Podiatric Medical Association. I'm here to support my bill, House Bill 5196, which will allow podiatrists to perform total ankle replacements and treat pilon ankle fractures. As of now, we're one of the only states remaining to not allow this for podiatrists, and this would allow me to practice to the full extent of my training and board certification. As a podiatrist, I treat ankle arthritis regularly in my office. I'm able to fuse an arthritic ankle, yet I cannot implant an ankle replacement. I can, however, remove one and convert it to an arthrodesis or a fusion. Despite the fact that I have the skill set and the board certification to perform ankle replacements. It's been argued that 3 years of surgical training is insufficient to perform this surgery. That's false. That was also argued more than 15 years ago when podiatrists earned the right to fix ankle fractures in the state and perform ankle fusions. And since then, podiatrists have been doing these surgeries successfully without any significant complaints or patient safety issues, to my knowledge, to the Department of Public Health. In my 3 years of training, I amassed over 1,800 surgical cases dedicated to the foot and ankle, which is significantly more on average 3 times as much as any graduating orthopedic surgery resident with a foot and ankle fellowship. In fact, one of my orthopedic colleagues in this state published data regarding limited foot and ankle experience in orthopedic residency training. There is a study in JBJS, the Journal of Bone and Joint Surgery in 2021, that shows the average orthopedic resident graduates with a total in 2020 with 67 logged cases dedicated to the foot and toes and 167 to the ankle and leg. It's also been argued that, well, orthopedic surgeons do surgery on the whole body. Using that same study, the graduating resident in 2020 will amass 1,212 cases on the entire body. When I have 1,800 cases on the foot and ankle, yeah, I'm restricted because the orthopedic community believes that I have insufficient experience. This doesn't make much sense to me. There's data published by the orthopedic community indicating that many residents upon graduation are not comfortable performing many surgical procedures involving the foot and ankle. This is usually not the case with podiatry. Also, it's important to note that while I was at Yale doing my residency training, I trained with many orthopedic surgeons who taught me how to fixate ankle fractures, obtaining comprehensive ankle fracture care, and performing total ankle replacements. So it was said earlier that we are not trained to do these surgeries. We are trained to do these surgeries. The passing of this bill is not going to allow just any podiatrist to perform total ankle replacements or treat complex pilon fractures. It will allow those who have the skill set and the training to do so. Total ankle replacement is a relatively new surgery in terms of treating ankle arthritis and has become the standard of care in some patients over the last 10 to 15 years. It's not an old surgery. At some point during the evolution of this, there were orthopedic surgeons and podiatric surgeons who had no experience with the surgery, yet the surgical technique was learned. And these surgeons who had no experience were able to perform the surgery because they acquired the skill set doing other various foot and ankle procedures.
Excuse me, Mr. Gambarella, but your time is up. Thank you.
Happy to answer any questions.
Thank you so much. So I think we do have a few questions. I'm going to start, and then Senator Anwar and Representative Claridis Tito. So you have been here for the day today.
Yes, my letter actually says good morning, committee member.
Yes.
I was a little overconfident about
So, well, maybe optimistic. So you've heard a lot of the testimony here before us. One of the comments that was made by someone who testified earlier today was related to a weekend certificate, for example. So what I'd like to do is ask you, as a podiatrist, you also referenced residency at Yale. Can you just briefly outline the training pathway for a podiatrist, education and training, and then speak to that comment that was made about a weekend certificate?
Sure. So I did 4 years of podiatric medical school at Temple University, where my first 2 years were identical to those that go to an allopathic school, the same classes that the Temple medical students had. My second 2 years are much different. We do rotations that are more relevant to our specialty. So for instance, I wouldn't do a rotation in ENT or OBGYN. I do rotations in plastic surgery, trauma surgery, orthopedic surgery, dermatology, and so on that are relevant. After that, we do a 3-year residency. The one at Yale, and there are differences in residencies. The one at Yale is pretty comprehensive. We train with podiatrists and orthopedic surgeons. We do complex reconstructive surgery, limb preservation techniques. We learn how to use external fixation, which not everyone does, dynamic and static correction of complex deformities. And my training with the orthopedic surgeons there, we had a dedicated rotation in orthopedic surgery. So not only was I trained in ankle replacements, I scrubbed many shoulder replacements, knee replacements, hip replacements. I did a dedicated rotation in general surgery, trauma surgery. I helped treat patients in the SICU. So it's not like we just do foot and ankle surgery for 3 years. We do, but we're also exposed to other various specialties. We do rotations in internal medicine, where most of the time we learn how to treat patients or manage patients who have complex medical conditions such as diabetes. So after that 3-year residency, there's an option to do a fellowship. That's been more, I would say, popular over the past 5 years. Coming from Yale, having that experience, I didn't feel the need to do one. I felt like I was trained to really take on anything that was foot or ankle related. In terms of the weekend course, that's not the podiatrists who we're going to allow to do these surgeries. I'm the section chief at St. Francis Hospital, and I get to determine who gets surgical privileges. And I know Dr. Bloom and another doctor at Yale, they get to determine who gets them at Yale. This is not something that we take lightly. We want to make sure that patients are getting the best care they can. And we want to, honor our patients and make sure that they have good outcomes. These surgeries are not for everyone. In fact, I would say most podiatrists who are in Connecticut probably wouldn't even request to do these surgeries. But the new podiatrists who are graduating, who have extensive training, they will. And we want to encourage them to come here. So I hope I answered your question.
Thank you. I wanted to ask, in terms of it here in Connecticut, I asked a professor from UConn if UConn offered education in podiatry. Can you tell me where in Connecticut you can be educated if you'd like to become a podiatrist and where residencies are available?
Sure. And I think I didn't answer your question on the weekend course. So in order to do a total ankle replacement, if I may say that, you have to go to a course that's sponsored by the company who manufactures that device. You can't get the privilege to put that device in someone unless you train on their total ankle replacement system, because they are different. In terms of where you can train in Connecticut, St. Francis Hospital, we have 6 residents there. I also train the residents at Yale. There's 15 residents there. And then there's the Yale Bridgeport system. There's podiatry residents at that hospital as well. So we have 3 surgical programs. And to be honest, I think that we're doing a disservice to our residents. You know, they should be trained to do foot and ankle surgery. You know, we are board certified foot and ankle surgeons. We're not board certified foot and ankle surgeons absent a pilon fracture or absent a total ankle replacement. We're questioned on total ankle replacements for our board certification. We're tested on it. We need to know about it. We should be doing it. We should be teaching the new residents to do it.
You went to Temple. Are there schools in Connecticut that offers the same?
No, the
education?
closest podiatric medical school is New York. There's one in New York. I went to Temple. There's one in Florida, Des Moines, Ohio, I think. I'm not sure where they all are.
Okay, thank you. And back to the weekend certificate. So what you, if I may, yeah, I know.
That's a
there's
very
lot to say.
simplification of.
So that's why I'm bringing it up, because I think it's important for people to be able to speak for themselves rather than others who are not as, are not in the field, so to speak. And not to say, again, we've heard lots of different perspectives. I think I'm looking for the specific information. What you're telling me is that the total ankle replacement is a device.
Yes.
And because it's a device, the device manufacturer requires a certification, which is where that weekend certificate, so to speak, I'm sorry to use that term, but I'm just using what was
That's
spoken
fine.
about earlier, comes into play. Is that correct?
That's correct. So you have to take a course if you want to put in a certain ankle replacement. Now, again, we have a robust credentialing system. We have to vet surgeons to allow them to do what they want to do. They have to check off a list of surgical procedures they want to do. And someone who just goes to a weekend course, they're not going to be able to do that surgery at a hospital. Yeah, and I don't want to speak for orthopedics, but I'm pretty sure when they come out of residency, whether or not they have a foot and ankle fellowship, they can do whatever they want. They don't need to show a certain number of cases. They did 15, they did 20. We had to, for a long time in Connecticut, we had to just keep proving ourselves. There's no other surgical specialty who has to put so much forward to get what they're trained to do. In other words, when you're a plastic surgeon or a neurosurgeon or an orthopedic surgeon, when you're done with your residency in orthopedic surgery, you can come out, be a general orthopedist and fix an ankle fracture. With podiatry, you have to show a certain number of cases, and the standard that we have to live by to get our surgical privileges is just more than anyone else, I think.
So one last question, because I know others have questions, and
Sure.
I think I'm the one who told people to be aware of the time, right?
Yeah.
So the last question I have is, you earlier, one of the people who testified, I believe it was one of the orthopedic surgeons, talked about the difference in board certification. That in other words, the board certifies everyone, and you have a separate board certification process for podiatrists. Can you just briefly, in a minute or less, if you can?
Yes, so board certification, we have basically 2 certification options. You could do foot surgery, be board certified in foot surgery, or board certified in foot surgery plus reconstructive rear foot and ankle surgery. So with these, you have to submit a certain number of cases. You have to log diversity, meaning that you can't just do the same bunionectomy or just a lateral malleolar fracture. You have to have a variety of cases. You submit your cases, and then you have to take a test online, and you become board certified that way. But it takes years to do that. It takes about a few years to do that certification process.
Thank you very much. I think you did it in under a minute. Senator
Thank you.
Onwar.
Thank you so much for your testimony and thank you for waiting for most of the day with us.
No problem. My pleasure.
What were the things that the scope review committee agreed on? What was the part that you all said, yeah, that's right?
So I don't think, and I was at all these meetings, I don't think we all really said yes to everything at once. I think that the one thing that we had a general agreement on was amputations. And I think that was the case because in Connecticut, the majority of diabetic limb preservation, to my knowledge, is done by podiatrists. So at St. Francis Hospital or at Yale, when there's a diabetic foot wound or someone who's at risk for losing a limb, we're the ones who are consulted in the ED. We do their foot amputations afterwards. We do their deformity correction if needed, tendon rebalancing. Can you repeat? I want to get to the point of your question. Can you just say that one more time, Senator?
What I was saying was, what were the areas that everybody agreed on?
So amputation. And then when it came to total ankle replacement and peel-on fractures, no one agreed. So I think what your next question maybe was what happened with that agreement that we had? I don't want to assume.
Yeah, because from what I gathered in the two meetings, everything was moving in the direction of developing some consensus. And the third meeting, you guys sort of said all or nothing and walked away. This is what I heard today.
Sure. So we wanted to really go to these meetings in good faith. And we said, you know what? We both agree on the amputation. And we're willing to give up peel-on fractures and we want to do total ankle replacements. And they wouldn't agree to that. In fact, when they wouldn't agree to that, they wanted to limit our ability to do ankle fractures even more by defining a peel-on fracture in a way that's not really defined. For example, a trimalleolar ankle fracture is a fracture where there's 3 parts of the ankle that are broken. 2 parts of the tibia called your medial and posterior malleolus. A peel-on fracture is a high energy fracture where the ankle joint is comminuted, it's destroyed. There's displacement, it's a crush injury. It's a pretty severe trauma. A rotational ankle fracture is more of a trimalleolar fracture. So they wanted to define a peel-on as any ankle fracture where the posterior malleolus on a CT scan was greater than 25%. So now what they wanted to do was, okay, so now we have to order a CT scan on every patient who has an ankle fracture. Number one, that's unnecessary radiation for patients. And number 2, that's going to increase the cost of healthcare significantly, and it's not needed. So now we have to order a CT scan on every patient based on their definition to see, well, is the posterior malleolar fracture 25% of the ankle joint? Is it 26%? If it's 26%, I can't do it. That's not the way that an ankle fracture or peel-on fracture is defined. There's no consensus on that. So when they said, you know what, we want to define peel-on fractures as this, we're like, you know what, we're going to go back to our initial plan for our bill because they were just being completely unreasonable, in my opinion, and many of their our opinions. And we didn't think that they were coming to the meeting in good faith. So yes, we tried to negotiate. They wanted to not negotiate the total ankle and the peel-on and wanted to restrict us even more. So once that happens, everything's off the table.
Okay. Thank you. Thank you
You're
for
welcome.
sharing
Thank
that
you.
because
Thank you,
we
Dr.
heard
Amar.
pieces of the puzzle, but we wanted to hear it from you.
Sure.
Thank you, Senator Almar, and agreed. This is the point of hearing. So we get to hear from all different perspectives. It's wonderful. Representative Clara DeStitria.
Thank you, Madam Chair. Thank you, Doctor, for being here today. And I know you just discussed, you were part of the working group.
Yes.
Can you just, for the rest of us, one more time, the so-called compromise? So you both, with total ankle replacement, was that out or in?
It was out. They don't think that we
Literally
have
and figuratively.
out. If they don't think that we have the training, and that's just, it's just false.
So they didn't want that at all.
Correct.
The orthos didn't want that at all. And then their compromise was the pylon fracture at the 25% or less. That was
So
what they
they
thought
wanted
was
to
a compromise.
define, so
Right.
they wanted to not give us peel-ons, or I hate to say give us because, they shouldn't be really giving us anything. We've kind of earned this. But they didn't want to allow us to do peel-on fractures or ankle replacements. And then on top of that, they wanted to define a peel-on fracture as an ankle fracture that's more than 25% of the tibial plafon and the posterior malleus. That's the bottom part of the tibia. So again, to determine that, we would have to order an unnecessary CT scan, increasing costs, exposing patients to unnecessary. It's completely unreasonable. That's not how you define a peel-on fracture. So that was when the compromise kind of fell apart.
Okay, and you also said that incoming med school for podiatrists, you're trained on total ankle
Yeah.
and pilon fractures. That's
Yeah.
part of your training currently.
Well, yes, not everyone, every residency is different. Same with orthopedic surgery. Everyone has different exposures. My program that I went to at Yale, I was trained on comprehensive ankle fracture management, total ankle replacements. Again, I did knee replacements and hip replacements with the attendings. I was an assistant during the surgery. You know, you're going to hear from one of our new podiatrists in the state, rather young, who has incredible experience, and she'll tell you about hers and her training that she had during her residency and fellowship. And, you know, the experience that we have is significant. And, you know, again, I did 1,800 cases in 3 years, and in 5 years, based on this study, they're doing Dr. Peden, with all due respect, Dr. Peden, I think he said he did 400 during her residency because he really wanted to focus.
Thank you.
400.
And there are currently 44 other states that allow podiatric surgeons. to
Including
do these.
the District of Columbia, correct.
Okay, thank you. And then my last question, are there any studies showing the different outcomes from podiatric surgeons versus orthopedic surgeons?
So, yes, I think we spoke about a couple of them earlier, and Dr. Anwar, if I may, I think that you had questions about the infection rates, and one of the studies by Dr. Chan, it had 11,000 patients. So it was 11,000 orthopedic patients compared to 600 podiatric patients. Completely unbalanced study. That study actually showed no difference in infection rate. There was a difference in the malunion rate, but again, 11,000 to 600. If we were going to compare two medications, antihypertensive medications, we're not going to look at two groups, one having 11,000 patients, one having 600. It's not a reliable study. There was a study in 2020, and also that study showed demonstrated patients from back in 2007. So it's pretty old. There's a study in Journal of Foot and Ankle Surgery 2021 that looked at 4,500 podiatry patients who were taken care of by podiatrists for ankle fractures. It didn't compare them directly to an orthopedic cohort in that study. I don't think, there's one reason why someone does a study like that. It's to undermine the other profession, in my opinion. However, what they did do was they did compare it to the current literature, and they show that there's no difference in infection rate. And actually, when you compare these more than 4,000 patients taken care of by podiatrists for ankle fractures, I have it here, there was a higher incidence of malunion and unplanned revision surgeries than 90 days when you compare that to the current orthopedic literature. So in that study, Dr. Peden again said there's no data, and we do have data. We actually had similar outcomes in terms of infection rates and better outcomes in terms of patients requiring an unplanned revision surgery within 90 days.
Thank you. And thank you for being here today and shedding some light and waiting all day and being
No, it's my pleasure. And
our last podiatric surgeon that's here, but also thank you for the work that you do. We know it's very important. And a little birdie did tell me that you may or may not have played Division I baseball. So that's wonderful. Thank you.
Long time ago. Thank you very much for letting me speak today.
Oh, we still have more questions for
Oh.
you. No, not so bad.
I'm ready.
Thank you so much. Love the baseball reference. We've got Representative Ryan to be followed by Representative Parker to be followed by Representative Denning.
Okay.
Thank you, Madam Chairman. But the one time I was going to ask a question, Representative Claudius Detrius usurped my question, and it goes answered, so we don't have to go any further. Thank you.
Thank you, Representative Ryan. We appreciate your brevity and that great vocabulary word too. Representative Parker to be followed by Representative Denning.
Thank you, Madam Chair. No brevity, no good vocabulary over here. I want to ask you about Medicaid patients and access.
I'm so glad that you.
As we're hearing earlier from folks, I was trying to suss out the extent to which these are, there we go, suss out. The extent to which these are significant portions of the business for some of the orthopedists that we heard from. And it sounded like that wasn't exactly the case. These were maybe overall some rare cases. And so, because I was wondering, is there, are folks going to lose a lot of business if this change happens? And I'm not thinking that as strongly right now, but there wasn't then also an acknowledgement of maybe there's an unmet need here. And I think if we're going to zoom out here and not make this a turf war, but really look at patient access, which is going to be probably the most compelling path forward, would be great to know if there's actually an unmet need. And I'm wondering if you could provide some more information
I
on that.
can't thank you enough for that question. You know, I didn't get to it in my talk. So right now, I think in 2023, there's 979,000 patients who are on Medicaid. If anyone thinks there's not a disparity in patients who have Medicaid, they're just not living in the real world. I don't know where that's coming from. If anyone has a family member or a friend who has Medicaid, you know how hard it is for them to get in to see someone for whatever it is, whether it's an acute issue or a chronic issue. So there was a study that came out of Yale, actually in New Haven, that demonstrates it takes patients who have Medicaid longer to be seen, longer to be treated for orthopedic conditions. There's another study that shows out of the Journal of Foot and Ankle Surgery 2023 that patients who have private insurance and Medicare insurance are 84% and 37% respectively more likely to get an ankle fusion than be offered an ankle replacement. That's data. And again, when they say there's no issue with Medicaid, there is an issue with patients who have Medicaid. It takes longer for them to be seen. It takes longer for them to be treated. You know, I routinely see patients in my office who have Medicaid, and I feel like we need to address this disparity. The study in Journal of Foot and Ankle Surgery indicate there's a racial, socioeconomic, and payer status disputes disparities when it comes to patients who have Medicaid. That's undisputable. And not every orthopedic practice at all sees Medicaid patients. During one of our meetings, the argument was made by one of the orthopedic surgeons that, you know, I can call one of my colleagues down the street and they'll see a patient who has Medicaid. After this meeting, I called 9 or 10 orthopedic offices myself, private ones. I said, you know, my foot really hurts. You guys take Medicaid? And they said no. And one of the offices referred me to a Medicaid clinic. And then if you go on the websites, you're welcome to now. Back in, you know, a month ago, 2 months ago, I looked at all the websites and it always lists insurances that you'll take, and none of them said Medicaid. I'm not sure if they've changed that since the meeting that we had, but none of them say Medicaid. So they may see Medicaid patients in the hospital clinic somewhere, and they may see them in their office, but I cannot get into 9 orthopedic offices telling them I have foot and ankle pain and that I have Medicaid.
Thanks for sharing that.
You're welcome.
Thank you, Madam Chair.
It's anecdotal, I mean, but there are studies that corroborate that.
Thank you, Representative Parker. 2 follow-ups from me. Do all podiatrists and podiatry practices accept Medicaid?
I don't know the answer to that. I'm assuming no. I know there are podiatrists in private orthopedic groups. And I did try calling one and I couldn't get in. About if you're talking about just podiatry offices specifically, I don't know the answer to that.
Thank you for that. And then last one is Rep. Parker, I believe, touched on it, or someone did, the residency differences, which you had mentioned, and I meant to follow up when I first asked. So you referenced that your residency experience was very robust and comprehensive.
Yes.
But that there are differences.
Sure.
How can we know or understand what those differences are? Are they set forth clearly for the public? Are they measurable? Can you please speak to that?
Sure. So, you know, not every residency is the same. Some focus heavily on trauma, some focus heavily on reconstruction, some focus heavily on diabetic limb salvage. What we do is whenever someone wants to apply for privileges at a hospital, they submit all of their case logs and we go through them and we determine if someone has done a sufficient amount of work in respect to ankle surgery or fractures or replacements to obtain the privilege to do those.
Great, thank you very much.
You're welcome.
And I know we have Representative Denning online with a question.
Yes.
Representative Denning.
I think you're muted. I'm sorry.
Representative Denning, you are muted.
Now, am I unmuted now?
Yes.
Yes, I'm at home today. I still have a remnants of the flu. I didn't want to get everybody sick. And so here's my question. I've worked with podiatrists as a nurse anesthetist, so I'm familiar with the workload that you do. When you do a total ankle, the same as you do any other implant, does somebody from the company come to make sure that it's done properly and in the way that the company wants it?
Yes, even when we don't do total ankle replacements, Whenever we're using hardware, there's usually a representative in the room in case the tray is dirty, needs to be re-sterilized, or if they're missing something. Yeah, I don't think a representative would not be present during a case such as an ankle replacement.
And you believe that to be true also for an orthopedic surgeon?
I don't know. I don't want to speak for them. I don't, you mean
in my experience, every time they'd use an implant of metal, especially of a hip or a joint, they would want somebody from their company there to make sure that everything was done right according to what the company teaches.
No, I don't think so. I don't know why a surgeon would not want the rep in the room, because things happen. You can have a piece that's faulty. Your set could be missing something. I don't think that a surgeon would not want to be available, readily available in the operating room when someone's doing these surgeries.
Okay. And do you feel that because of the restrictions that podiatrists have in Connecticut, that we are not bringing the best podiatry candidates into our state?
Not only are we not bringing them, but we're losing them. I mean, we've lost so many fantastic residents from Yale and St. Francis. One of the residents that I trained a few years ago is one of the best residents I've ever got to work with. He's in Colorado now, and he's doing ankle replacements and peel-on fractures, and he's doing foot and ankle surgery, what he's board certified to do. And his wife was a nurse in Connecticut. She's from Connecticut. They both moved because of the restrictions here. I appreciate that question. And yes, we do have trouble bringing patients back unless they have a reason to really be here, their families from here or something else. But probably among other reasons, a lot of podiatrists are not choosing Connecticut to come and practice. I think that's a huge point when they're determining where they want to go. But again, we're also losing residents that we train.
So in our rural towns and communities where we don't have orthopedic surgeons and we may or may not have podiatrists, this scope of practice increase would allow you to take care of patients who normally would not have access to care.
I missed the first part of that.
In our rural communities, I mean, I know when you get to the hospital, a hospital can regulate anything it wants as to what a practitioner can or cannot do, even if it's the law. My question to you is, in our smaller towns and communities where we may or may not have orthopedic surgeons or podiatrists, are you providing care that normally would not be available?
I don't think I have the answer to that question. Thinking about the state, Connecticut and how it's broken up and the podiatrist and where they're located, I'm not sure if I can answer that question accurately for you. I think that we are providing comprehensive care throughout the state. I think a lot of us are centered in more urban or suburban areas of Connecticut. We treat a lot of the indigent population, but I don't think I can answer that specific question accurately. I can get back to you on that if you'd like.
Thank you for coming and testifying. I appreciate your answers. And back to you, Madam Chair.
Thank you, Representative, and we certainly hope you feel better. Thank you for staying home when you were not feeling well, and we are grateful for that. I do not believe there are any further questions. We are very grateful for your time today, as we have been for the others who have joined us, and appreciate you spending your evening with
I'm
us.
grateful to be able to speak, so thank you very much.
Thank you. Next, we have online Myra Reddy, to be followed on the phone by Olivia Zachor, which I hope I'm saying your name properly. So Myra, welcome.
Thank you so much. Thank you, Madam Chair, Senator Anwar, and honorable members of the committee. I appreciate your time I guess it's evening now, this evening, where you're at. And I just wanted a few moments of your time to talk about my support for Senate Bill 178. I am representing the Professional Beauty Association as well as the Texture Education Collective. We just want to reiterate how wonderful we think this legislation is and how inclusive it is. But I also wanted to be specific about the impact that this would have, and especially coming from a safety perspective. We do believe that having access and adequate training does provide individuals and consumers, clients, at least in their mind, everyone has a reasonable confidence that the individual that is providing services, that is physically touching the person, that they are trained and they are providing those services in a safe manner in an inspectable location. And by allowing more access to education and to training for licensed beauty professionals, we can ensure that those services would be available in salons or barber shops. And just in Connecticut alone, there are over 2,000 employment-based salons and barbershops that employ over 9,000 employees. And interestingly, 68% of that salon ownership is women, followed by 38% being women, which is just a staggering number. And this would really promote the health and safety and well-being for individuals across the state of Connecticut to find a location and to access a licensed beauty professional that has been trained in hair care services that will meet the needs of individuals with all textured hair. Especially when we're looking at numbers nationally, the Bureau of Labor Statistics Occupational Handbook for Barbering and Cosmetology does put out numbers including 89,000 new jobs that are expected over the next 2 years across the United States. That's joining already roughly 620,000 licensed professionals. And we know that programs already exist in the US that could help alleviate any concerns with cost or an increase in numbers for current cosmetology and barbering programs. Specifically, I wanted to mention the Texture Mastery Program, which already has been in over 150 schools and has had the opportunity to train over 800 instructors that have a reach of about 7,000 students. So this is just a great way to ensure health and safety, ensure access while being inclusive at the same time. So we really want to thank everyone and thank you for allowing me to speak this afternoon in support of SB 178.
Ms. Reddy, thank you so much for joining us. I really love your background too. Thank you for referencing safety. I appreciate you highlighting that. I do have one question. When you named that there are over 2,000 salons and over 9,000 employees, you said 68% women, and then you gave another statistic, and I just wondered if you could repeat that for us.
Oh, yes, 68% owned by women and 38% are minorities.
Wonderful. Thank you so much for that. Are there questions? Seeing none, we thank you for taking the time to stay with us and to share your experience and perspective, and look forward to further conversation on this bill.
Thank you so much.
Next by phone, we have Olivia Zachor. Olivia, are you able to unmute and speak with us by phone? Olivia, I see that you're on with us, and I'm just going to ask if our clerk is able to unmute you, if that's possible, or if there's a trick to unmuting by phone. Just give us 1 second, if you will. I believe it's *6.
Hello, hello, can everyone hear me?
Yes, we can. Wonderful. Welcome.
Oh, wonderful. Okay, thank you. Good evening, co-chairs, Mr. Anwar and Madam McCarthy, and esteemed members of the committee. My name is Olivia Zachor, a graduate student studying social work at UConn, residing in Ansonia. Today, I stand in full support of HB 5198 and the Act of Concerning Telehealth. Telehealth has been an indispensable lifeline, particularly during crises like COVID-19, breaking down geographical barriers and ensuring timely access to healthcare for countless individuals. From rural areas to marginalized communities, telehealth has proven invaluable in addressing disparities and improving health outcomes. In my experience, I have witnessed the transformative impact of telehealth, especially for vulnerable populations who often face significant challenges in accessing traditional healthcare services. Its convenience has enabled individual disabilities, chronic illnesses, or mobility limitations to receive necessary care without the added burden of transportation or logistical hurdles. Furthermore, telehealth has played a crucial role in addressing mental health needs, providing counseling, psychiatric services, and support groups from the comfort and privacy of one's home, thereby reducing the stigma and isolation that can exacerbate mental health challenges. Extending the provisions for telehealth services until 2027 presents us with a significant opportunity to build upon the progress we have made and ensure that all individuals, regardless of their circumstances, have equitable access to the care they need and deserve. This extension will not only promote health equity, but also result in substantial cost savings by facilitating timely intervention and preventive care, thereby averting more costly medical interventions in the future. In conclusion, I urge you to support this vital bill, recognizing the critical role that telehealth plays in advancing the health and well-being of our communities. As a social work student deeply committed to advocating for social justice and equitable access to resources, I firmly believe that extending telehealth provisions is an essential step toward building a more inclusive and compassionate healthcare system for all. Thank you for your time and your consideration.
Thank you so much. And it's wonderful to have our students here with us and testifying. Really appreciate that. As a fellow social worker, I am wishing you all the best as you continue your studies. I see no questions. So have a wonderful
Thank you so much.
Next, we have in person Susan Halpin. Susan, welcome, and thank you for hanging in here all day. Welcome.
Thank you. Thank you, Madam Chair and members of the esteemed committee. For the record, my name is Susan Halpin. I am with Robinson & Cole, and I'm here today before you wearing my hat as the Executive Director of the Connecticut Association of Health Plans. First, I'd like to commend all of you for your time and dedication today. It's truly admirable to see so many committee members around the table and so engaged on such a continuous basis. So I commend all of you on that. I wanted to testify today on behalf of the association in opposition to two bills. The first is Senate Bill 180, an act concerning adverse determination and utilization reviews. And the second is Senate Bill 182 around step therapy. The first bill is really a couple different bills in one. The first establishes a rebuttable presumption for matters around medical necessity. If I could just leave you with one thought on this measure in particular, it is almost impossible for a health plan to reverse course on that presumption because they don't have the medical or clinical information in their possession. So in order to, challenge the medical necessity of that, they would have to have those medical records, which are in the possession of the provider and or the member. I also don't want to sit before you today and say that we do not acknowledge the frustrations around prior authorization. I have sat here all day. It is something that the carriers have heard. It is something that we have worked on. Many of the carriers themselves have reanalyzed and reconfigured their prior authorization processes just within the last year. Also, I want to say that there's a number of actions that have been taken by this body and also by the Biden administration just as recently as 3 weeks ago around prior authorization. These issues have typically been before the insurance committee in the past, so I welcome the opportunity to come before you to talk through them. But just last year, Public Act, I just had it in front of me, 23-204 did a number of things in this area. As Senator Marks is well aware, there was a single authorization for autoimmune multiple sclerosis and cancer drugs. We also had a mandated reduction in utilization review timeframes to 24 hours that just went into effect on January 1, 2024. There was a reduction in the step therapy applications from 60 to 30 days. There was a 3-year prohibition on step therapy for drugs used to treat schizophrenia, major depressive disorder, and bipolar disorder, led in large part by Representative Christy Carpino and Representative Michelle Cook, among others. So there were a number of things that were passed just in the last year, taken in addition to the Biden administration's recent guidance that put a number of provisions in place around prior authorization. We would hope that the committee would hit the pause button and give time for these new policies and procedures an opportunity to work.
Excuse me, Ms. Halpin, but your time is up. Thank you.
With that, I will conclude, and thank you for your consideration.
Thank you very much. Thanks for staying here with us today. We have questions beginning with Senator Anwar.
Thank you so much. Thank you for staying with us the whole day. And I wanted to ask you, I know last year we were able to make a very small change from the clinical patient's perspective. For a stage 4 cancer, 30 days is a lifetime. And so that's one of the areas, is that there's an opportunity for expanding the diseases, but also reducing the timeline in some respects. And it's not like it's an unrealistic or unfair ask. These are justified and provable, except that the bureaucratic process on the insurance side is delaying it. So if you look at it from that perspective, there is an opportunity to improve where we are at compared to before. Do you want to reflect on that?
Sure, a couple of things. First, I would say that state statute does provide an automatic override provision in statute upon request to the health carrier. So that would be my first piece. I usually start out these conversations talking about what Connecticut can do as a matter of authority from the state level, but with 3 minutes, it's hard to do that. And I think it's a really important thing for this body in particular that doesn't usually deal with insurance matters to understand. Connecticut has authority over a very, very small portion of the insured market. So when things pass and people say, oh, well, we passed that law and it hasn't changed, that is because it may be in the self-insured market. If you look at it on a population basis, only 13% of Connecticut's population is governed by Connecticut insurance law. I heard a lot about the prior authorizations and discharges to nursing homes and Medicare Advantage from the hospitals, and we've been in those conversations as well. But that is a federally regulated program and service through Medicare Advantage plans that Connecticut, as much as it might want to, does not have authority to govern. So I just think those are really important distinctions. And what has happened over time, in part due to the regulation and in part due to the cost, we all agree that evidence-based practice should be part of medical delivery. And I know the vast majority of doctors are following those protocols and procedures. The protocols and procedures that the carriers use around step therapy are developed by the specialty societies. Those are the protocols that typically the insurers are following. So they're not, and they have boards made up, which Sam Hallemeyer, who's going to testify after me, can speak to, of professionals, doctors, and others, subject matter experts in developing those protocols. So they're not pulled out of thin air, as is sometimes attributed, but they are tried and true and evidence-based models.
And thank you for clarifying that part, because that's very relevant. Many of the people who interact with people, or the family members who have been unwell, we've been traumatized because of some of these issues. And we look at the legislative body as a solution, but to your point, the legislative body has control over a very small percentage of that. Do you think that there's hope if we fix a small percentage and have that be an important part of the picture? That would be an opportunity to expand those kind of programs, because the federally regulated ones are not necessarily helping the consumers.
I think what you have to look at always is a balance. Resources are not infinite. So as, you know, a society, we have to decide how to best use the resources that we have. And in other committees, our industry is being taken to task, if you will, for not holding down healthcare costs enough, not pushing back harder on doctors, pharmaceutical companies, hospital systems, et cetera, because at some point, if you don't have any insurance, you don't have coverage and you don't have health care. And when it gets to that price point that's too high, that's exactly what you will end up having, is people without coverage and without health care. So it's a balance. What we are seeing is a migration out of the fully insured market, a migration out of the market that is regulated by the state of Connecticut and into the self-insured market, because there are more affordable benefit packages in the self-insured market than there are in the fully insured market. And that is in part, not solely, but in part because of these added requirements and regulations. Everybody wants, you know, everybody agrees we should invest in the lower cost drug, and that people should look at, you know, using generics instead of brand names and those things. But it's practices like step therapy that implement those protocols, if that makes sense.
So because the federally regulated ones are a little less expensive right now, so you think there's an out migration that's happening for that reason, because people are looking at the short-term benefit and they believe that they have some kind of insurance till they really get sick?
I don't think it's just a short-term benefit, and I don't think it's for less cost. There's less regulation. There's more ability to tailor benefit packages and designs to the needs of those particular employers. Frankly, they're not subject to the premium tax that fully insured plans are, that goes to the state of Connecticut. They're not subject to the assessments for the Department of Public Health programs and services. They're not subject to the assessments that fund the health insurance exchange. So there are a number of regulatory assessments, taxes, restrictions and requirements. They can be much more innovative in the self-insured space than they can in the fully insured space. The rates under the fully insured products can only be determined by age, by family size, and by geography. As you recall, the ACA took out gender. So you're looking at one pool of people in the fully insured market, individual or small group, and those are the only three bases that you can use to develop your rates. And so all of those other things go into that mix master, as you will, when you develop a rate that comes out. And what's happened, as you know, Senator, from testifying at the rate hearings, those are going up and up and up each year. And those are in part because of the regulations, the mandates, and the other requirements that are being imposed in the legislature, unfortunately. They're all laudable in intent, but they have a cost, and we have to recognize that they have a cost that has to be paid at some point down the line.
I'm not sure I'm convinced by the last part fully yet, because I think there's a lot of other things that are happening in that money, and the rate changes that are happening are far beyond the actual cost, but there are other interests in the picture too. I'm sure my other colleagues have questions. I'll come back for more. Thank you for your answers.
Thank you.
Thank you, Senator Anwar. We have Representative Denning to be followed by Senator Gordon.
Hi, Ms. Halpin. It's a pleasure to see you as always. I usually talk with you in the Insurance Committee, yes, and I'm glad you're there. Explain for me again, and just to help me I understand a lot of this thanks to your help, but what percent of the self-insured market is managed by insurance companies located in Connecticut?
What percent of the self-insured? I would say probably a large majority. I can't say exactly, because I don't have that. No, I don't have that answer. But that said, there are also third-party administrators that also administer employer benefit packages in the self-insured space, in addition to the commercial insurers that you would recognize, like Aetna, Anthem, Cigna, Connecticut, and United.
But you would admit that there's a large percentage of large companies here in Connecticut who, while they are self-insured, surely want to provide quick, efficient care to their customers, even though they're not, they're self-funded plans, correct?
Correct, yes.
Okay.
In a self-funded plan, the employer is actually paying the bills. So just like the
Correct.
state of Connecticut is a self-funded plan for the state employees, they set up a bank account, they contract with Anthem, Anthem reaches into the bank account and pays the claims in coordination with what the benefit package is that the state comptroller has set out.
Thank you. So you're telling me, though, however, that you were my concern is what we talked about, heard testimony before, is somebody coming into the emergency room at Friday afternoon and needs mental health addressed, and there's no one to talk to at the insurance company as to where to put them or how to get them admitted or what their needs are until Monday morning. And I kind of go along with this is that how can we make it so that not just the part of the insurance companies that we cover, but encourage the market in general to adopt a policy in the 21st century that information is readily available and 24/7? Because it seems to me like while the healthcare industry runs around the clock, the insurance companies shut down in the afternoons and on the weekends. And I think it could be better served somehow if we were to have maybe instead of a 24-hour window, maybe even a 6-hour window if it was done electronically. Are we moving towards that at all?
Yes, and thank you for bringing up that point. I think it's a very good point. I do think as electronic medical records evolve, and they're doing so quickly, both under federal guidelines and under state guidelines, you will see less and less of a administrative burden because everybody will have access to the same clinical information, which is used to determine medical necessity and to establish prior authorization. I think, prior auth is a very easy target, and it certainly plays a part in terms of, some of the issues you've heard today around emergency room backlogs. But as I think you heard other representatives and other stakeholders and other doctors even say, it is a multifold issue. It is not singularly on the back of prior authorization process. There are issues about, access to care on the weekends or nights. I know myself, I've brought family members to the emergency room at the suggestion of their primary care physician who couldn't see them at that point in time. And I think there's probably a welcome audience in this group here to say liability plays a large part of that, right? They don't want, even if they don't think it's anything serious, it's a UTI or what have you, the medical malpractice situation in the state, is pretty significant. So nobody wants to take on that liability. I think that plays a large part in, folks getting sent to the emergency room, folks coming out of the emergency room, COVID and other respiratory diseases like RSV made sure that people had to go back to nursing homes in single rooms as opposed to double rooms or triple rooms. That caused backlogs, coming out of the hospital. So there are a number of reasons and factors that I think are playing into this. And certainly I'm willing to take the spears where where prior authorization has not functioned as it should, but I do think it's much more multifaceted than just that.
I agree with you. And I don't think you can have prior authorization in an emergency. My question is, at that point, shouldn't we just trust the provider and deal with the rest of the deck later?
Well, I think if you're a layperson, you don't have prior authorization in the instance of an emergency.
I'm sorry.
You don't have prior auth in the instance of an emergency.
Yeah, that's what I'm saying. So that if a doctor, so maybe at that particular point, we should yield to the healthcare provider at the emergency room to do the admission and then deal with the after effects later, instead of allowing for, you have to wait until the insurance company makes the decision. And that's what I'm saying. If you're not 24/7 working with us, then how else can we do it to make the system work as efficient as we can?
It's very difficult, and you've seen this in the insurance committee. It is very difficult to answer the anecdote. And I think that's why you saw the legislation also passed last year that included data submissions under the Connecticut insurance report card on prior authorization. I'm just as guilty, right? We hear a story that's compelling to us and we keep revisiting it. I think we have to take a fresh look at what's happening, what are the causes, what are the roots behind it before we can adopt additional policy. And I would just hope we've done a lot, and the Biden administration has done a lot. And certainly for a small state like Connecticut with 4 national health insurance carriers, it is easier to implement something on a national basis than it is to go state by state. And given that that rule just came out 3 weeks ago, I would hope we would give it a chance to roll out. And it's going to roll out over a couple of years because these are complicated, complex systems interactions that are happening and require electronic communication between providers and carriers and intermediaries. So, but the rule is on the books. It is in effect. And I hope we'll give it a chance to roll out before we take additional action in this space.
Thank you very much for your time. It's always a joy to talk with you. And I yield back to the chair.
Always a pleasure. Thank you, Representative.
Thank you, Representative Denning. Senator Gordon to be followed by Representative Carpino.
Thank you, Madam Chair. I could ask hundreds of questions, but I won't. But I'm
Thank you for that.
That's correct.
But you won't be off the hook because I'll ask them offline. So let me start out with a very basic question that I think we can all agree upon. The number one priority is to make certain that people get the medical care they need in a timely manner. Isn't that correct?
Agreed. But if they don't have coverage, they don't get the care. So I guess that's my only caveat to that.
Thank you. That wasn't my question though, but I think my understanding is that we can agree that priority number one is making certain that people get medical care when they need it in a timely manner. And certainly if someone doesn't have medical insurance, especially in emergency, things are taken care of for them. So with that premise in mind, which is how I've always guided myself as a doctor for more than 30 years, prior authorization is contrary to that, directly contrary to that. My question is, how is it that an insurance company feels that it can make a medical decision when a doctor, a nurse practitioner, another healthcare provider, duly educated and trained and licensed in the state of Connecticut, perhaps more than one state like me, that those decisions would be overridden when we're there with a patient, many times in person, making complex medical decisions? Certainly we do follow FDA guidance, but as you know, there are many things that aren't FDA approved. Aspirin isn't FDA approved, yet it's used all the time. But yet we have to jump through hoops to provide what we just agreed upon is priority number one, caring for people for the care they need in a timely manner. I'm just trying to understand where an insurance company feels it knows better than, for example, a doctor to be making those decisions for patients here in Connecticut.
I guess I'd go back. Well, first, I think it's not just an insurance carrier. I think Medicaid does prior authorization, Medicare does prior authorization. So this is a process that is across our healthcare continuum. So I guess that would be my first answer. I would also point you to some of the statements that are in my written testimony that 65% of physicians report that between 15 and 30% of medical care is unnecessary. There are a number of studies that talk about the billions, unfortunately, dollars that are wasted on excessive testing and treatment. There are also a lot of studies that talk about the low value care that a number of Medicare beneficiaries have received. So, you know, I don't want to sit here and say that I don't value and don't support the judgment of the medical profession and you in particular. Certainly, I think we all do. We're talking about coverage. We're talking about systems of care, and it's very difficult to compare a single situation to a system of care. It's the same thing you're seeing on Medicaid. And you struggle with as legislators that oversee the Medicaid program. It's the same thing that the federal folks struggle with in overseeing the Medicare program. There aren't infinite resources, and we have to look at that picture in its totality.
Oh, thank you. And that gets to my next question, which I now don't have to ask because I think it was just brought up about it being a business model and certainly trying to save money. And my last question, and the rest of my questions, I'm happy to send you in pages of a letter. When in your testimony, I read through both of your testimonies, you did mention here about that you stated that, quote, the number of treatments subject to prior authorization is small, less than 15%, end quotes. So my question to you is, if we look at the top 20 procedures or treatments per specialty, what is the percentage that you have that is actually having to go through a prior authorization? Because I can tell you as a board certified cancer doctor and I'm board certified hematologist, so I do both. It is at least 50% of the major things that I have to do for patients on a daily basis, including on weekends sometimes, that I have to go through a prior authorization process. So, you know, your testimony is there, but I'm very interested if we look at the top 20 in each specialty, what is the percentage that have to go through prior authorization? And I don't want to put you on the spot, certainly. So if you don't have that, I'd welcome an opportunity to know those numbers.
No, I think your question is a good one. And I think that's why the legislation passed last year that's going to collect that data as part of the insurance department's report card. I don't have it at my fingertips, nor easily or readily available, but you will have it. You will have it as a matter of the legislation that you passed last year.
And thank you. And I think if you talk with doctors and other healthcare professionals, you'll find out that we have to deal with it at least 50%, if not more, on a daily basis. So I think the data is going to very much support that. And that 50% may actually be an underestimation. And that gets back to my original point is we're focusing on providing care to people when they need it in a timely manner and these types of things. And why I argue strongly for some of these bills, did last year and am this year, is it gets to interfering with that type of care. I understand about costs, but at the end of the day, we're taking care of people and we need to make certain that we can when we're trying to deal with the interference by prior authorization and also the interference by step therapy. But those are all the questions I'll ask right now, Madam Chair. Thank you.
Thank you, Senator Gordon. Representative Carpino.
Thank you, ma'am. Sue, thank you for being here. You know, I have shared my frustration and without mincing any words, with you on many of occasions with prior authorization as a legislator, as a caregiver, as a patient, and you have been more than fair with my responses. It is an imperfect system, and to be honest, I think a broken one, but I'm not here to beat you up tonight. I was hoping that if not tonight, but in short order, if the carriers could provide some realistic solutions to fixing this, right? We hear about prior authorization being broken every year. I'm not sure I have gone through a session without talking to families, constituents, patients who have story after story about frustrations they have experienced with trying to get the care that their healthcare providers, their chosen healthcare providers, believe is in the best course for their future. So if you, on behalf of the carriers, could provide me, and I'd be happy to share them with this committee, with some realistic suggestions as to how we're going to fix this system. And I realize that there's no panacea because somebody long before me would have found it. But I'm frankly frustrated with hearing about different failures in the pre-authorization system, and I never hear a solution from the carriers. So I don't expect you to have an answer. If you do, by all means, I'll listen, but it's 7:30 at night and I'm catching with that question cold. But if you or any of the carriers would like to provide some realistic solutions, I'd find that more fruitful than railing against prior authorization tonight.
I guess I would just add, and I appreciate your comments, and I always appreciate a dialogue with you. We've known each other for a lot of years. I will say that the Biden administration did just issue a rule literally within the last 3 weeks. I think everybody is still digesting it. I think the aim is to resolve some of this burdensome back and forth. I do think electronic medical records and electronic interchanges that are coming to fruition are going to resolve a lot of this as they come into commonplace practice. So I do think there are solutions on the horizon, and nobody would be more hopeful than me that they will come to fruition. So thank you.
Thank you. You're far more optimistic than I am. I'm not convinced that electronic medical records seamlessly syncing are going to solve our problems. Thank you, though. Thank you, ma'am.
Thanks.
Thank you, Representative Carpino. Seeing no other questions, Ms. Halpin, thank you so much for staying with us and for answering our many questions. And I know we'll continue the dialogue both here and in other committees as well. So
Yes.
thank you so much.
Thank you for the opportunity.
Next, we have James Christina on the list. Patrick DeHere will be reading Dr. Christina's testimony. Welcome.
Thank you. Thank you to the members of the Connecticut Public Health Committee for granting me an opportunity to speak on this important matter. I'm Dr. Patrick DeHere, a trustee of the American Podiatric Medical Association, and I speak in favor of HB number 5196, an act expanding the podiatric scope of practice. And I am speaking on behalf of Dr. Christina. I have been involved in podiatric medicine for over 30 years, and for the past 9 years as a trustee of APMA. I currently practice in Indianapolis, Indiana, and have served on the Indiana Podiatric Medical Association board, including as president. I also serve as residency program director at a large teaching hospital, Ascension St. Vincent's, Indianapolis, and I'm heavily invested in the training of today's podiatric physicians and surgeons. Today, I am speaking on behalf of the members of APMA. APMA is the premier professional organization representing a vast majority of the estimated 15,000 licensed podiatrists in the United States. Within APMA's umbrella of organizations are 53 component societies and states, including Connecticut, and other jurisdictions, as well as several affiliated and related organizations. We adamantly support the modernization of Connecticut's podiatric scope of practice laws. This modernization is essential to ensure that the legal authority to practice podiatric medicine and surgery in Connecticut is in alignment with the rigorous education, comprehensive training, and experience DPMs possess to be consistent with the countless other states in the United States. APMA rejects the assertions made by other stakeholders suggesting that podiatric physicians seeking to perform these procedures lack the required training and education. We believe that the studies cited indicate concerns about patient safety are poorly designed, misleading, or misinterpreted. DPMs are extensively trained to effectively diagnose and address conditions impacting the lower extremity. This expertise includes the foot and ankle, and when necessary, the muscles, tissues, and bones of the leg. It is important to emphasize that podiatric physicians are the sole group of healthcare professionals who undergo specialized medical training and obtain board certification exclusively dedicated to the comprehensive care of the foot and ankle. Regarding CPMA's proposal to modernize the scope of practice to permit qualified podiatric physicians to perform the aforementioned procedures, it is important to note that these procedures are already well within the skill set of today's podiatric physicians and surgeons. However, under current Connecticut law, the limitations imposed on DPMs practicing in Connecticut prevent these skilled surgeons from performing these procedures. Concessions in 2006 were made in a long-fought compromise between various stakeholders to update Connecticut's podiatric physician scope of practice to include treatment of the ankle. Since that time, a majority of states have incorporated these procedures into their podiatric physician scope of practice. With regard to the specific procedures permitted state by state in APMA's review of podiatric scope of practices, we found the following. Total ankle replacements, an overwhelming majority of states permit treatment of the ankle and leave specific delineation of privileges up to the facility. Only 4 states, including Connecticut, explicitly exclude podiatric physicians from performing this procedure. Tibial pylon fractures. Similarly, an overwhelming majority of states permit podiatrists to treat tibial pylon fractures and leave specific delineation of privileges to perform this procedure up to hospitals and other similarly designated facilities.
Excuse me, Dr. DeHere, but your time is up. Thank you.
Thank you for your time and consideration.
Thank you so much for staying here with us and for sharing this testimony. As you know, we've had lots of conversation today, so appreciate you sticking with us. Seeing no questions, we will move on to Our next stakeholder here is Dr. Paulina Piekarska, followed by Greg Allard. Welcome.
Hi, thank you everyone. Thank you distinguished members of the Public Health Committee for allowing me to come and speak to you today. I am speaking in favor of House Bill 5196. I wanted to essentially share insight into my journey as a young podiatric surgeon that has just recently returned to Connecticut to practice. So I've lived in Connecticut most of my life. My family moved us here from Poland when I was just 5, and we pretty much settled here and stayed here. I did my undergraduate training at Quinnipiac. I majored in biomedical science with a minor in chemistry. I did 4 years of graduate school at the New York College of Podiatric Medicine. And then I came to Yale for my residency. And during my training at Yale, I did perform total ankle arthroplasty and pilon fracture fixation under the guidance of my MD and DO counterparts. Ultimately, I pursued fellowship. So I attended the West Virginia University Medicine Foot and Ankle Advanced Surgical Fellowship. This is just 1 hour outside of Pittsburgh. And it's one of the many states that's unencumbered by the restrictions that bring us here today. In fact, my first case into fellowship was a pilon. It was a young 24-year-old boy who worked as a house painter, and he had fallen from a ladder. And ultimately, I'm back here speaking with you because I accepted a position in Connecticut. It was actually advertised for a fellowship-trained foot and ankle orthopedic surgeon, and I am not an orthopedic surgeon. I do not claim to be. My training from the beginning was always more fixed, more predetermined. But I accepted the position. I became the second female surgeon and first podiatric surgeon to work at Coastal Orthopedics, which is a division of Ortho Connecticut. And I'm very happy to be home. I'm happy to be taking care of my community, but I am now at this point forced to weigh my obligations to my patients against these restrictions that bind me from providing comprehensive care. Most recently, I was sent an ankle fracture from one of my orthopedic partners, and according to the CAT scan that I ordered, there was just enough of that tibial articular surface involved where I could no longer treat this patient. She was one of my young Medicaid patients. And so at that point, I considered 2 options. I either have to refer her out and hope that she finds timely care. What I ultimately ended up doing was discussing this with my partners, and I do most of the foot and ankle trauma there for them. And one of them agreed to take this case on with me. So I am no longer her primary surgeon, but I am there from start to finish because that is what I trained in. I actually presented on pilon surgical techniques at the American College of Foot and Ankle Surgery meeting in 2022. So I'm here now, and I'm so happy to be here taking care of my community. But I find that the longer I'm here, and I've only been in practice 1 year and 5 months, the more I realize that these restrictions are inhibiting me. And as long as I stay in Connecticut, at least a portion of my training is for naught. And I want to thank you so much for letting me speak with you today.
Thank you so much. And thank you for the care you provide for the residents of our state. And we're glad you're back here in Connecticut. Seeing no questions, thank you for spending your time and sticking with us today. And we're going to go on to the next person on our list, who is Greg Allard, to be followed by Dr. F. Scott Gray.
Good evening, Representative McCarthy-Vahey and Senator Anwar and the other distinguished members of the Public Health Committee. My name is Greg Allard, and I'm the president of the Association of Connecticut Ambulance Providers. On behalf of the Association of Ambulance Providers and EMS providers across the state, thank you for raising Senate Bill 179. We stand in strong support of this legislation. You heard from several other of my colleagues today talking about this bill and its need within our state system. And I wanted to just say that I did submit written testimony, so you certainly could read that. But I did want to talk about a couple of points that were raised in testimony today, or that were questions that were asked of the committee. So Connecticut is one of only a handful of states in the country that has rates set for it by their departments of public health. So our rate is set for us by the Department of Public Health, the Office of Emergency Medical Services. We have an application process that we all have to follow. We have a short form and we have a long form option. These rate settings were brought into the state through a number of complaints that were brought up throughout the system, and it was done in conjunction with the EMS providers, the Department of Public Health, and obviously the legislative body, because it is in statute today that we do go through that process to get our rates. So the short form is a small application. You put in some information, you submit it to the state, and they accept that. And basically what you're doing by filling out the short form is you're accepting the rate of increase that the state has established they deemed appropriate that year. The long form is a much more detailed process where you're submitting basically all your accounting information for your service for that particular year, all your expenses, your losses, all that is within there. And then they review that information, and then there's a possibility that you may get more than what the state has deemed appropriate for an increase that year. So there is a lot of scrutiny that these rates and that our rates go through. It has been beneficial to the state and the people that reside within the state and that we care for, because in comparison, our rates are lower than our surrounding states. And just as a comparative as to rates and the way that other states do this, because that was a question as well by some that there are some states, again, that do this. In some other states, it's not the state department that's doing it. It's set by the counties. In some states, it's set by the municipalities. And then there's some states that don't set rates at all. They're just arbitrary rates that are set by the providers. So, we appreciate the process that we go through. I also want to bring to attention that, CMS themselves looked at, this as an issue. And in 2018, their Bipartisan Budget Act in 2018, CMS was asked to start to collect ground ambulance data, just like we're already providing our state. So basically, they want to look at the rates and the data that we're, providing our costs, our expenses, that type of stuff, and compare it and do an assessment to see if their rate for Medicare is adequate. And we all know that it's not as providers, but this is their way of starting to gather this data. So it has been, as of recent, the services around our state and others are starting to provide CMS with this data as well, so that they can look at that information.
Excuse me, Mr. Allard, but your time is up. Thank you.
Well, thank you. I'll be happy to answer any questions.
Thank you so much for being here today and for your tireless advocacy on this issue. I know we will be continuing the conversations with you and others, and I thank you for spending time with us this evening.
Thank you.
Seeing no questions, we will go to Dr. Gray, to be followed by Marisa Tukpa.
Okay, can you hear me all right, everybody there?
Yes, we can. Please proceed.
Thank you. Well, good evening, distinguished members of the Public Health Committee. I'm Dr. Scott Gray, an orthopedic surgeon and foot and ankle surgeon with 37 years of experience in the Danbury area. And I thank you for the opportunity to share my testimony in opposition to Health Bill 5196. You will be provided with my expanded version of my testimony today for your review. This expansion proposes adding 3 very complicated surgeries to the scope of podiatric practice in Connecticut, one of which was never discussed in the DPS scope working group of which I was a member. During our working group meetings, podiatry representatives did not include additional scope requests in this bill, one additional one, allowing the management of complications associated with the placement of external fixation devices in tibia. Fixator potential complications include tibia fractures, tibial osteomyelitis, or bone infections that often require subsequent surgical procedures that they currently can't do based on proposed scope of practice or their current scope of practice. They require performing surgery above the muscle tendon junction of the calf and muscles in the lower leg, and or potentially at the knee joint level, to eradicate infection and to manage iatrogenic or physician-caused fractures and non-union complications. How can legislation allow the management of complications in the diaphysis of tibia from the use of external fixators when the procedures required to manage these complications are not legislatively sanctioned? As a member of the DPH Working Group on Podiatric Scope expansion, I'm aware that the DPH report, which recently came out, is a comprehensive reporting of each meeting activity and the data submissions. The report will not have any recommendations attached to it, I believe. I have been disappointed with the Podiatry Association's lack of regard for the peer-reviewed, data-driven, industry-regarded journal reports that were provided to the working group, and other members have talked about them today, as well as what I feel a lack of commenting about the fact that the reporting of total ankle and pylon fracture procedures in the logs in their own state residency programs were missing. There just weren't any. Access to care in Connecticut for total ankle replacement and pylon management by orthopedic surgeons is not compromised. That is because pylon fractures require hospital admission, and orthopedic foot and ankle surgeons and trauma surgeons get consulted for these problems. So access is not an issue. In every, and neither is total ankle, because total ankle replacements are not urgent or emergent cases, they're elective cases. And in every county in Connecticut, orthopedic foot and ankle and trauma surgeons are available, no matter what level of insurance a patient has or doesn't have. And this evidence was presented to the working group. So I respectfully request that this committee oppose the scope of practice expansion requested by the Podiatry Association in this bill. Since 2007, there is no evidence that adequate improvements in the level of training for these very complicated procedures has occurred, thus putting the health and safety of our adult and child population at risk. Thank you for allowing me the time to stay with you into the evening, and I'd be happy to answer any questions or elaborate on my testimony. Thank you.
Thank you, Doctor. Senator Anwar.
Thank you, Dr. Gray. Dr. Gray, what were the areas that you would agree with the request?
Well, let's start with the one that we never even discussed in the work group, and that is the external fixation. We can't, I gave you the reasons why that would not be appropriate. The other problem with Dr. Anwar is what you just asked me, is that looking at the language of this bill and expanding the podiatric scope of practice, it doesn't include the request for more proximal midfoot amputations. So I guess I can comment on it, even though it's not in the bill. That was something we agreed upon. We also agreed upon the fact that the podiatrists would remove, they're required to do pylon fractures. So those are the things that we agreed upon in the group, that midfoot amputations were reasonable since the podiatrists were doing a yeoman share of foot and ankle diabetic, even though most foot and ankle surgeons in Connecticut, like myself, take care of complex diabetic problems. But the one thing we could not agree upon was the approval of total ankle replacements, and a lot of comment today, and I've sat through most of it, I think gave you our opinion about why that is.
So I just want to clarify, you said midfoot amputations was something that the two parties had agreed on, and what was the other part?
Yes, we agreed that they would remove the request for pylon fractures until, as Dr. Peden, I think, testified, that we couldn't come to agreement on total ankle replacement. And then they changed their mind and said they were going to put it all back in. I think they were disturbed by our opposition to that. So one area of agreement was something we agreed to remove, and one area of agreement we agreed to something that could stay. But the strange thing is that's not in the bill.
And the other question I wanted to ask, this pylon fracture, there was this question of a CAT scan that would give us an angle of some kind. Is there a technical rationale for that?
Yes, so let me explain carefully what a pylon fracture is. It's a high energy injury that usually results in a significant comminuted, meaning the fracture that is in the distal end of the tibia at the ankle joint, that can turn the ankle joint into cornflakes, basically. It can be 2, 3, 4, 5 pieces. But also the definition of a posterior malleolus, the orthopedic definition, is if there is a fracture in the back part of the tibia that involves 25% or less, we call that a posterior malleolar fracture, and that is within the current statutory scope of practice guidelines for podiatry. If that fracture involves more than that, it is technically not considered a trimalleolar fracture any longer and is considered a low-grade pylon fracture. It also has a little bit of a different classification, but it's not considered a trimalleolar fracture. technically it would be considered a pylon and often occurs with higher injury. So our concern in the group when we brought it up to podiatry was that we were concerned that because podiatry, and I don't like anecdotal things, but I just will give you one. Many times over the past couple of years, probably a dozen, I have been involved in peer review of cases where a podiatrist will schedule a case and do it and call it a trimalleolar fracture because they're allowed to do that when the surface area of the injury to the tibia is more than 25% of the posterior part of the tibia. And that, to be honest, is dishonest. It means that they're using a statute and using a definition of what they're allowed to do from a scope standpoint inappropriately based on the configuration of the fracture. Does that help?
It does. Again, having a little bit of an insight in some components of orthopedics, there's a rationale for some of those angles. There's a
yes. So
procedural component. We were led to believe that it was just being nitpicking rather than actually.
So I heard the testimony of Dr. Gabriella, and there was something about what he said, which in my opinion couldn't be more inaccurate. With pylon fractures and with many bimalleolar fractures and almost all trimalleolar fractures, the standard of care is to get a CAT scan. That is because a plain X-ray is a two-dimensional study, a two-dimensional radiographic study. Two-dimensional radiographic studies can miss central intra-articular components of the fracture, kind of in the middle of the end of the tibia. You just can't see them. And you need to know they're there to know how bad it is and to know what needs to be done and know how to make your approach and or what kind of hardware may be required. That's why the CAT scan is the standard of care. So when Dr. Gabriella testified that often, or most of the time it's not necessary, that's not true. We use CT scanning as a standard of care to identify things that can be missed on plain two-dimensional radiographs when we understand that the mechanism of injury has a high likelihood of causing more damage than might be apparent on plain radiographs. So CT scanning is done to identify what we're going to do with that injury. But it also helps identify whether something is simply a posterior malleolus component of a trimalleolar fracture or involves more of the joint surface and therefore shouldn't be called a posterior malleolar fracture and would take it out of the current scope of practice allowance.
Okay, thank you so much. Thank you for your testimony and answering some of the questions. Thank you.
Thank you, Senator Anwar. Representative Clara Destitria.
Thank you, Madam Chair. Thank you for your testimony here today. I heard you mention at one point that there was something wasn't in the bill as written, and just to clarify that our attorneys write a bill based on that. I believe they wrote it based on the recommendations from the working group. But now, correct me if I'm wrong, but I thought you agreed to total ankle amputation and not the pilon fractures during your deliberations with the working group.
Well, with all due respect, there's no such thing as a total ankle amputation. We agreed in the working group that an amputation in the midfoot up to the talonavicular and calcaneocuboid joint would be okay. Because to remove the whole foot and just leave the end of the tibia and the fibula is not any longer an accepted or defined procedure. So it's not relevant. So we agreed to allow amputations one more level up than the foot than is currently allowed, which is at the tarsal metatarsal joint. And we had really no real problem with that. And remember, I think I also stated that we agreed that pilon fractures would be removed. And I just find it interesting. I don't know what to do with it. Maybe you can tell me how to understand this better. But in the bill raised that I'm looking at, it just doesn't have the amputation component in it. And maybe it should.
It possibly could, as we continue through this process. These bills, as we go through, aren't the final determination. It's not the final bill. So we
that's good, because it's definitely something we had discussions about and agreed upon in the working group, for sure.
Thank you.
Thank you, Representative Clara DeStitria. And yes, these public hearings, this is what we do. We hear and listen, we have conversations with one another, and then we continue to discuss and refine the bills as we move forward. So Dr. Gray, thank you for being here with us today. And
Thank
no other questions, we will move to Marisa Tupa, and please correct me if I mispronounced your name, and we'll be followed by David Kamenier also. Hopefully I got your names right. Welcome.
Yeah. Welcome. Hello, esteemed and honorable members of the public health community. My name is Marisa Tupa. I work with the research and development team for Department for Diva Curl, which is a Henkel-owned brand which produces and markets products that are sold to consumers for textured hair. And in this case, textured hair is referring to hair that is coiled, curly, and wavy. Diva Curl is a founding member of the Texture Education Collective and an alliance of professional hair industry leaders working together to influence cosmetology state board licensing requirements and curriculums to be inclusive of all hair textures and all hair types. We envision an inclusive professional hair industry for all, from behind the chair and beyond. On behalf of the TEC, we write to express our strong support for SB 178, which would require barbers, hairdressers, and cosmeticians to receive training and pass testing on working with textured hair. The legislation will ensure safe and sanitary textured hair care services are provided by educated, trained, and licensed beauty professionals in Connecticut. 65% of the world's population has textured hair, and as someone who falls in that demographic, I have personal experience where I've encountered cosmetologists who were unfamiliar with styling my hair type. Through my current role at Diva Curl, I've spoken to stylists who look to directly address the gaps in their knowledge and with complicit training on how to style textured hair. Hair is a deeply personal experience, and we want people to feel confident and beautiful when they come into the chair, especially with uniquely textured hair in all ways that is linked to our personal identity. With the passage of this legislation, Connecticut will be in the forefront of promoting a more inclusive profession and experience for consumers. The Texture Education Collective urges the honorable members of the committee and the Connecticut legislature to support and pass the legislation. It represents a significant stride towards creating an industry that can safely meet the needs of every individual, fostering inclusion, understanding, and ensuring safe services. Thank you for listening to me, and I'll answer any questions.
Thank you so much for being here. And I love what you said. We want people to feel confident and beautiful. And when I was in college, I remember we used to saying, look good, feel good, do good. So we have a question, Senator Marks.
Hi, thank you, Chair. Thank you. I have been known many, many, many times to say Diva Curl has changed my life. So, and I mean that sincerely. I have very, very curly hair. And I just love you. And I will say, as a kid with curly hair back, in the 60s and 70s, we had to have short hair because you couldn't have nice curls because nobody knew how to cut curly hair. I do know, I'm getting my Diva cut and color Saturday morning, that Diva Curl, you have a good business where my beautician got certified by you in order to do Diva cuts. So how will this affect your business model if all of the people are going to learn this now in cosmetology school?
So it will only assist our business model. Currently, we have access to classes online, but there are some cases where people can't field into that, or they might not have the barrier of entry. So we want to sort of eradicate any barriers of entry that you might encounter. So we're going to try to use these bills to help across all states to help inclusify the testing and make this a mandate. We don't want curly hair to be separate from any hair. Hair is hair. Everyone should be educated on how to cut it, how to use it, and how to style it. And if you want additional specifics and you want additional help we can also offer that. It's the same from any other hair care styling team. Just because we're Poi specific and we were one of the first people to support this bill as well as to offer classes doesn't mean that's the only recourse that we should offer cosmetologists.
Okay, thank you so much.
Thank you, Senator Marks. Representative Carpino.
Thank you, ma'am. I know I have pin straight hair, but my daughter does not. So I have a couple of questions, and very, very succinct at this hour. How much training do you require for your certification, and how much training are you looking to include in future iterations of this bill for, promising students? I want to understand the difference and the actual numbers and type of training that we're looking at. So if you're now offering, and that was great information, so thank you. If you're now offering a certification or an extra for hair care professionals to offer to their clients, I have to imagine that there's a certain set of requirements that you require them to go through. And I want to know how that would differ from what we're looking to include for all future students here in the state of Connecticut.
So there will be no increase in hours. So if part of our program to become with a certain type of cut that we offer, I believe it's anywhere from like 120 hours. But the way that we envision this bill moving forward is that we want them to have familiarity with curly hair in tandem. So one of the founders, Sean Stearns, already does a free program where he does texture mastery. And so he does it in tandem while they're learning on straight hair. So the students work with 2 mannequin heads during the program, one with straight and one with curly. They use the resources that they're already involved. So there's no additional hours that they might have to have as part of the program. It's just introducing and having that comfort level when it's not already required for them to even touch curly hair on the process of becoming certified.
Thank you. That's helpful information. Will it raise the cost of the courses, in your professional opinion, to be offered? Because obviously, if it's a raised cost, I worry about the implications it might have on students. So I want to better understand.
No, not currently. So because we have the mastery program currently, so they utilize current textbooks from Pivot Point or Malady, who have also signed the education collective. So they are using resources. So there's no additional cost to the clients who or the students who are involved in this program.
Thank you. Thank you, ma'am.
Thank you. Thank you so much for staying with us today and for sharing that very helpful testimony. Seeing no further questions, I believe next is David Kamenier. Please again, correct me if I'm wrong on the pronunciation, followed by Ashley Weiss. Welcome.
Perfectly. Thank you very much. Thank you. My name is David Kamenier. It is my pleasure to provide testimony in support of the Bill 5196. I'm a second-generation podiatrist and foot and ankle surgeon. I've been in practice for almost 30 years and was the first podiatrist in the state to join an orthopedic practice now called Connecticut Orthopedics. This is the largest orthopedic practice in the state of Connecticut. I work alongside orthopedic surgeons every single day. In fact, throughout my career, I've been asked to assist and co-manage nearly every single total ankle arthroplasty and pilon fracture that my orthopedic partners have treated, because they understand full well that I have the training, board certification, and experience not only to assist them, but also to perform the procedures. Yet the current Connecticut statute won't allow me to perform these procedures on my own. 17 years ago, along with my colleagues, I sat in front of this committee and successfully testified to change the law to allow qualified podiatrists to perform ankle surgery. And since then, we've been able to safely perform surgery, ankle surgery, and there has not been a public health crisis with respect to podiatrists performing ankle surgery. There simply has not. I see that some of the same orthopedic surgeons who testified against us back then are here once again today, and a few with a paucity of experience are also testifying against us. Once again, they are demagoguing the issue. They continue to use the same antiquated arguments that they used 17 years ago. This is their playbook, the same false narrative, the same inaccurate statements about our training, the same hyperbolic fear-mongering concerns about patient safety and patient welfare. This is a canard. This is a false story. It is simply not true. To my knowledge, there has not been any public health safety issues related to trained podiatrists performing ankle surgery. In fact, let me ask you, why is it that two of us podiatrists testifying here today are working as foot and ankle surgeons within orthopedic practices? Is it because they don't trust us? Do they think we're poorly trained or unsafe? Of course not. It's the exact opposite. They trust our training. They trust our board certification and ability and understand that we have the knowledge and skill set, more importantly, to perform these procedures. 17 years ago, as a compromise with the orthopedic surgeons to get the law changed, total ankle arthroplasty and pilon fractures were excluded from the state. But now this was an arbitrary exclusion in order to make some progress on what was then considered a very restricted license for podiatrists. The time has come now to modernize the Connecticut statute for qualified podiatrists. Our training has certainly been vetted. Our board certification is standardized, and we are not requesting anything unusual or out of the ordinary, nothing that's not been done in almost every other state in the United States. This is a reasonable change to reflect what we are trained, tested, and board certified to do. That's it. Thank you very much, and I look forward to answering questions. Again, I urge your support of HB 5196.
Thank you very much for your testimony today, and for your passion for your profession, which we've heard today from a number of those who have shared their testimony. We have a question from Representative Parker.
Thank you, Madam Chair. Thank you, Doctor, for being here. Yeah, I had to double check Connecticut Orthopedics, given where you're testifying on this. By the way, your colleagues have helped both of my knees and my elbow to great effect. So I'm grateful for that. And today, the only folks that have spoken, I may be wrong, but I'm pretty sure that the folks that have spoken against this are the orthopedic surgeons. Folks that have spoken for this are the podiatrists. Do you think that you have colleagues that I'm sure you can't speak on behalf of Connecticut Orthopedics, but do you have colleagues that are orthopedic surgeons, orthopedists, that would say, sure, we should expand your scope? Are these conversations that you have around your office? And can you give us any insight there other than sort of the dichotomy we're seeing today?
Yeah, I believe I can. I think my colleagues, in particular, the colleagues that I've been working with for a long period of time, will tacitly support me as an individual. I think they risk being vilified by their orthopedic colleagues if they come out in support of an entire profession. But I can tell you, certainly on a personal level, and of course on a professional level, since they're the ones who asked me to perform these cases with them, that they support my ability and my efforts to do this.
And so you're able to do these under the supervision or partnership of these orthopedists? I know that what we're talking about today, if the change was made, maybe the hospitals could decide who practices at their hospitals, doing what, that's great. In a private practice like yours, are you already a part of these procedures, you're saying, but they just have to have an orthopedist at the table or in the room with you?
Typically, they're their patients, not my patients, and they ask me to assist because they understand my skill set and my training and my experience. And, let's be, I like to look at things from a common sense standpoint, and these current exclusions just simply don't make common sense. I mean, look at ankle arthritis. I mean, we can treat ankle arthritis surgically with a complex operation called an ankle fusion. I mean, it only makes sense that we should be able to treat the same diagnosis with a joint replacement if indicated. In fact, as the law is currently written, we can actually remove a problematic total ankle replacement and fuse the ankle. But we're not allowed to replace the ankle. We can remove it, but we can't replace it. This makes absolutely no sense. The total ankle arthroplasty or replacement procedure should not be an arbitrarily excluded for the treatment of a diagnosis that we can certainly manage surgically. What about ankle fracture? Pilon fractures, as has been said by our orthopedic colleagues here, pilon fractures is nothing more than a variant of an ankle fracture diagnosis. And we get into the nitty-gritty of, what's the difference? And that's the point. It becomes cumbersome. But we can already treat the diagnosis of ankle fracture. We can already treat other ankle fractures surgically. So once again, it makes common sense that we should also be able to treat pilon fractures or pilon fractures, as they fall into the diagnosis of ankle fractures. The treatment of pilon ankle fractures should not be arbitrarily excluded. It makes common sense that we should be able to treat all ankle fractures surgically, not just certain types of ankle fractures surgically.
All right. Thank you so much. Thanks for your time, Doctor.
Thank you.
Thank you, Rep. Parker. And I was remiss in not going first to our good ranking member, Representative Claritas Detria.
Thank you, Madam Chair. That's okay. Hi, Dr. Caminair. So glad to see you here today. So you were part of this task force, is that correct?
Yes, I was.
And during these meetings and your deliberations with DPH during your meetings, was there an agreement that you came to at some point?
Absolutely not. And I'm so glad that you asked this question, as I just sat and listened to Dr. Gray's testimony to you. And we must have been sitting at completely different meetings. We agreed to nothing. As a matter of fact, we came to the table in good faith with a compromise. It was completely rejected. And so at that point, after it was rejected, and after they tried to surreptitiously try to redefine the ankle and ankle surgery, which is a procedure that we can currently perform, we were a little bit concerned that they might do an end around and try to pull those privileges from us to begin with. So it was at that point that we said, you know what, we apparently us acting in good faith wasn't good enough. So let's go back to our original proposal and add the pilon fractures back in, which is what we wanted to do originally, with the total ankle arthroplasty and with the amputation. And again, I don't recall agreeing on anything at the work group. It was like two sides with a huge wall in between us, and we came to the table, I believe, as podiatric surgeons with a good faith effort to compromise. And simply my view of this was that it was completely rejected.
Okay, thank you for that clarification. And you had mentioned before, I think briefly you touched on, you have extensive experience with pilon ankle fractures and total replacement. Is that correct?
Yes, I do, as an assistant, correct.
Okay. Well, maybe we can consider bringing the two groups together with public health leadership to try and figure this out together, if that could be a possibility. Thank you again, Dr. Caminair. I appreciate everything you do.
Thank you very much.
Thank you, Representative Claritas Detria. Some of you may have heard me say this before. Oftentimes the term gospel truth is used, and I will point out there are 4 versions of that story. So I do very much, Dr. Caminair, appreciate your time, the time you invested into the scope review process, for spending time here with us tonight and answering questions. And I know we'll continue to have these conversations. And meanwhile, thank you for caring for the patients of Connecticut.
Thank you very much.
We have Ashley Weiss, to be followed by Sam Hallmeyer. Ashley, welcome.
Welcome. Thank you. Good evening, Senator Anwar, Representative McCarthy-Vahey, Senator Somers, and Representative Claritas Detria, and other esteemed members of the committee. My name is Ashley Weiss. I'm a respiratory care practitioner and ECMO specialist at Harvard Hospital and a resident of Waterbury. Today, I am providing testimony on behalf of the Connecticut Society for Respiratory Care, henceforth the CTSRC, regarding HB 5201 and commentary on HB 5199. The CTSRC would like to offer our support of HB 5201, the act concerning the use of funds in the Tobacco Settlement Fund. A significant portion of our adult patient population suffers from often debilitating lung diseases such as COPD and lung cancer, which can be a direct result of smoking tobacco. Even as cigarette smoking continues to decline, new customers of increasingly innovative nicotine delivery systems are born every day, and I fear that without specific funding, the users of these products will one day fill the shoes of our more traditional tobacco users. With smoking prevention campaigns, cessation programs, the Connecticut Quit Line offered by the Tobacco and Health Trust Fund have demonstrated that directly funding efforts to reduce the use of tobacco and nicotine products is effective in getting people to think about quitting, embarking on their cessation journeys, and receiving continued support. The next issue I was going to bring up has already been expressed by Adam Kay of Advanced Radiology Consultants in regards to HB 5199 and responded to exhaustively by the committee. The CTSRC is deeply appreciative of any and all efforts made to expand the various workforces throughout Connecticut. We do not undervalue any work that our varied colleagues do or their contributions to the health of our communities. We only ask that the task force on workforce shortages of respiratory care practitioners, radiologic, and nuclear medicine technologists be able to convene as soon as feasible in this complicated landscape of healthcare-wide staffing shortages, and that our deadline be extended to January of 2025. We are ready to begin devising plans that would provide us with similar infrastructure and education pipelines that exist for nursing so that we can begin to train new professionals and retain our existing ones. Healthcare is all about teamwork, but it's difficult to be collaborative when critical members of that team are in short supply. The vacancy rates within many acute and long-term care facilities in Connecticut are an ongoing issue, with anywhere from 20 to 40% of full-time positions remaining unfulfilled for months at a time. These staffing shortages are directly affecting the quality of care we can provide to our community members and can result in delayed treatment, extended hospital length of stays, and increased healthcare costs. Thank you, distinguished Public Health Committee members, for your time today and for your consideration. We look forward to meeting with you in these work groups and devising solutions to address our staffing shortages so that we can get back to helping our neighbors breathe easy. Thank you.
Ms. Weiss, thank you. More than I can say for your work and your testimony today.
My pleasure.
We will be in touch for sure. Thank you. Next, we have Sam Hallmeyer, followed by Martha Howard.
Good evening, Chair Anwar, Chair McCarthy-Vahey, and members of the committee. My name is Sam Hallmeyer with PCMA, which is the National Trade Association for America's Pharmacy Benefit Managers. PCMA's members and their clients serve 275 million Americans with prescription drug insurance. I did submit written testimony, so I will keep my comments brief in opposition to Senate Bill 180 and 182 as it's specific to prescription drugs. I want to start off, though, with no one is required to use a PBM. Plans choose to do so because PBMs save on costs through various PBM tools. Two of those tools I'm going to talk about today are prior authorization and step therapy. We're concerned that Senate Bill 180 will impact the way that prior authorization is done, as prior authorization is a tool used by health plans and carriers to ensure that medication is being dispensed clinically appropriate, safe, and cost-effective for the patient. So why would there be a reason for prior authorizations? Drugs that have dangerous side effects are impacted by prior authorization, and also drugs that are harmful when combined with other drugs. But then also there are drugs that are prescribed when equally more effective or more affordable drugs would work. Another tool that PBMs have is through step therapy, and plans use that to save on costs, and we're concerned that it would be impacted by Senate Bill 182. It ensures that patients can get safe, equally effective, and reasonably priced drugs that are available out in the market. And step therapy encourages trying proven, more affordable therapies before brand name drugs that cost more. The purpose of prior authorization and step therapy is not to interfere with the patient and doctor relationship, but prior authorization is another set of eyes so that the provider does not make inadvisable treatment, but also cost is a factor, as prescribers don't always have insight to the high prices that manufacturers set. Every plan does have an exceptions process that permits coverage of a drug, and then all of these protocols are set up by pharmacy and therapeutic committees that was mentioned earlier by the Association Health Plan testimony. And those are made up of doctors, specialists, pharmacists, and nurses as well. And finally, it was discussed on solutions that we could offer. I have a couple solutions: encouraging real-time benefit tools in e-prescribing to reduce the burdens that prescribers face, and then begin the prior authorization and step therapy process in the office with the patient and discuss and review pricing options. And another solution is just to address the high cost of prescription drugs that are out there and create more competition. I appreciate the opportunity to speak to you all in front of today, but I am opposed to Senate Bill 180 and 182, and I'm happy to answer any questions at this time.
Thank you. Thank you for being here with us for the day and for your testimony, Senator Anwar. No?
Sure.
Yes.
I'll go after Senator Gordon.
Okay, Senator Gordon.
You go ahead.
Thank you, Madam Chair, and thank you for your testimony. I just want to ask a few questions if you don't mind. All the other questions I have, which are probably a couple of hundred plus, I can always send to you offline if you don't mind.
I'd be happy to take a look, Senator.
Excellent. I look forward to that. My first question is, we can all agree that the priority number one is we're trying to do what's best for patients, in this case, the people of Connecticut, and giving them the care that's determined by a doctor or a healthcare professional that they need, and in a timely manner. Assuming you can agree with that.
Yes, I agree.
Thank you. And that's always been my premise. I know I said this earlier on my many years in taking care of people, and it still is the first and foremost in my mind. And you mentioned about safety issues, which we all take into account. You did mention about that, using the prior authorization process, and my other question is, I think you said another set of eyes, which would seem to be another bureaucratic layer. And you also mentioned about us being able to use EMRs and things like that, which actually don't necessarily make us more productive. It actually contributes more to our time and leads in part to physician burnout and for other healthcare professionals, certainly. So I'm trying to figure out, and my question is, how exactly does prior authorization step therapy, other than trying to save money? And there are many drugs of which there's no generic equivalent. For example, I can give a number of biologic drugs that are key to treat certain cancers and immune disorders, and there is no other drug to use. So I have no choice but to use a brand name. How exactly does that help patient care and patients getting care in a timely manner when there's no lack of data out there, especially talking with those in the trenches taking care of people, that prior authorization, things like step therapy, interfere in the decision-making and do lead to problems trying to get drugs for patients that are determined that they need, especially when there's no other equivalent.
Thank you for the question. I'm going to try and repeat back what was conveyed. So your concern is the issue with prior authorization of step therapy interferes with patients receiving their care. Am I summarizing it correctly?
Yeah, that's part of it. Yes.
Right. So, providers are obviously burdened with a lot more than just prescribing, and we don't anticipate you or prescribers rather to know that all the various benefit designs and drugs that are available out there and the negotiations that PBMs make with those drug companies to get to the lowest net cost for everybody. We don't anticipate doctors to have that insight. So that's why we work with prescribers to make sure that the patients are receiving the right care at an affordable cost as well. So PBMs are able to negotiate discounts on some of these brand name drugs, even if there's not a generic out there. So there could be competing brand name drugs, but we don't anticipate the provider to know all that information. So that's why we work with providers to make sure that the patient is getting appropriate care and safe care, but then also that they're getting at the lowest and most affordable cost as well.
No, I appreciate that answer. And I think that does give me some insight, since you're talking a bit about cost effectiveness and cost. And I think that gets to one of the, in my opinion, the real reason we have prior authorization in step therapy, which is to save money. But again, that's not the same as trying to give people the treatments they need and the treatments they need in a timely manner. So I won't ask any further questions at this time, given the late hour, but I appreciate your answering the questions and supporting my what I was trying to say. Thank you.
Thank you, Senator. Thank you, Senator Gordon. Senator Anwar.
Thank you, Madam Chair. So Mr. Hallmeyer, with the PBMs, your customer is the insurance industry, not the patients.
PBM clients are payers who, yes, offer prescription drug benefits to beneficiaries, aka patients.
But the contract, I don't think the customers of the insurance companies are signing on with your organizations. They're signing up with the insurance industry.
I'm sorry, I'm not sure I follow your question.
So your business model requires you to work with insurance company, and the stated goal is to maximize the profits for the insurance company in the business model. It's when you say that you're starting off your testimony, you mentioned that the patients have a choice to work with you or not work with you and make that choice, but the patients are going to the insurance company, and the insurance company is hiring you guys to be able to figure out a way to maximize their profits.
Thank you for the question. So maybe I can help clarify with, like, let's use the State Employee Plan of Connecticut as an example. They're not required to use a PBM to offer prescription drug benefits. They could purchase from manufacturers themselves directly if they wanted to, but they found that that is not a cost-effective way to control costs and to make sure that patients are getting the care that they need. Instead, they do contract with a PBM who can do all those negotiations.
So you're contracting with insurance company is what I was saying, and you're agreeing with that.
Yes, I
Yeah.
guess so, yes.
Okay, so your contract is with insurance companies, and you're trying to work out a mechanism to be the middleman to maximize the profit for your client, that is the insurance company, and yourselves.
I would respectfully disagree. It's to offer the lowest cost, and I'll use the State Employee Plan again, to get them to the lowest cost for their prescription drug benefits.
So you're alleging that because of the PBMs, the cost to the consumer is the lowest.
That's what PBMs exist to do. They try to do that, yes.
Okay. And if you could help me, this is an insurance question, but why is PBM speaking on step therapy?
Step therapy is a product that PBMs use with, and I keep using the State Employee Plan.
Okay. So, and so in your contract with insurance company, you've used this technique to create, quote unquote, in your own words, another set of eyes, because the people who are providing the care do not have good enough eyes. Is that?
No, Mr. Chair, that's not what I'm implying. Step therapy, it would suggest that patients start on proven, safe, clinically effective drugs before they start on more expensive drugs. So
then the goal is to try but if the physician has made a decision that the certain drug is going to be the most effective one, so your set of eyes are going to look at, from a cost vision, what should be the first thing to be used and failed before they would go to the second.
There's always an exception process that doctors can work with through their patients.
And that's the point. What is the timeline for that?
What is the timeline for step therapy?
Yeah. So in other words, if the step therapy says that somebody who has stage 4 cancer, and then we made that from 60 days to 30 days in the state of Connecticut, the 30 days for a stage 4 is a lifetime, like I said earlier. So for PBMs to argue that the second set of eyes would take about 30, previously 60 days, but now 30 days, to make a decision, what the cancer specialist would say is the treatment of choice at that particular time is not good enough for the people that we represent. And anybody who's listening in the community who has cancer of any kind, they would agree to it. That for them to wait 30 days for this second set of eyes, and we'll talk about what those second set of eyes is in a second. And I think that's part of the problem we are having. I know what you're going to say, because that's your responsibility, but I'm just going to share the second set of eyes that you're talking about. They're not even the same eyes as the physician who's ordering the treatment. So it's somebody who has the MD at the end of it, or a DO at the end of it, or whatever the title would be, but they do not have the same level of care. So when an oncologist is a good example, when an oncologist is asking for something and somebody who's not even in that field is making a decision, you are basically giving a death sentence to the citizens of the state of Connecticut and our patients and the community and our constituents and the people we represent. So I have a serious problem with this whole plan, whole understanding, whole business plan. Then the power of the middlemen to try and control the treatment for the people who are their survival is dependent on this is not a sustainable model. And that's why we keep bringing these bills. We brought this in the Public Health Committee to be able to have this conversation, because we'll have this conversation perhaps in the Insurance Committee too. But For overwhelming majority of the people for the state of Connecticut, these processes aren't working.
Thank you for the feedback, Senator. I hear your frustrations and concerns, and I'd be happy to follow up with you on how those criterias are set for prior authorizations and step therapy, and how there's similar specialists who work on those things for oncology, for example. I'd be happy to follow up with that for you.
Okay, thank you so much. We would appreciate this. And this is part of the bill that we're trying to look at is, and when somebody says no to something, they should be of the same level of training, same level of background, same level of expertise. Otherwise, it's unfair. And then what we're seeing is many of the times when I'm trying to get something approved for a person who has a lung cancer or has a lung clot in their lungs, and I'm talking to a retired surgeon who's retired for 15, 20 years. And I asked them, I said, when was the last time you saw a patient? And they say, well, 20 years ago. And I said, okay, I'm polite to them. But you realize that it's not fair to the patients. And overwhelming majority of the time, it's approved. But the timeline and the office staff work that it requires is making it very difficult to be able to take care of the patients. If anybody in the community calls to get a primary care, an internal medicine primary care trained individual, they will be fortunate if they get somebody in 6 months' time. And the reason is majority of the people are spending about 15 to 40 hours a week in their offices trying to get prior authorization because they're listening to music, because we have technology in everything in the world except the prior authorization process, which is fascinating. Which is just fascinating that you have to pick up the phone and wait and wait and wait and listen to the music to talk to a person who will pass on to the second person. So the system is made to have people drop off, has been made for the patients not to get the treatment that they're supposed to make. It isn't working. It's not a good business model. It's not a good business to be in. And you may think that you're trying to reduce the cost of medication, but if the other end is a person suffering and dying, it's not a good business model. It's just how I feel. I wanted to just say this to you again. I try to say this almost every time, but maybe it's therapeutic for me to be able to say this, but it is what it is. Thank you so much.
Thank you.
Thank you, Senator Anwar. Representative Welander.
Thank you, Madam Chair. Thank you for being here tonight. I'm going to tailor my question a little bit differently, I think, because Senator Anwar just covered quite a bit of what I was also thinking. When we're talking about trying to save money as a whole, we also need to take into consideration what the parents are doing when they are not working because they're calling their pediatrician multiple times to try to get that authorization. And then the pediatrician is calling to try to get the authorization. And then the insurance company is throwing in the new requirement of a secondary authorization that has never been required for medication that this child has been on for years. This is a situation that a constituent brought to me just a few weeks ago. And if we are going to be, looking at how companies work, how healthcare works, I echo what Senator Anwar said, and I think that I want to know, would you be open to requiring the people who are doing these authorizations to have the same level of training in every scope of practice than the physician has who is requesting it?
Thank you for the question. So if you're referring to the clinical peer language in the bill, we don't take a position on that language of the bill.
Okay, but would you, if we're looking at taking away the prior authorization or the requesting for step therapy, would you be open to having trained physicians in the positions of saying, yes, you can have this, no, you can have that, or let's try, X, Y, and Z first?
I'm sorry, I'm having a hard time following your question.
If a physician is calling you and saying, we need prescription A, we need treatment A to make sure that this person is given the relief and the care that they need right away.
Okay.
And the insurance company is saying, no, we want you to try B, C, and D before you go to A because we think that B, C, and D are going to be more effective because they cost less. That doesn't seem to be providing healthcare. So I was wondering if should we be going to the people who oppose this legislation and ask, would you be open to having a physician or a surgeon or an oncologist of equal training on the other end, so that we can know that the people who are declining this type of treatment are on the same level as the physicians who are prescribing it?
Okay, thank you for clarifying the question. So those criteria are set up by specialists, for example. So an oncologist that is calling about a prior authorization, those criteria are set up by other oncologists as well. So oncologists are looking at this and making those suggestions for other drugs, for example.
Well, I appreciate your answer. Based on the feedback that I've gotten from multiple constituents, that doesn't seem to be the case everywhere. Thank you.
Thank you for the second time, Senator Gordon.
Real quick, one question, Madam Chair.
Thank you for your brevity.
We've been talking about oncologists, and I am an oncologist. And you talk about oncologists setting up guidelines. So why should it be that last week when I needed to treat someone with advanced stage non-small cell lung cancer, and it's well known that one of our gold standard drugs, which is FDA approved and supported by no lack of literature and guidelines, is carboplatin, pemetrexed, and pembrolizumab, that I couldn't get that approved. I had to go through a prior authorization. As my colleague, Senator Anwar, said, we listened to music, but it wasn't very pleasant music for me. And the only peer I could get was a rheumatologist. So my two questions to you, and they're in one, it's a compound question, and then I'll be done, is if you have oncologists coming up with guidelines, how come I, as an oncologist with more than 30 years of practice experience, couldn't get a straightforward FDA-approved regimen approved through the guidelines that were set up by other oncologists, evidently? And then why did I have to get a rheumatologist who readily admitted that she doesn't treat lung cancer, but if there were side effects of the treatment, she could take care of it? That's my question to you.
Yeah, thank you for the question, Senator. So the first one is, again, those criteria are set up. I can follow up with additional information for you, and I'd be happy to look into you. I don't have an answer at the tip of my fingers right now. As far as your second question, why another specialist answered the phone, I also will have to follow up with why that is happening as well.
Thank you, Senator Gordon. Seeing no further questions, thank you for being here with us tonight and for being persistent and spending the entire day with us as well.
Thank you.
Have a wonderful rest of your evening. Next, we have Martha Howard, followed by Stacy Taylor. And then finally, we will have Michael Arno.
Good evening, Representative McCarthy-Vahey, Senator Anwar, and other distinguished members of the Public Health Committee. My name is Martha Howard, MD, and I'm a board-certified ophthalmologist at Yale and the president of the Connecticut Society of Eye Physicians. I'm here representing over 800 physicians in the medical specialties of ophthalmology, otolaryngology, dermatology, and urology in opposition to Bill 177, an act authorizing naturopathic physicians to prescribe medication. Many of those who choose to go to a naturopath do so for alternative health treatments and not for the prescription of traditional pharmaceuticals. Yet the naturopaths have asked for prescriptive privileges 7 times since 2010. Each time, careful review has found that request not supported by training and scope. As recently as 2018, the legislature mandated that such requests be addressed through a scope of practice review process, which allows for a more deliberative review. The Department of Public Health concluded that naturopaths do not have the education, experience, or training to prescribe medications currently prescribed by highly trained physicians, APRNs, and PAs. This time, they're bypassing the scope of practice review process by directly introducing legislation to expand their scope of practice. They have not demonstrated any change in their education or experience during training to merit a change in the decision by the Department of Public Health. The scope of practice expansion should go through the mandated process to ensure the request is supported by training and experience. Naturopathic literature suggests modified dosing and scheduling of medication. Underdosing and overuse of antibiotics is a main contributor to antibiotic resistance in bacteria. We are concerned about the potential worsening of this trend if antibiotics are used without adequate training and experience. The process proposed by this bill is also very problematic. It states that the Department of Public Health will consult with the Board of Naturopathic Examiners to determine the necessary education and scope of prescription authority, including drawing up a formulary. The Board of Naturopathic Examiners has 3 members, 2 naturopaths and 1 public member. Neither ND has experience with prescription medications. This is simply too small, too inexperienced in prescription use, and too narrowly focused a group to determine the scope of prescriptive authority and a medication formulary that will affect the care of potentially every patient in the entire state of Connecticut. In contrast, the Board of Medical Examiners has 18 members, 11 physicians or osteopaths, 4 public members, and at least 1 allied health member. In the medical care team model, the reliance on expertise provides guardrails for the actions of the team. There are no guardrails on this bill. Connecticut enjoys one of the highest per capita physician and APRN to patient ratios in the country and is not lacking providers who can prescribe safely with medical training and education. The need in our small state simply does not exist. Thank you.
Thank you very much for your testimony. Seeing no comments or questions, I want to thank you for sticking with us. You're one of our last testifiers today, and we appreciate your input and perspective. Next, we have Stacy Taylor to be followed by Michael Arno. Ms. Taylor? Or Dr. Taylor, there you are.
One second there. Thank you. Good evening, Senator Anwar, Representative McCarthy-Vahey, and distinguished members of the Public Health Committee. Thank you for your curiosity and your stamina. My name is Dr. Stacy Taylor, and I'm the current president of the Connecticut State Medical Society. I am before you today to express our strong opposition to Senate Bill 177, even if it's limited to injectable vitamin B12. The proposed bill seeks to grant naturopaths the authority to prescribe, a responsibility that exceeds their education and training, posing risks to the health and safety of patients in Connecticut. Naturopathy is a natural modality in which neither surgical nor medical agents are used. A close review of naturopathic education and training reveals several shortcomings that should give this committee pause. Naturopathic school is not comparable to medical school. Naturopaths generally have only 1,200 patient care hours before being allowed to practice. The clinical component is limited in both time and scope, with clinical rotations typically occurring only in outpatient settings. The lack of exposure to diverse clinical scenarios poses significant concerns regarding the readiness of naturopaths to safely prescribe medications, as well as deal with adverse effects of those medications. By contrast, MDs and DOs have 12,000 to 16,000 patient care hours by the end of their clinical training in very diverse settings. As such, MDs and DOs can safely and effectively prescribe medications for their patients. One could consider B12 injections as natural. However, that request alone is evidence of the differences in experience and education. Evidence-based medicine has shown B12 injections to be completely unnecessary. A study in Switzerland in 2017 compared oral to injectable B12. In 2018, there was an analysis of multiple studies in the United States, Turkey, and India, also comparing oral with injectable B12. In a study in Spain in 2020, compared injectable B12 versus oral in those over 75. In all cases, oral B12 was as effective as injectable B12 at the same doses. Injectable B12 is painful for patients, can result in more adverse effects compared with oral B12, is unnecessary and out of date. Why would someone do that? As physicians, we strive to protect the health and well-being of Connecticut's patients. Naturopathic training simply does not include the education or clinical experience to allow naturopaths to safely prescribe medications, including B12. Please oppose Senate Bill 177 and protect the health and well-being of the citizens of Connecticut. Thank you very much.
Thank you so much for being here with us, Dr. Taylor. Seeing and hearing no questions, I will thank you for your work, for your care for the patients of Connecticut, and for your leadership among your peers.
Thank you so much.
Before we go to Dr. Arno, I just want to note that the YouTube will need to be restarted at 9. So Dr. Arno, I think what we're going to do is have you go ahead and testify, see where we stand afterwards, and then we may, depending, have to pause. So please welcome and please proceed.
Great. Thank you very much for sticking around. I want to thank Senator Anwar, Representative McCarthy-Vehi, and the other distinguished members of the Public Health Committee for allowing me to speak in opposition to HB 5196. I'm Mike Arano. I'm an orthopedic foot and ankle surgeon practicing in the Hartford area. I'm the current president of the American Orthopedic Foot and Ankle Society, a member of the recent DPH work group, and I've been working with podiatry on a local practice level and a national and state policy level for most of my 27 years in practice. There are some podiatrists in Connecticut, who can safely perform some of the procedures, the 3 procedures in this bill. However, there's no mechanism to distinguish them from the vast majority who I believe cannot perform these procedures safely. The report states the podiatry representative's position that podiatrists were required to complete a minimum number of ankle surgeries that is more than twice the minimum required of other surgical specialties who also licensed to perform ankle surgery. In my submitted testimony, I included abridged documents from the accreditation body for podiatric residencies, for orthopedic residencies, and for the American Board of Foot and Ankle Surgeons, which is the board certifying agency. The number of ankle surgeries is required for podiatrists to graduate from resident currently and become board certified in reconstructive rear foot ankle is 0. If you look at the documents, podiatrists are required to do 400 surgical cases during their 3-year residency. Orthopedic surgeons are required to do 1,000 to 3,000 documents. Podiatry has 2 pathways, as you heard before. First, board certification residency. There's the foot pathway, which is the bones of the forefoot and the soft tissues of the foot, and the reconstructive rear foot ankle pathway, or RRA, which consists of the bone of the midfoot, the bones of the hindfoot, and the bones of the ankle. They're all combined. If you look at the residency guidelines, if you're one of the programs that is not credentialed for the RA pathway, of which 10% are per the letter by Dr. Christina, they're required to do 0 RA cases. If you look at the ones that are on that pathway for accreditation, they're required to do 50 cases. But if you look at the cases that are listed, they're midfoot, hindfoot, or ankle cases. So you could just do fractures in the foot and soft tissues in the foot and meet the RRA ankle requirements. So the way our current bill is, if this thing were to pass, in order to do pylon fractures, ankle replacement, and treat tibial shaft infections by going through the knee and reaming them, inserting rods, all you have to do is become board qualified, which you can do without as soon as you graduate your residency, and that's pretty much it. If you look at the work group, we asked the podiatry group to present the case logs of the residents at the 3 podiatry residencies in Connecticut for the last 5 years. They gave us 2. They gave us one from St. Francis for the person who graduated in 2020 and one from Yale graduated in 2023. The St. Francis.
Dr. Arno, your time is up. Thank you.
Okay. Be happy to answer any questions.
Thank you. And we do have questions for you. So because we need to pause our YouTube recording and restart, I'm going to ask you if you wouldn't mind staying with us. And for all of you here on the meeting, we just need a few moments. So please hold.
Happy to do so.